58 MB na 100% that video must be there, sir. Others are only 950 KB, 13 GB.
Okay.
58 MB means
Warm welcome to all of you on the second day of the conference. Let us start this session. I invite the chairpersons, Dr. Jyotsna Kalra Madam, Dr. Devesh Kumar Sir, Dr. Arun Kumar, the first speaker of the day is Dr. Rajiv Paul. He will speak on antimicrobial resistance and new frontiers in the management of UTI. I invite Dr. Rajiv sir. And I request the chairpersons to please introduce the speaker.
Dr. Rajiv Paul is MBBS MD and he is HOD of Internal Medicine and Senior Consultant Critical Care. And he has a lot of achievement. Now I would like to invite Mr.
Good morning, everyone. It's too early in the morning to start off, but we are starting off. So, I'm from Dr. Rajiv from Apollo Hospital, Hyderabad, the Jubilee Hills, the head of Department of Mental Medicine. Basically, going to discuss about new drug plasmamycin, which is being in the market for quite some time, but in the last year or so, we have been using it more extensively because of the developing resistance that all of us know that. We are presently faced with this antimicrobial resistance problems, and India is one of the capitals of antimicrobial resistance, and there is huge number of resistance bugs that we see in the ICUs, especially the tertiary care ICUs. You would see every third patient having resistance to most of the cephalosporins that we use. BLA combinations also, the routine use of cephalosporin sulbactams also resistance, carbapenem resistance. All these are quite prevalent, and many of our patients do suffer from serious consequences of antimicrobial resistance, and it's projected that 2 million deaths to occur in the India due to resistance pattern by the year 2050. So it's a huge problem, all of us know, and the resistance patterns even encompasses the complicated urinary tract infections. Infections like pyelonephritis, post-stenting, post-urethroskopy, post any instrumentation of the urinary tract. Which infections develop, which is called complicated urinary tract infections. Their resistance patterns of resistant bugs have increasing, mainly because of rampant use of antibiotics at the community level, use of cephalosporins, quinolones, rampantly in the community level without proper monitoring and the proper dosing and duration. A lot of resistance to this newer agents like beta-lactam inhibitors, and even carbapenems have developed. So the rapid emergence of carbapenem resistant bacteria, which is becoming the problem now, even from the community also we are getting back bugs. I would not say community patient has been treated with some other antibiotic in the recent past and comes to the OPD, and we see the resistance of the E. coli resistant to most of the drugs, even carbapenem resistant or colistin sensitive. So that's not uncommon, and even outpatient department we see such patients, and we are in real problems how to treat these patients. And if we talk of the most common two bugs which affect the urinary tract infection, all of us know in the community as well as the hospital-acquired or complicated urinary tract infections, E. coli and Klebsiella. These are the two most common bugs that most of the times, most of your cultures, 8 or 9 of your cultures of urinary tract cultures will be either of these bugs. And if you see the resistance patterns of E. coli ranges in the range of 60%, nearly 2/3 of the bacteria are sensitive to carbapenems, 1/3 are not sensitive. And if you come to Klebsiella, 1/3 are sensitive to carbapenems, and on 2/3 are resistant to carbapenems. So you complicate UTI, you have a Klebsiella, you have a very high chance that 1 out of 3 will be sensitive only, 2 or 3 out of will be resistant to carbapenems. That is what we are talking of. And the major player in this is called the NDM gene, which is the New Delhi beta-lactamase gene, which promotes E. coli resistance. And for the Klebsiella, it is mostly the KPC. The Klebsiella also have the NDM genes. The KPC is an OXA48, we call it. They are the ones which is mainly in Klebsiella. And Klebsiella is around 60% to 70% resistance in carbapenems. That's what we get in complicated urinary tract infections. And on top of that, what we are getting is something called a penicillin binding protein 3. What I will discuss about this in the next little bit. It's a 4-amino acid insertion at PB3, which makes the even drugs. Now, when we talk of Klebsiella, or which we talk of drugs, bugs like E. coli, which are resistant to carbapenems, we have drugs now developed called aztreonam, which especially when we talk of NDM bugs. So aztreonam is a drug which works for carbapenem, especially the NDM type. However, when same E. coli, which has been found to be having an NDM type, also is now having something called a PBP3 or penicillin binding protein 3 alteration. Now, this is present. This makes the drug or the bug resistant to or less sensitive to drugs like aztreonam ivactam, which is becoming in the ICU a major drug in resistant drug bugs. And newer agents like ceftriaxone, cefepime, taniribactam, which is not available as in India, they also will not work in such conditions. Now, this is what basically is that we talk of New Delhi beta-lactam NDM type, which basically is nothing but a beta-lactamase which inhibits carbapenems. Now, when we talk of carbapenems are killed by this NDM bugs by production of this NDM enzymes, neutrally beta lactamase enzymes. In such case, this aztreonam is the drug which basically is not affected by this NDM or neutrally beta lactamase enzyme. So aztreonam can go and kill the bacteria or the E. coli or the Klebsiella, which is producing NDM. So aztreonam is the molecule we thought will be the wonder molecule. So all NDMs will be covered, and carbapenem resistance is not a worry for us at all. However, what we are seeing nowadays development of now this aztreonam works through a pathway called PBP3 or penicillin binding protein 3. The aztreonam has to attach to this penicillin binding protein 3 in the Klebsiella or the E. coli, and then only it can cause the alteration in the cell wall by preventing the peptidoglycan synthesis. Now the bacteria started developing PBP3 alterations. We call altered PBP3. So aztreonam, which is supposed to the wonder molecule to work for all NDMs, all carbapenemases. Now the same E. coli is harboring the major site or the attraction site or the site where it should attach. It is altered, called PBP3 alterations. So aztreonam cannot attach to the penicillin, to the bacteria, and obviously aztreonam starts to become resistant, or the MIC increases. This is how the combination of aztreonam and avibactam is supposed to work. Just to be in short, aztreonam is a parent molecule which is supposed to take care of NDM. However, aztreonam is lysed by other beta lactamases, like we call it the OXA48. So to prevent that, they cover it with avibactam. So a combination of aztreonam and avibactam is supposed to be the wonder molecule which is used in many ICUs in carbapenem resistant bacteria in septic shock. However, as we discussed, if the bacteria also has NDM along with PBP3 alteration, this combination fails to work, or the MIC goes up and failure of treatment may happen. And this is already shown in a publication in 2020 that a very high proportion of isolates of E. coli in one of the studies showed nearly 9 out of 10 of the bacteria having PBP3 with NDM both together coexisting. So incidence of PBP3, now that doesn't mean that every bacteria with the PBP3 is going to be resistant to. There are different types of PBP3, but the presence of PBP3 indicates that the possibility of aztreonam not working. So if there is aztreonam failure or aztreonam is not working properly, we start thinking this bug is probably also having an NDM along with the PBP3. Most bacteria may have PBP3, but there are some PBP3s which are effective or some PBP3s which are not important. At the present ones, luckily the non-important ones are more prevalent in the E. coli. The ones which confer resistance are less, but we don't know the future going forward a few years down the line. The ones which are more potent PBP3s will be more populating, and drugs like aztreonam will completely fail. So this is a combination of CRE or carbapenem resistant enterobacterials with PBP3 or the penicillin binding protein 3 among enterobacteria, which makes the bugs pretty resistant to most of the antibiotics that we're going to use, and only we're left with the detergent, which is called colistin. There's only drug which is going to work in a E. coli which is sensitive, resistant to, or which is having PBP3 and NDM. So only colistin is going to work. And we know the colistin prolonged use and nephrotoxicity and other problems can't be used on a community level, has to be in intensive care unit. So many complications of colistin that we have. So that brought us to this molecule called plasmomycin, which has been in circulation in US quite a long time, but then come to India in the recent last 2 years or so. Basically, it's again the action. It's like any other aminoglycoside acting through the ribosomal pathway. It doesn't need the PBP3, so obviously it works directly to the microsomal at the RNA pathway and causing protein prevention of protein production by binding to the ribosomal 30S subunit. So it doesn't require PBP3. It is not hydrolyzed by NDM. So this is how the plasmomycin comes in the picture. So when we have a combination of NDM as well as a combination of NDM with PBP3, the NDM does not hydrolyze plasmomycin, neither the PBP3 is required for plasmomycin to work. So plasmomycin could work in such conditions where a bacteria, E. coli, which is a highly resistant bacteria, which most of your culture report shows resistant to most drugs, only colistin sensitive. It's unique. It is nothing but it is derived from sisomycin, which is one of the original aminoglycoside. It is modified. The sisomycin, then tobramycin, amikacin, gentamicin. We all know about it. And the sisomycin was modified to create this plasmomycin, and the plasmomycin is created so that most of the aminoglycosides are neutralized by something called aminoglycoside modifying enzymes. So the newer aminoglycoside, the plasmomycin, is developed in the lab so that it is semi-synthetic derivative. So they have created some extra branches. You can see these branches so that this aminoglycoside is not hydrolyzed by aminoglycoside modifying enzymes. The aminoglycoside are destroyed by AMEs or aminoglycoside modifying enzymes. Plasmomycin escapes most of the aminoglycoside binding modifying enzymes because of its unique structure. That is the difference between plasmomycin, amikacin, or tobramycin and gentamicin. It's unique because it is not modified by AMEs. It can act on the most of the Enterobacter family, the E. coli, Klebsiella, Enterobacter, Proteus, some activity on Staphylococcus, but we don't use it for Staph aureus. So it can work on carbamidin-resistant Enterobacteria. It can even work on colistin-resistant Enterobacteria. And other aminoglycoside like amikacin doesn't work, plasmomycin still will work. The dose is very simple, 15 mg per kg once a day, and the route is intravenous, IV given over 30 minutes, and normal renal function is important. With a decreasing renal function, the dose obviously modifies. It is predominantly 80-90% excreted in the urine, so has the highest urinary tract concentration, especially in the urinary bladder and the kidneys, because it goes completely unchanged from the not metabolized, so high concentration, so it's very effective for UTIs. So coming to the in vitro evidence, which we have right now basically is, this was basically 488 clinical isolates from 9 studies across 19 countries from 2014 to 17. And most of the pathogen was Klebsiella pneumonia. And 76% of all the isolates were, so it was a Klebsiella pneumonia, which was Enterobacteria, and it was how plasmomycin will perform. All of these bacteria were resistant to carbapenems. So 488 clinical isolates which were carbapenem resistant, they tested plasmomycin and found nearly 77% isolates were susceptible to plasmomycin. And these are different types of carbapenems production. NDM, one is called VAME, the other type which makes meropenem resistant, IMP which makes imipenem resistant. There's different types of carbapenems that we cause. In India, for us, NDM is the most important one. In NDM cases, 66% of the bacteria or the E. coli which were carbapenem resistant because of NDM were sensitive to plasmomycin. That was a very heartening feature. And even in cases where it was evaluated comparator aminoglycoside against colistin-resistant Enterobacteria like MCR1 producing. MCR1 is the one which encodes for colistin resistance. Comparating between aminoglycosides, plasmomycin with other aminoglycosides showed that it worked much better than other aminoglycosides, and the plasmomycin inhibited nearly 90% of the carbapenem-resistant isolates. So in this study, nearly 90% carbapenem-resistant isolates were inhibited compared to the other drugs like amikacin, gentamicin, and tobramycin. And this is data from India in which data from two areas. One was the Christian Medical College Vellore from E. coli and Klebsiella from CMC Vellore blood culture samples, and E. coli and Klebsiella pneumonia from International Health Management Associates. Their samples were tested, all were carbapenem resistance, and also ESBLs. From ESBLs, plasmomycin worked very well. You can see the E. coli 95% sensitivity of ESBLs. All ESBLs, you can see all the ESBLs, it worked well. However, in the Indian data, plasmomycin did not do so well. The previous two data from the Western world, one of the US data mainly, plasmomycin in India did not do so well. 50% sensitivity was documented for Klebsiella, carbapenem-resistant Klebsiella, and 50% for carbapenem-resistant E. coli, and 15% around for Klebsiella. So plasmomycin in Indian context did not do as well for carbapenem, but still 50% of E. coli which were carbapenem-resistant, plasmomycin worked. So this is what we discussed. Presence of PEP3 with NDM production is where we discussed use of plasmomycin, and most of these cases only aminoglycoside which we are left with is plasmomycin. So if you can't use, don't want or can't use colistin in such cases, you are only left with the only other drug which is a plasmomycin, which can be even used on a OPD basis as an OPAT therapy. And this is how plasmomycin would work. Basically, it works through the ribosomal pathway and causing misreading and premature truncation of the chains, leading to protein synthesis. And however, it is again if resistance happens because of the 616 RMTS barrier, the methyl transferase barrier, which can confer resistance. Fortunately, at present, it is not very high. However, the mechanism of action completely evades the metallobital lactamases as well as the PP3. That makes it unique, and that's why many times it would work where all the other drugs will show resistance in your lab. So anywhere you talk of PEP3, meropenem, ceftazidime, cefiderocol, imipenem, aztreonabactam, this is going to be a possible antibiotic which will work. Clinical evidence is from two major trials, the phase 3 EPIC trial, in which 609 patients with complicated UTIs were, including pyelonephritis, compared plasmomycin with meropenem, 15-minute plasmomycin once daily versus meropenem 1 gram 8th hourly. Both the groups could switch over to levofloxacin after day 4. And it was to basically show non-inferiority, whether it's inferior or non-inferior to meropenem. It was found, yes, on day 5, their cure rates were more or less same. At end of IV infusion, which was mostly from day 4 to day 7, again the cure rates were similar both for meropenem and plasmomycin. What was more important is that at follow-up, after 15 days to 19 days, and at follow-up at 28 days, recurrence rates were higher with meropenem group. Both clinical recurrence as well as microbial recurrence was more in the meropenem group than the plasmomycin group. So both worked well for eradication of the infection. However, patients who took plasmomycin did have lesser relapse or recurrence of the infection compared to carbapenem. This was what the EPIC trial showed. So, and the incidence of aminoglycosides adverse effects were similar in both groups. Renal dysfunction was noted in 3%, 6%, but compared to the meropenem, there was no statistical significant difference. Creatinine rise was marginally higher, but not statistically significant. And the other, the phase 3, the CARE trial, which directly compared colistin with plasmomycin. And it was basically all-cause mortality data. Directly colistin, patients who were on colistin and who were on plasmomycin, the composite death was said, and it was shown that plasmomycin had a better survival rates as compared to colistin vis-a-vis, but it's very small data, and it was basically the data is from very less number of patients, who really cannot be used as a marker to promote or use this molecule. However, vis-a-vis colistin, it is not inferior, that much you can easily say, and toxicity-wise, it will obviously be not worse. So these two EPIC trials and CARE trials basically compared in complicated UTIs for the EPIC trial and the CARE trial, which I just said about the small number of patients, bloodstream infection, HAPs and VAPs. Because this BSI or the bloodstream infections and HAPs and VAPs, the CARE data was very small. That's why FDA did not give recommendation to use plasmomycin as a single drug in bloodstream infections. However, FDA has given, based on the EPIC trial, FDA has given plasmomycin can be used in complicated urinary tract infections in drug-resistant cases. And synergy also has been documented with carbapenems, with the fosfomycin. So whenever you combine meropenem with plasmomycin, you get a 3 times possible synergy, which gives you another leverage that you could use meropenem with plasmomycin in doubtful cases, where plasmomycin you're not very confident to use alone. You could have a better activity with carbapenems and fosfomycin. Fosfomycin is available in sachet, complicated urinary tract infections. It works for cystitis, but it does not work for pyelonephritis. So in such cases, complicated urinary tract infection with cystitis and pyelonephritis, a combination of plasmomycin with oral fosfomycin could be a very fantastic molecule when there is a resistant to meropenem or all the carbapenems. So in summary, once daily dosing makes it a very attractive option, and most of the recommendation is to give 5 to 7 days of plasmomycin, and even can be given at home because it's just because a 30-minute IV infusion. Activity against, as I told you, carbapenem, or most of the carbapenem resistant bacteria, there's a good chance it will work. So if you're getting a E. coli in your lab or in your OPD or in the inpatient or E. coli, which is resistant to most carbapenems, most of the labs nowadays still not reporting plasmomycin as in their culture reports. So if you don't have plasmomycin, you could ask your microbiologist to test for plasmomycin. If you don't have the testing or the disk testing, you could still use plasmomycin in such conditions because the chances that you will, an Indian scenario, 50% plus chances that it will be sensitive to plasmomycin. However, the same patient in the ICU in critical care, obviously plasmomycin is not the drug as a single agent. It could be a top-up drug, as I discussed with meropenem, plasmomycin, or plasmomycin with other drugs like Myvac or what we call a ceftriaxone ibactam. Not a single drug in ICU, single drug in the OPD, single drug in the inpatient, where you're talking of meropenem, imipenem, doripenem resistance. Their complicated urinary tract infection, this drug could be a wonder drug because it's once daily and very easy to use. The efficacy is going to be quite significantly positive towards. So this is the data from US 2016 to 2020, which compared to all the other aminoglycoside, plasmomycin was the highest efficacy as drug, and nearly 100% efficacy compared to Tobacco, which were less than 50% sensitivity. This is plasmomycin which has been used from US from 2015 onwards. So the data has been last 5 years data from 16 to 20. This shows In that time, plasmomycin was quite effective in most carbapenem producing bacteria or meropenem or imipenem resistant bacteria. So Indian scenario, first line therapy can be therapy for, it could be a first line therapy for complicated urinary tract infection, which is carbapenem resistant. And alternative to patient not responding to Septinia bacterium astronum, colistin sparing is important advantage. When you can't use a colistin in the inpatient, in the hospital, in the inpatient, you can use in the ICU, but not in the inpatient in the wards. There, this drug could be alternative to colistin in such cases. Patient should not be hemodynamic unstable. Obviously, in the wards, you won't have hemodynamic unstable patients. And recurrent UTI, it could be another wonder drug. In recurrent UTI, probably you're talking of E. coli, which are resistant to having a PVP3 plus minus NDM. In that case, it could be a very good drug. As a combination therapy, I told you, carbapenem with fosfomycin, very good drug for UTI. Even with meropenem, you could use in the inpatient. Thank you.
Thank you, sir. Thank you, sir. It's true. Antibiotics are among the greatest discoveries in medicine, but the power lies in responsible and rational use. Every prescription today influences the resistance patterns of tomorrow. Let us commit ourselves to evidence-based antimicrobial stewardship for safer patient care and healthier future. Any questions from the audience?
Thank you, Raksa, for very useful presentation. But I have a few questions. As you know, recurrent UTI is very common in females, and it is asymptomatic mostly, and resistance is also very common. Similarly, in the male, in case of prostatic infection, it is very common, and even it becomes lifelong phenomena. So, in this view, what is your this view regarding the adverse reaction? It's autotoxicity of this compound, plasmomycin.
So autotoxicity has not been documented as yet. It's more of a nephrotoxicity which has been documented with this plant. And presently, sir, this, like when you're talking of chronic suppressive therapy for a female or recurrent UTI or male prostatitis, we're talking of weeks of therapy. For prostatitis, we're talking 6 weeks to 3 months of therapy. This drug is not for that use.
What is its route of administration and dose?
Dose is IV. I told the route is 15 milligram per kg IV. This drug is presently not recommended for long-term use for asymptomatic UTI. Recurrent UTI, it could be starting, you could start with this drug. If somebody recurrent UTI or chronic prostatitis, you could start using the drug. However, after 5 to 7 days or maybe up to 10 days, you could use the drug and switch over to other drug like fosfomycin or nitrofurantoin as a suppressive therapy. Not recommended for long-term therapy.
What is its cost?
The cost-wise, it's present little costly. I think it is 6,000 to 7,000 per dose. But if you compare meropenem TID with this dose, a good quality meropenem 3 times a day with this drug, and for only 5 to 7 days therapy, it works out well for patients with carbapenem resistant. And obviously, in carbapenem resistant, meropenem is not going to be used. So we are specifically putting in a particular scenario where meropenem resistant, and you're looking at drugs like colistin, drug like Septinia ibactam, which are much costlier, much toxic. There, this drug, the cost efficacy is a once daily dose it is. Yes.
Okay, Raksa, what is your opinion, this experience with any bacteriophage therapy? It is that.
I have not used it, so really it's only in anecdotal, as I've read about it, bacteriophage therapy I have not used it in any of my patients, so really can't comment on that, sir. Thanks.
Thank you, sir.
Madam, one question. What is your personal experience with this drug?
Actually, I mean, I was supposed to show you, but I didn't have a time. That's why. Yesterday only got one patient from the community acquired bacteria, which is resistant to all. I mean, this patient of one of my old patients. When I saw the sensitivity, patient having symptomatic UTI. Resistance, it shows resistance to everything, sensitive only to or what is called intermediate to colistin. This is an OPD patient at home. She has been treated multiple times for UTI, fast, she's a diabetic, obese lady. So many times she has got antibiotics, carbapenems also many times in the hospital. Now she has got another UTI and this is now sensitive only to colistin. So I have no option, but this patient needs plasmomycin is the only drug which our lab still, our microbiology still doesn't give plasmomycin as a routine sensitivity, we would ask for it separately. But in such cases, this is if this drug, you test for it, and if it is sensitive, this is going to be the drug which will change the outcome. That's I can tell you, sir.
Sir, adding to what sir was asking, bacteriophages are being used in chronic rhinosinusitis, sir.
Yeah.
Because being an ENT surgeon, trials are going on. So bacteriophages are being used in, the trials are going on. Yes. Yes. Not recommended. Guidelines have not come, but trials are still going on. Thank you, sir.
Thank you very much. Thank you.
Thank you, sir. We move on to the next session, post-MI guidelines in lipidology. We invite Dr. K. Narsaraju, sir.
Sir, I request the chairpersons to please introduce the speakers.
Dr. Narasa Raju Kavalapati is Senior Consultant Cardiology and Director Interventional Cardiology Care Hospital, Banjara Hills, Hyderabad. He is involved as a principal investigator in 2 international multi-central clinical trials, and he has a passion for teaching, actively involved in teaching DNB cardiology fellows and budding interventional cardiologists. Thank you.
Good morning, respected chairpersons. Thank you for the introduction. Good morning, delegates. And at the outset, I would like to thank Dr. Sai for inviting me here and Novartis for facilitating my coming here. So, acute coronary syndrome is an important clinical syndrome where we call it as acute MI, where there is always a chance for recurrence. So today we are going to see what it means when we are managing an acute coronary syndrome and what are the implications for lipid management in acute coronary syndrome. So we all know acute coronary syndrome develops due to a rupture of a coronary plaque, and this plaque in the first place is formed because of the atherosclerosis. Atherosclerosis is multifactorial in origin, and lipids is one of the important factors, especially LDL cholesterol. So to give you some statistics, so 1 out of 10 will have a recurrence after an acute MI within the first 100 days, and more than 10% event rates in the first year, which includes death, MI, and recurrent ACS. So this is a highly vulnerable kind of a situation, or a very important clinical syndrome where once we identify an acute coronary syndrome, we have to be aggressive to prevent death and mortality, the morbidity and LV function deterioration. And one of the factors which contributes to further worsening of the atherosclerosis, as we know, is LDL cholesterol. And it is for the last more than 2 decades, we understand that once we reduce the LDL cholesterol, and once we reduce the LDL cholesterol very effectively, very early on after an acute coronary syndrome, we reduce the recurrence rates, we reduce the acute coronary syndrome recurrence, and also we prevent mortality. So we need to bear in mind that we have to be aggressive. Not only being aggressive, we have to be very quick in reducing the LDL cholesterol. So these are the 2 important principles we need to keep in mind. So we all talk about LDL cholesterol. Other than LDL cholesterol, there are important factors, especially the triglycerides. So now, thanks to the research being done now, 5 months ago, we have in an NEJM paper on olezarsen, which is a antisense oligonucleotide which addresses triglycerides. So we are moving ahead even in the field of other cholesterol components, including triglycerides, ApoB, in trying to reduce the risk. But importantly, at this juncture, what we have at hand is LDL cholesterol, and LDL cholesterol has to be reduced effectively and early on to prevent an acute event. So this brings us to the important aspect. How do we, when we see a patient with acute coronary syndrome, how do we risk stratify, and what are the targets that we have in mind to get the LDL cholesterol controlled? So the risk stratification allows us to effectively give a target for the LDL cholesterol and decide about the treatment strategies. So the in acute coronary syndrome, we classify basically these people into 2 categories. One is the very high risk cardiovascular risk, where a development of an acute coronary syndrome, or for that matter, any kind of atherosclerotic vascular event in any arterial territory, it qualifies as a very high risk situation where we need to be aggressive. And people who have recurrent events, means the event is occurring again and again, second event happening within the first 2 years of an acute event, either in the same territory, means the coronary, or elsewhere, like peripheral vascular disease or cerebrovascular disease, that qualifies as an extremely high risk group. So the Cardiological Society of India has given a very practical and clinically useful tool how to assess these risks. They categorize the risks into 4 categories. So I request you to read from the right to left: the low risk, high risk, and then very high risk, and extremely high risk. So those who develop acute coronary syndrome by definition are very high risk, and we will look at them. But low risk is where there are no risk factors, but there is a chance for atherosclerosis. So that is, in fact, we believe that Indian ethnicity itself is a risk. So that means for all, the LDL goal should be less than 100. So low risk category, the goal of LDL is less than 100, and for high risk, the goal is less than 70. For very high risk, the LDL goal is less than 55, and those who are extremely high risk, the LDL goal is less than 40. So we have to remember these 4 important figures. For everyone, the LDL goal is less than 100. For those who have a high risk, means a diabetic with any other additional risk factor, or CKD with EGFR between 30 to 59, or heterozygous familial hypercholesterolemia without any other risk factor, hypertension with any one more risk factor, hypertension with target organ damage. So all these categories, the LDL goal is less than 70. So coming to very high risk, so acute coronary syndromes fall in this category where they are labeled as very high risk and the goal is less than 55. So that means anybody develops an acute coronary syndrome, acute MI, we should endeavor to get the LDL less than 55, and the non-HDL goal is kept as less than 85. So what are these categories of very high risk? Those, as I enumerated, any kind of atherosclerotic CVD anywhere in any arterial territory, which shows by imaging either more than a 50% lesion in more than 2 major vessels in that particular territory, or simply diabetes which is long-standing, defined as more than 20 years. Again, diabetics, most of the diabetics, the goal is not achieved. In fact, it's very important to bear in mind that diabetics more than 20 years, they have to be treated as very high risk, especially if they have other risk factors and target organ damage. Of course, heterozygous familial hypercholesterolemia with atherosclerotic CVD, or CKD with EGFR less than 30. So we see among nephrologists, there is a tendency not to start statins because of 2 trials. One trial called 4D and the other trial called Aurora, which are atorvastatin and rosuvastatin trials. They feel that the statins don't have a role, but we disagree with that. Anybody whose EGFR is less than 30 is a very high risk for atherosclerotic events. In fact, they die not due to renal causes, they die due to acute coronary events. So we need to get their LDL less than 55. Extremely high risk, as I mentioned, those who have recurrent events. So in that categorization, we see that all patients who develop an acute coronary syndrome or an acute event should get their LDL less than 55 and less than 40 if they tend to have more events. So is it only the CSI, the Cardiological Society of India, which is talking like this? No. In fact, the European guidelines and the Lipid Association of India, which is an independent body, they also give similar guidelines where, as you can see, the ESC guidelines, the LDL reduction is required to be less than 55 after an acute coronary syndrome, and those who have recurrent events, the goal is given as less than 40. Similar guidelines are given even by the American guidelines. So we have to remember these 4 figures: less than 100 for all, less than 70 for those with high risk, Very high risk, meaning those who had an acute coronary syndrome less than 55, and those with recurrent events less than 40. So now we have seen that we have certain targets like this. Now, how do we achieve these targets? So the guidelines say like this: suppose somebody develops an acute coronary syndrome, so you have to first draw a non-fasting lipid profile sample within first 24 hours of admission, and immediately start them on 40 milligrams of rosuvastatin with ezetimibe, or a combination of ezetimibe 10 mg with atorvastatin 80 mg. This has to be started, and check for LDL at 4 weeks. So do a fasting lipid profile at 4 weeks and see whether the LDL is less than 55. If it is less than 55, continue with this, and to on follow-up, try to keep this goal of less than 55. And those who don't have a goal achieved at 4 weeks of less than 55, they have to be added on a bempedoic acid, and then recheck the lipids again at 8 weeks. That means 4 weeks from the first sample, second sample. And if LDL is less than 55, continue bempedoic acid and the intensive high intensity statin and ezetimibe, and continue them. In case at 8 weeks the LDL is more than 80, injectables have to be brought in. Here we have two options. One is the PCSK9 inhibitor and inclisiran, and ultimately we have to get the goal. So what is the post-discharge? How many patients do we have? I mean, do we have data to say how many are actually achieving? You see, globally or India, in Indian data, only about 40 to 50% only achieve the goals as we want them to be. So what is the role of the newer agents? The bempedoic acid, which I was mentioning, is an ACL inhibitor, which is the first step in cholesterol synthesis, where the citrate, which is the product of carbohydrate metabolism, is converted to acetyl-CoA. Acetyl-CoA is then acted upon by HMG-CoA reductase to develop cholesterol. This is the intrinsic cholesterol synthesis. So once we block the intrinsic cholesterol synthesis, the LDL receptor population on the hepatocytes increases. Once the LDL cholesterol receptor path, the receptor expression is increased on the hepatocytes, more and more LDL is extracted from the blood, and LDL cholesterol comes down. That's how bempedoic acid and the statins work. So we have novel agents, the PCSK9 inhibitor. PCSK9 is a protein which actually binds to LDL cholesterol and lyses the LDL cholesterol. So the more the PCSK9, the less is the LDL receptor population on the hepatocytes. So we want to block the PCSK9. So we have monoclonal antibody. The typical example is evolocumab or alirocumab. These are the drugs which act on the PCSK9 and prevent LDL receptor degradation. So now we have a newer drug called the inclisiran. Inclisiran is a novel agent which is a siRNA, which is small interfering RNA, which actually once injected, it gets internalized into the hepatocyte, binds to the RNA inhibitory complex, and then this complex risk and the inclisiran act on the mRNA and thereby degrading the production of PCSK9. So PCSK9 inhibitors like alirocumab and evolocumab are acting on the formed product, whereas inclisiran is acting on the genetic level to prevent the production of PCSK9 itself. So inclisiran, like evolocumab, had shown about 50% reduction from the baseline, and when it comes to administration, so we talk about long-term administration. As you can see in this slide, when we are giving oral medications like statin and bempedoic acid, the individual is exposed to 365 days of therapy. With monoclonal antibodies like evolocumab, it is 26 injections in a year. Whereas with the small interfering RNA, which is inclisiran, only 2 injections per year, which is attractive, which makes the compliance better. So we talked about triglycerides, and a lot of research is going on in the field of triglycerides, and that once it sees light, we have the typical Indian lipid problem of high triglycerides, low HDL will be addressed. So apart from all this, post-acute coronary syndrome, we should not lose sight of the lifestyle and the diet, exercise, which help in raising the HDL and also reducing the LDL cholesterol. So to summarize, the key points that I wanted to emphasize is in patients who develop acute coronary syndromes, they have to be treated as very high risk and extremely high risk if they are having acute recurrent events. And we should endeavor to get LDL less than 55 or less than 40. And most of the times, this level of LDL reduction is achieved by injectables where the compliance is better and the efficacy of LDL reduction is also superior compared to statins, ezetimibe, and bempedoic acid. So with that, I stop here and I thank you for your attention.
Thank you, sir. In modern day cardiology, lipid is not only in prevention but also in the management. Over to chairpersons.
Thank you, Dr. Saab, for your very nice presentation. As you know, due to this faulty diet, lifestyle, and other risk factors, especially in this software company workers, it is in the younger age group, the people are having the risk of this hyperlipidemia. So, and this new drug, it had to be given only twice in a year. So, what is your opinion regarding its safety in pregnancy?
So yeah, it's
in
a
such cases.
good question. In fact, lipid management in pregnancy is a very controversial topic. So to suppose somebody is already on an anti-lipid lowering therapy and becomes pregnant, the guidelines say we have to continue, irrespective of whether it is a statin or any other drug. So for the primary indication for starting the lipid lowering therapy has to be borne in mind. Suppose the same individual had an acute coronary syndrome, is on aggressive statins, it has to be continued. If it is just for primary prevention, now the problem comes here whether we should continue or not. Now this was a controversial topic for a long time, but recently the recent data says even in pregnant people we have to continue the lipid lowering therapy like what we are treating with non-pregnant people, because pregnancy itself can sometimes raise the issues of increasing the development of acute coronary syndrome and etc. So it has to be continued.
You administered the first dose of inclisiran.
Yeah.
And after the 6 months, you have to introduce the second dose.
Yes.
If she gets pregnant within this period, what will be your criteria for this second dose or further continuing the drug therapy?
Yes, it has to be continued.
It has to be continued.
Yeah. See, inclisiran is one drug where it is acting on the hepatocyte within the cellular level. It is acting at the mRNA level. So this is a drug or an injectable which can be used safely even in renal failure, safely in hepatic failure, because this is acted upon in the hepatocyte by nucleases. It's got nothing to do with the renal function, liver function. So all these things are pregnancy. There is no harm in continuing. Of course, having said that, we don't have data. So what the guidelines say is suppose there is renal impairment until the EGFR less than 55, less than 15. If the EGFR is less than 15, we don't have data. But until the EGFR being 15, you can give inclisiran. And even in hepatic failure, child pug class C, we don't have data, but class A and class B, you can safely give inclisiran.
And what is the cost of this inclisiran?
Yeah, this is, it used to be close to 1 lakh. It is still 1 lakh, close to 1 lakh. One injection costs close to 1 lakh, 1 lakh rupees.
So what will you recommend this selection of patient? Suppose in the railway we can do, but in this in the general population,
people are not able to get it. And so, in your view, matlab which kind of number of one or two situations?
So, as I showed, the first line would be high intensity statin with ezetimibe and bempedoic acid. Suppose the patient is not able to afford, this can be tried. This leads to about a meaningful reduction of LDL close to about 30%. This strategy of high intensity statin with ezetimibe and with bempedoic acid. But sometimes, especially when there is an acute coronary syndrome, we would like to have the LDL reduction to the tune of more than 50%. So that is where the role of injectables comes into play. And where we have to give this to get, see, acute coronary syndrome is one, life threatening. Two, once the patient develops an acute coronary syndrome in any major corporate hospital, the bill would cost more than 3 lakhs to 4 lakhs. So annually the patient is spending 2 lakhs and preventing an expenditure of 4 lakhs and also preventing a mortality. That's how we should look at it. So the cost effectiveness in an Indian society with the kind of economic issues we have, of course we won't be able to justify, but somebody who can afford it and somebody has a risk of developing acute coronary syndrome, I think this is a wonderful drug to prevent recurrent events.
Thank you.
You mentioned diabetes as high risk of more than 20 years. This thing you mentioned it in the high risk.
Yes.
But this is post ACS, as you have discussed. But many diabetics also have silent attacks. So, what do you recommend for people having diabetes? Do you recommend imaging studies to rule out the level of atherosclerosis in them?
Yes. So this less than the diabetes more than 20 years is not in acute coronary syndrome. It is in general. Somebody who has diabetes more than 20 years is at a risk, high risk. And we actually, when it comes to diabetics, how do we screen for CAD and how do we go about in practice? So one thing that we employ nowadays is calcium score. So somebody who has a calcium score more than 100 needs to be definitely on statin, and this statin they have to be treated as the LDL goal should be less than 55, and suppose the same individual has more than 300 to 1000, we have to do some objective test to look for ischemia, and if there is ischemia they have to go for invasive testing. And more than 1000, since you talked about silent ischemia, the coronary calcium score more than 1000, they have to be upfront going for a coronary angiogram, because an acute coronary event is life threatening, and once life lost, you can't do anything.
Thank you.
Actually, one patient gets acute coronary syndrome, but he told we send speed profile. But if it is higher side, for example, LDL is 170, 180, and we know with the high statin, bumpedic acid and ezetimibe, we are going to decrease to 50%. That means we are not targeting 55. So before, even the second day, following PTCA, we advise evolocumab or increasable. I mean to say, if your index LDL level is higher side, and with the high statin bumpedic, you are not going to target, then you should give. Don't wait for one month or 4 weeks, because first 4 weeks is high chance of getting recur MI or acute stent thrombosis. So target should be increase, hit hard and hit fast.
Yes, it's a very good point. We in practice do like that. What I was mentioning was the CSA guidelines. So CSA has given those guidelines, but in practice, whatever we are doing is off label, you can say, because none of this is all more of our own feeling that they will have an acute event. So the best strategy in that scenario, what we do normally is, somebody develops an acute coronary syndrome, we start them first on evolocumab, not on inclisiran. The reason is, once you give evolocumab, because you see the mechanism of action of evolocumab, it is acting on the formed product. So it is immediately acting on the PCSK9 formed and preventing LDL receptor degradation. And studies have shown that once after an acute administration of evolocumab, you have within a week the LDL cholesterol levels drop. Whereas with inclisiran, this takes about 28 days. That's what the the literature on inclisiran says also. So what normally we are doing, we give in a scenario what you mentioned, though of course this is off label. This is not, no guideline has endorsed this practice. So we give evolocumab, wait for a week, and then administer inclisiran and continue the patient on inclisiran. Inclisiran has to be given one dose and then 90 days, then 6 monthly once after that. Every year, 6 monthly, one dose. That's a good point you raised. And this is what we do normally in practice. Which statin? So the most of the evidence is for atorvastatin. Most of the ACS, post-ACS statin, the most evidence-based statin is atorvastatin. For rosuvastatin, we have data, but not so robust as atorvastatin, because atorvastatin is the first molecule to come into market, and it generated a lot of literature with the high-intensity statin at 80 milligrams of atorvastatin. And so the rosuvastatin at the time, the rosuvastatin is not studied so much. In fact, if you look at the overall evidence for both the statins, atorvastatin has a lot of data for secondary prevention, and rosuvastatin has a lot of data for primary prevention. But though their head-to-head trial, Saturn trial, they have shown that both are equally efficacious, more or less. So I don't see any difference between atorvastatin 80 milligrams and rosuvastatin 40 milligrams in practice, but this is what the evidence is. So if I have to answer in terms of evidence-based statin, it is atorvastatin.
So please use mic.
I think there is an extreme fear amongst the doctors maximally tolerated dose of statin. So using statin to atorvastatin 80 mg or rosuvastatin to 40 mg, I think a lot of people, they do not go to the maximally tolerated doses. I think if we go to the maximally tolerated dose plus ezetimibe plus bempedoic acid, I think we can control LDL almost in 90% of the people. Maybe about 5 to 10% of the people may require either PCSK9 inhibitor or the inclisiran. I think the rest of the people can be managed with these three drugs. That's what I feel.
Yeah, but the reality is the compliance issues. So literature has shown that only 40 to 60%, 40 to 50% of the people are compliant with this kind of therapy. That is the reality in practice. That's where the role for injectables comes into.
It is a very interesting topic, and I think a lot of questions will be coming. So for this purpose, we can continue.
Yes.
Sir,
later on.
one last point. Actually, I'm from Perambur and I'm a nephrologist. So what you said about high dose statins and nephrology phobia is a little bit true, because we are worried about the statin-induced myoglobinuria and AKI. About 6 months back, we had an elderly diabetic with MI, with a stent 3 thrombosis, going for another stent, and then he presented 6 weeks later with acute kidney injury, and he had deranged LFT and an incidental gallstone. So it was for a long time thought that it was related to the cholangitis, but actually it turned out to be high-dose statin-induced myoglobinuria with AKI. Once we stopped the statins, his creatinine came down to a baseline of 2. His LDL was around 110, and twice he had an acute coronary disease. So in such case, we had to use inclisiran, and ICF CMO, the patient belonged to ICF, and sir procured inclisiran. Due to the cost, we don't routinely use. We use when there is a target LDL is not achieved, and some rare situations where the patient develops statin-induced AKI, where you fear to use the statin.
Yes, ma'am. Good point. Actually, we see in my last 30 years of practice, I have seen 2 cases of statin-induced rhabdomyolysis. But that's a very, potentially life-threatening situation, very scary situation.
Okay,
Thank you for your attention and very sound interaction. I also feel I learned a lot. after interacting with you all. Thank you.
Thank you, sir. Sir, I request you to stay back, sir. Please stay back. We'll have a felicitation of the speakers. I request the first speaker, Dr. Rajiv Paul, sir, to please come over the stage. I request the chairpersons to please felicitate our first speaker, Dr. Rajiv Paul. One announcement, please. All delegates are requested to go to the registration counter and please register yourself by geotagging the system. Otherwise, you will not be getting the credit hours. And the registration counter will be closed before lunch.
Thank you, sir. Before we head on to the next session, when science, lifestyle, and patient commitments come together, that is diabetes treatment. We call upon Dr. P. Satyababu, sir, CMO ICF, to speak on new frontiers in diabetic management. We welcome you, sir.
Good morning to you all. It's a pleasure to introduce my colleague, Dr. Satya Babu. He's presently working as PCMO at ICF. Previously, he was CST at Northwestern Railway Headquarters. He's president coincidentally, he's a physician as well as a radiologist. He is president National Paper on Indian Railway Conference in 2019 and Radiology and Occupational Health Conference. He belongs to IRHS 91 batch. Thank you,
Respected PCMDs, respected honorable chairpersons on the dais, senior colleagues, former and present functionaries of APRCON, SB Gupta sir, friends, ladies and gentlemen. I wish to first thank the Lord God Almighty for bringing us together in yet another APRCON, now rechristened as APRCON 2026, and also for gracefully giving me an opportunity to be on stage here. I thank PCMD South Central Railway Madam, Dr. Nirmala Madam, Dr. Sai, and the organizing team for giving me this chance. Before starting the lecture, I just want to tell one thing. We know that aging-related health complications or risks, we know many of them. Diabetes, hypertension, coronary artery disease, stroke, degenerative disease. But there is one risk which is not mentioned in the textbooks. The risk of being pulled up on stage and given a mic to address an august gathering such as this in a national level conference with no place to hide. So I start with a prayer for the God Almighty to give me the grace, wisdom, and word to do some justice to the topic I am talking. We all know that the first description of diabetes as to great emptying of urine happened almost 3.5 millennium back. And we know the burden of diabetes in India, so I don't have to go through the numbers or the complications or the life-threatening disorders it can cause. What is a new frontier? A new frontier refers to a new uncharted area of opportunity, exploration, or development. Signifies moving beyond existing limits in the field or known terrain of knowledge. A popular speech by US President John Kennedy in 1962 when he started the US space program, he said, going beyond known frontiers. Having drawn such high parallels, I feel a little apprehensive whether I will be able to do justice to their speech here. These will be the broad topics in which I will be talking. The interplay of diabetes and obesity and all the burden we know. In the clinical understanding, what is new? The APA Medicine Update 2026 mentions diabetic neumopathy as a new target organ of chronic hyperglycemic status. Diabetes-induced pulmonary fibrosis is the most well-characterized subtype of diabetic neumopathy. The pathophysiology is the same as it is elsewhere. Thickening of the basement membrane of the pulmonary capillaries, resulting in impaired diffusion of gases and reduced diffusing capacity, causing subclinical hypoxia. So in railways, will we be doing spirometry apart from welders, painters, and grid blasters, even to diabetic patients in the future? How do we diagnose it? Long-standing diabetes, particularly with poor glycemic control, in the background of albuminuria and retinopathy, exertional breathlessness, which is not explained by cardiac reason, and a 6-minute walk distance, which is reduced to less than 400 meters. With the restrictive pattern spirometry, you should suspect the diagnosis of diabetic neumopathy. I wish to bring to your attention this article on Elsevier in recent advancements on novel approaches of insulin delivery. Insulin, we know, was discovered in 1921 by Besson Banting. The injection came the very next year, 1922. For almost past so many decades, oral administration being the most logical and convenient, research has gone for decades trying to find out a way to present an oral insulin presentation, which would be a major breakthrough, you will agree. Nanoparticles, microparticles, hydrogels, tablets, capsules, ionic liquids, GAT patches, whatnot. What prevents the administration of insulin through the oral route? We have enzyme inhibitors, cathepsin, pepsin, which can aggressively and instantaneously destroy peptide hormones, including insulin, and we have a barrier the barrier of columnar epithelium with tight junctions, which can prevent permeation. So physical insertion through microneedles was a way thought out of this problem. I just want to highlight, because of lack of time, I will be going through fast. This is an Eligen is a technology patented by Hemisphere Technologies of USA, where they have produced a carrier molecule combined with insulin to give it orally. And the action started within 30 minutes and lasted for 1 hour. Still not in the market yet. There is another proprietary molecule, pegylated recombinant human insulin, called IN105. Biomedical research, you need patience, perseverance, and billions of dollars. You might hit a jackpot, or you might end up in bankruptcy. The corporation, Naubex Corporation, tried to develop it and ended up in bankruptcy, unfortunately, but was taken over by APRCON. Still, we have not seen the light. This molecule has not seen the light of day. So, intestinal insulin delivery, overcoming the oral route, can we try and do it? Research has been on this. I bring your attention to this luminal unfolding microneedle injector. Maybe you can watch, this thing. This consists of an orally swallowable oral capsule with a small spring with 3 arms with microneedle patches impregnated with insulin particles. On entering into the small intestine with a change of pH, the arms are released. The microneedle array gets inserted into the intestinal mucosa, and within 1 hour, the insulin is injected, the needle gets dissolved. It's all self-dissolvable needles, and even the arms get self-dissolved, and only the empty cartridge is excreted through the system. This has been reported in journal Nature. When the creation goes out of ideas, it's always advisable to look into the supreme creator's intelligent design in the different beings. This is a leopard tortoise, a very popular pet in the Western countries. If you are a tortoise, the most dangerous complication to your life can be getting flipped over on your back. You don't have the cover of your shell, you are vulnerable to predators, you can lose your life, if not by predators, by exhaustion and dehydration and starvation. What is special about this geometry of this design? It has got a high curvature on the top and the flat surface on the below with the low self-gravity, so low center of gravity that even if it gets flipped over, it can struggle, wriggle, and come back to its original position and save its life. Based on this, inspired by this design, they started this novel way of industrial delivery of insulin called SOMA. It is self-orienting miniature needle actuator. This is a small video clip I will try to play. Yes, it can self-orient. It can come to the base level. It consists of a small needle with a micro pump with insulin particles inside. In the gastric mucosa, when it reaches the stomach, based on the gravity, it locates to the mucosa, and then within a second or two, it can inject through the needle. The needle penetrates only 1 to 2 millimeter. Gastric peristalsis will not affect it, and after that, it is passed away through the system. It will not penetrate up to the muscularis mucosa. So this has been patented, helped in animal studies. It will soon expected in human studies. If anybody worries of the size of the capsule, it is around 9 to 15 millimeter, still swallowable. Is it really worth it? Should we think about administering insulin through all these routes? When they compared this insulin uptake through SOMA technology with subcutaneous insulin, it was slightly less. However, the blood glucose lowering effect was higher than subcutaneous injection. So this is a promising strategy. Now we come to the next emerging frontier on insulin therapy. From daily injections to, we are moving on to once weekly insulin. It is an important near future development for reasons which I do not have to mention. Insulin has been combined with albumin to form insulin-albumin complexes, and it's called insulin icodec. And when injected subcutaneously, it can stay in the circulation and with a half-life of around 196 hours or 7 days, and it can be given as a weekly injection. Here we compare weekly injection here of icodec along with daily glargine, 300 units per ml glargine on daily basis on subcutaneous basis. By the end of second week, you see that this insulin icodec reaches therapeutic efficacy of glargine, and by the end of fourth week, it gives the same glucose lowering effect. It is expected to be available in the market in the next year or so. The another long-acting weekly insulin is FC-Thora. Here, they have combined insulin with the FC portion of immunoglobulin IgG, and with the recycling phenomenon of IgG in our physiology, this gets recycled again and again, and it can work for around 1 week. Just imagine what weekly insulin can do to all the diabetic patients and the diabetic persons here in the stadium also. Here, when you compare all the insulins here, only glargine 300 and degludec cross 24 hours or get into day 2. Whereas when you see icodec, it passes on up to the activities last for around 7 days. So is FC-Thora with a smaller peak. What next? Still the future is more exciting. They have started trials using weekly once insulin with weekly once GLP-1 analogs also. So we are looking into far brighter days. Then comes smart engineering. We know that when insulin is given, what action it has, and we also know what glucagon has when given in separate infusions or injections. What will happen if insulin and glucagon are infused together or injected together? If you remember the previous artificial insulin delivery systems, insulin pumps had a glucagon emergency button insert in this thing. So if a person goes into hyperglycemia, you can just inject glucagon without checking blood sugar also. They have created a molecule, fusion protein, due to biomedical engineering, where there is a natural ultra-stable single-chain insulin has been combined with the glucagon molecule. This fusion protein has been injected into the body. What happens? In the hepatic physiology, there is a metabolic switch. It switches on and off depending upon the amount of glucose. If the glucose is high, it will give preferential activity to the insulin, and if the glucose is low, it will give preferential activity to the glucagon. So a single molecule managing hyperglycemia and hypoglycemia. Quite fascinating, but it is already, the biotechnology is of striking simplicity, and one more advantage is ultra stable, does not require cold storage. It is given by subcutaneous injection. Can this help for our loco pilots in railways? I come to another exciting molecule, probably the highlight of this speech maybe. And forgive me producing the hype, probably if it comes to the market, maybe by another 2-3 years, they discover the people behind this might end up getting a Nobel Prize. A single molecule has been designed, insulin, with 2 arms. And they have found out that if the 2 arms are open and active in the presence of glucose, it will bring down glucose. But if the 2 arms are tied together, it cannot bind to the insulin receptor and it cannot produce glucose. So in this smart molecule, why do we say smart? Because we expect this molecule to sense the glucose itself without any other sensors, automatically sense and switch off itself. So in the one arm, they have attached one glucose-like molecule called glucoside, and the other arm a synthetic lectin which has high affinity towards glucose. So in the presence of glucose will come and get attached. Please see the marker there. The marker is not coming. The synthetic lectin on the other side, the glucose will come and get attached here, and this will remain active and reduce glucose. On the other hand, if glucose goes down, this glucoside, because of its lower affinity, will go and get attached to this arm. This glucose will go and get attached to the arm. The marker is not working. I mean, I am not able to show this thing. It will attach to that arm and it will switch off the insulin molecule. The insulin, when given, will act when the glucose is high. When glucose goes down, it will automatically switch off, preventing hypoglycemia. I have made a small clip. This is the glucose molecules coming through and attaching to the synthetic portion, the round, bigger portion, blob-like portion. When glucose attaches to itself, it will act and try to reduce, and will reduce glucose as any other insulin would do. But when there is no glucose, this glucoside goes and attaches that and binds the arms. And when the arms are tied, it cannot act. And it will not cause hypoglycemia. And again, when glucose comes, the round molecules come, they get attached to that synthetic lectin because of higher affinity, and again insulin starts acting. Such a wonderful molecule. It has passed through animal trials and expected within a year or 2. It is called NNC2215. So in animal studies, of course, when compared to basal insulin, in this portion, basal insulin produced hypoglycemia coming down below the normal range also. But whereas on the other side, on the right side, when blood glucose levels came down to around 4.5 millimoles or 81 milligram DL, it stopped its activity and there was no hypoglycemia. This is because when the glucose concentration is low, near the 0, the binding affinity of this NNC to 2215, I'm sorry for the typing mistake, that remains active. Whereas when it comes down, it remains bound and becomes inactive, whereas in higher levels, it becomes active. A smart insulin which senses glucose on its own and switches off itself. No need for your CGM and other sensors also. Probably no need for a doctor also. Well, will this be a solution for our Indian railway healthcare system? We have a lot of loco pilots who require, after a period of time, insulin for their management, for proper management of hyperglycemia. But the risk of hyperglycemia, with all its effects, resulting in an accident, harming thousands of lives, is always on our mind. we are not able to deliver, give them, prescribe them. But many of them are taking without our knowledge. Maybe with this molecule and other molecules which are not supposed to produce hypoglycemia, apart from the approved metformin 2 gram, we will be having an armamentarium soon, approved by Railway Board also, which will help us to take care of our loco pilots and running staff. So this is only this thing, still it's not approved, please don't take it for a message. Still, as long as the oral licenses are still not available, we are now having the only non-invasive insulin to be delivered in the form of inhalation called technosphere insulin. It was previously approved in 2014 in USA, now approved in India. The insulin, rapid-acting insulin, has been combined with another carrier molecule, ephemeral dikeptopiperazine, and with that it's put in a small, compact, sleek inhaler, which can be taken by oral inhalation. There are pre-filled single-use cartridges of 4, 8, and 12 units. Once the molecule reaches the lung surface, it dissolves and insulin is released into the system. The action is almost immediate. When you see on the column, circled column, the time to measurable effect starts in 12 minutes, peak effect within 45 minutes, and total time around 180 minutes, which closely resembles the endogenous insulin in healthy humans in the previous column. Here also in the graph you can see the rapid onset of action. Clinical efficacy in type 2 diabetic patients controlled on oral drugs, it has produced a HbA1 reduction of 0.82 when compared to other drugs. And in comparison with aspart insulin, it has produced a reduction of 0.21 in baseline HbA1c. Hypoglycemic episodes were comparably lesser in compared to aspart, and effect on body weight, it reduced weight by 0.4 kg. Cough, of course, will be the major symptom, which can go down in another 3 to 4 weeks. Other than that, throat pain, headache, diarrhea, fatigue, and nausea are the other side effects. What about lung safety with the technosphere insulin? A 2-year study says there's an early and sustained mild reduction in FEV1, but which reverses after stopping the drug. And this remained non-progressive for a period of 2 years of study. Contraindication, any chronic lung disease such as asthma or COPD is contraindicated, and hypersensitivity to regular human insulin is also a contraindication. You should make sure that before starting that the FEV1 should be not less than 70% of predicted value. There is another inhaled insulin, liquid insulin called Solo-2. The patented product is DANCE 501. It is still not touched the market. Well, we come to the newer advances in investigation. We all know that here nowadays, even 2-3 years later, we will not have articles comparing the efficacy of a drug in terms of HbA1c reduction. We know now even our patients are talking about time in range, time in hypoglycemia, average and that ambulatory blood profile, sugar, glucose profile, everything. I'm not talking about continuous glucose monitoring because there is another speaker behind me who is going to talk about that. So what is new in continuous glucose monitoring alone I will talk. Now continuous ketone monitoring devices are available in the market. It detects beta hydroxybutyrate in intestinal fluid, can be integrated with CGM, and cortisol sensors are also now in the market. Nobody wants to be pricked. The CGM only has a small micro needle which goes only 5 mm inside the skin, but still nobody wants to be pricked. Is there a really non-invasive way of sensing blood glucose? Yes. Raman spectroscopy, near-infrared spectroscopy are available. Also, wearable optical AI-driven sensors which could eliminate finger pricks are available. It started with Massachusetts Institute of Technology, starting the first prototype. In 2009, when I was in Southern Railway Headquarters Hospital, we tested blood urea samples along with the MSc biochemistry student in IIT Chennai for estimating urea through spectrometric methods. The blood sample was sent, not the patient, sent. They could find good correlation, but still not clinical accuracy because of lot of noise. This noise reduction happens with the introduction of AI, and now this is a very important tool. And this is another non-invasive glucose monitoring where the light, you just have to put the finger at the corner edge. It reads like a pulse oximeter, reads through the optical signals sent back from the glucose in the blood. The near infrared signals are detected by AI and blood glucose levels are got. The accuracy matches normal CGM. Wearables are small electronic gadgets which can be worn, spotted on ourself to sense all health-related parameters. You name them, they can sense. Glucose also can be sensed nowadays. The armband, all these things you know of. And you also see a t-shirt here, I will come to that. Okay, I don't want to wear any all wearables can transmit the data to net or remotely connected machines or a system and can be seen by doctors or healthcare professionals, and a patient in a remote village can be monitored effectively, and even an ambulance alert system can also be altered. So if there is AA-based prediction says there is a chance of hypoglycemia at 3 o'clock in the night, the ambulance can reach the village at 2:30 and take care of the patient, bring the patient to a tertiary care hospital. The wearable market is growing at a very high rate. Okay, I don't want to wear anything, still I want to have my our glucose sensor sensed on a continuous basis. Well, you have advanced smart auto technology now. Ink that thinks, senses and transmits data from your hand. It is only the ink made of graphene and nanowires, which is the superficial layers, which will last for 6 weeks to 6 months. It will transmit data, will do a wonderful job, even better than CGM. It analyzes interstitial fluid analysis. I talked about in the variables, I was talking about the t-shirt there. Now we have a glucose sensing fabric. A fabric with threads with nanoparticles which can sense glucose in the sweat or saliva or tears and can give a wireless readout to other devices. It has been patented by Hong Kong Polytechnic University called PolyU. Smart insulin pens, it can be connected to CGM, personal parameters, and dose injected, it can give you warnings and reminders, and dose adjustment advice it can give. Artificial insulin delivery systems has got a battery-powered pump and an insulin cartridge with a computerized chip with a plastic catheter delivering the insulin into the subcutaneous plane, and it's connected to CGM and internet and also to all other AA devices. This was a mammoth camera built in 1900 to get high resolution photography. I am talking about this because this can be useful in Indian Railway health system. This is a handheld retinal imaging device with a smartphone. This doesn't require an ophthalmologist, nor a trained person. If you know how to take a selfie, that will do. A technician can be trained, and there is no need for any mid-Adriatic also. It captures exceptional images in under a minute, and there's no wait, 30 seconds maybe. The average period is less than 1 minute. And with this, when it is combined with smartphone-based camera, a technician go to the patient's home or in a factory to a production unit, everywhere employees can be screened at their work spot with such high potential. I direct your attention to this article regarding diabetic retinopathy, but when compared this AA even excelled retinal specialists and ophthalmologists in diagnosing early DR and diabetic retinopathy and staging. Can this fundal imaging with the AA imaging can predict other diabetes related complications? We know that kidney disease is a diabetic complication, and we usually follow eGFR prediction and urine albumin creatinine ratio for following up these patients. Without doing any of this, with the retinal fundus image, it is possible to predict CKD risk even before the onset or changes in the renal parameters. This RETI-CKD score versus eGFR, the RETI-CKD blue column, it was found to be more sensitive than the GCD. Similarly, because these detect changes in the microcapillaries network, which is quite visible through that, and AA predicts better because it can detect subtle changes which our human eye misses out. Even depth perception, color perception, and the difference in intensity, near infrared signals, all this it can predict. It also, when compared to coronary artery disease prediction, we compare to CT coronary arterial score of calcium score prediction also, it has almost leveled up to that prediction levels, and with higher learning models, this might even improve over that, all with the fundal picture taken by a technician. Same way with stroke also, it has got this thing. There's a different article, different item, I'm not going into that now. Newer advances in diagnosis. In type 1 diabetes, now we have islet autoantibody screening. There are 4 antibodies with which you can screen and diagnose type 1 diabetes earlier, and you can avoid DKA risk also, and possible access to disease-modifying therapy before clinical insulin dependence starts. What is this disease-modifying therapy? Now we have teplizumab, which is a humanized monoclonal antibody, FDA approved. It targets the CD3 molecules on T cells to reduce the cytotoxic attack and beta cells and delays the onset of stage 3 type 1 diabetes. This is a recently approved topic. It is given as a 14-day infusion. The rare side effect is lymphopenia. Now all these drugs are coming new to the market, are quite costly, but how to address this diabetes problem on a major public health scale all throughout the country or maybe throughout the world? Every citizen in the country and every human being on the planet requires or should be given the same level of treatment. This instantly has been named as Frontier Rice. International Rice Research Institute and the Philippines and Max Planck Institute of Germany, they have brought out this Frontier Rice with the lowest glycemic index and 53% more protein than normal rice. Such a simple thing. We added iodine to salt and grossly reduced the incidence of iodine deficiency disorders in India. So this is a major public health intervention which can be done all over the world with the simple introduction of this rice. Is there a smart rice? What I am talking about, a smart rice, a rice which has got a glycemic content, carbohydrate content, and also has insulin activity or insulin-like growth factor activity. The research is on, and they have found out a plantavar, a variant of plant, which will produce a rice with insulin-like growth factor in it, so that you don't have to worry about insulin. That amount of rice you take, it automatically give you the defect also. Well, I will talk about this paradigm shift only because it's time already. The previous model was to escalate drugs stepwise to maintain or lower.
Yes, sir. It is already exceeded your time limit.
Sir, I have been given by the organizers additional time for covering one of the topics which they wanted me to add, sir. With your kind permission, I will conclude soon, sir. Stepwise escalation of drugs mainly to lower glucose levels to target levels of fasting blood sugar or HbA1c, but the now model advised by ADA 2025 guidelines is early combination therapy with individual selection for the patient considering the cardiovascular, renal, hepatic and obesity related benefits, taking into account the phenotype and the comorbidities. The 2025 guidelines says, you can see the wordings, what is preferred to insulin adult with type 2 diabetes is GLP-1 receptor agonist or dual GLP-1 receptor agonist because of the cardiorenal metabolic beneficial effects it has on it and increase in the life expectancy after starting of treatment. But it advises against combining a DPP-4 inhibitor with a GLP-1 RA because additional glucose lowering is not meaningfully gained. GLP-1 RA or SGLT2 inhibitors with proven benefits should be considered irrespective of background metformin use. You all know about GLP receptor agonists and there's a talk behind that, so I'm skipping about that.
Okay.
Sir, yes, sir. I'm just finishing, sir. And I will finish with this new GLP molecule which is coming up, not in the market yet, orforglipron. We know that oral semaglutide has come, but still it has got a lot of restriction and nausea and other things. This is not a peptide molecule. It's a small molecule with only the receptor portion and can be given orally. And this may be available in the next market with good effects. And beta cell regeneration, we know we have been talking about decades, many agents, but in 2024, a Science Translation Medicine described a combination therapy using hormone plus a GLP-1 receptors, which increased human beta cell mass by a whopping 700% over 3 months. Preclinical work is on, it is soon to be produced. Stem cell and beta cell treatment, we have been seeing decades of research and meaningful translations will be coming in the near future. We all know about artificial intelligence predictive medicine. I don't want to go into that because there is thing. Take home messages. Diabetic care is now cardiometabolic and organ protective, not just glucometric or not just your HbA1c levels. GLP-1 RA, dual GIP, GLP-1 agonists, and SGLT2 inhibitors are reshaping type 2 diabetes treatment. Yesterday, one speaker told in heart failure, even without diabetes, SGLT2 inhibitors are indicated. Continuous glucose monitoring and closed loop systems are redefining type 1 management. Early detection of type 1 diabetes through autoantibody screening opens the door to prevention and disease modification. Regenerative and stem cell therapies are the most exciting scientific frontier. And in railways, I think we need to find a way to treat effectively hyperglycemia in running staff. And the optical fundus imaging is a take-home message where we can predict many diabetic-related complications even before other parameters are apparent. Thank you very much for your patient listening.
Thank you, Laksa, for covering this entire diabetes management in your single lecture. And you have covered very much the two aspects, the emerging technology in the diabetes, especially this insulin. At present, the market is full of this insulin and this marketing we are seeing. And second,
And the AI, you have covered both aspects very well. One thing I would like to add that in our diabetic clinic, we must use the digital fundus examination. Because the diabetic retinopathy is very common and it starts very silently. So in our clinic, we can start a very simple computer-assisted photography, just a small camera, and it gives the picture of fundus in the mobile immediately. And we can store this data in our HIMS system.
Sir, that will be one of the main points of my lecture too. A fundus capture by a smartphone-based camera by a non-trained technician at OPD, outside the OPD or at work spot, which can predict diabetic retinopathy, not only classify in stage, but predict even before the stage 1 diabetic retinopathy. The years to onset of diabetic retinopathy, it can predict better, even better than an ophthalmologist or retinal specialist, is what I showed. Not more and beyond that, it can detect and predict CKD due to diabetes even before other parameters rise.
And years to progression to deterioration to CKD, not only that, CAD, and then stroke also it can predict.
so
Because
I
of
think,
its
you people here, we can develop a protocol regarding this
and
management here.
sir, a tabletop fundus camera, a high resolution fundus camera made with Z's or something runs to 1 crore. Whereas this smartphone based technology with the software comes to anywhere between 4 to 6 lakhs. And no trained personnel, your ophthalmologist will not blame you. You can go ahead with even screen the whole population on a weekly basis using a non-trained willing personnel.
Just like he mentioned about having this fundus camera and all, but I believe diabetes is not being only treated in our central hospitals and divisional hospitals, it is our health unit doctors also who face this dilemma. So I think most of the PCMDs are here, and as we have seen, Ministry of Health and Family Welfare has also been issuing SOPs for treatment of hypertension and diseases like that. So I believe we can have a system in our railways because there's so many medicines also coming up, and the doctors don't even are aware how to start, which medicine to start. As you rightly mentioned, the correct now is giving a combination right from the beginning. So I think if we have an SOP for our railways, it will be beneficial to all the doctors who are working in the periphery also. That is my suggestion.
Madam, I agree with your suggestions, madam. That is a need of the hour also. As I told you, madam, 40 years and above diabetes and or diabetes with even newly treated diabetes, this smartphone-based fundus capturing can be done by a non-technical person. He can go to production units and why not to all the health units also to detect all those patients, and a software base can be made and it can be followed up annually, and we can call those people who are at risk for complications early. This is one of the main things, and we, God willing, we want all 40 and above in ICF to be screened at their work spot, that we have asked for this The company name I am mentioning, Remedio, is what we want. There's another company called IVIS, which you can do it. And 90% of the times, non-mydriatic cameras, I mean, even without putting a drop, waiting for the dilatation, you can take with this thing, it automatically adjusts with 4 points, and you don't have to strain on it. It gives a good image. And even the images are not good and not decipherable by an ophthalmologist, AI, some or other, based on other parameters, is able to detect better, is what literature says. There's a separate article on that. One more thing you told me, madam, I'm sorry, madam, you told me something else also regarding the insulin therapy. What, ma'am? Yes, SOPs is the need of the hour. You were also telling then when the combination therapy, when we are not knowing which drug to start and when to start, AI-based decision support systems are available. You just have to, sorry madam, this is scientific advance I'm talking about. I am not propagating or advising people, doctors should use that, but there is decision support systems are available. There's a slide on that. I didn't have the time to do that. In the ICU, the intern or the nurse just has to feed up everything. The AI-based decision support system will say, add insulin, this thing, or reduce insulin, or even add this agent because of the presence of creatinine as such, or this parameter, or the family history. If you add, it can give you decision support systems. And there is one study, one slide which I could not show. When compared with an endocrinologist in diabetic complication management, diabetes management, one decision support system, AI-based decision support, I'm not telling the name, it has scored over endocrinologist-based therapeutic interventions. So AI is for here to stay. I'm not saying AI is going to replace us, but we have to make use of AI, otherwise we will be at a disadvantage. And our system is always struggling with the lack of manpower, strained at the seams. We've got a huge population. AI should help us do a better job.
Congratulations and thank you, Dr.
Thank you very much, sir. Thank you, sir.
Thank you, sir. Now we move on to the next session. IBS is not always life-threatening, but for many patients it's truly life-altering. Now here I welcome Dr. Srikanth sir to speak on irritable bowel syndrome. Not all struggles are visible.
Dr. Srikanth is MBBS MD, DMO and physician with special interest in interventional nephrology at Paikla Hospital Central Railway. He has had various publications and he's life member of Association of Physicians of India. Over to Dr. Srikanth.
Good morning, ma'am. I thank the chairpersons and the organizers for inviting me for this August gathering and this prestigious APR conference. I bring greetings from Central Railway. I'll keep, probably I'm the youngest of all the speakers, so I'll keep it very short and crisp, ma'am. Today I'll be talking about irritable bowel syndrome and its recent advances in terms of understanding the pathogenesis and pharmacology. But the bottom line is IBS is perhaps continues to be the most challenging condition to treat. It's a condition prevalent to a large extent in the common population. Still that. It's probably sometimes when I discussed it with the gastroenterologist, they say managing IBS is probably difficult than managing an acute complicated pancreatitis. So my outline presentation would be in this head. If we go by sheer numbers, in various studies quoted by various regarding prevalence of IBS and functional GI disorders, 1/3 of our patients have functional GI disorders, and IBS being the most common functional. And the term was coined way back in 1966 and later modified as functional enteropathies. When it comes to defining the IBS, it has changed constantly over the time, but now we go by the Rome 4 criteria, according to which where it talks about recurrent abdominal pain with onset at least 6 months prior to the diagnosis associated with two or more of the following. It has to be either related to the defecation or associated with the change in the frequency or in the form of the appearance of the stool. When we talk about the symptoms in a broader view, patient complaining with bloating and gas, pain in the abdomen, cramps, and two of the spectra of IBS, which are diarrhea and constipation. And also very often patient do report us with fatigue and sleep disturbances because of intimate neurogut access in the connections, and also do report increased sensitivity to food symptoms and can be specific or non-specific. One has to spend time and to interrogate the patient in the very first session and to figure out how to go about in the management of IBS. Coming to the classification of IBS, the subtypes are based on the Rome 4 criteria. The following heads are constipation predominant IBS, the diarrhea predominant, and a mixed variety and unclassified. Coming to the constipation, in the constipation predominant variety, the constipation is the main symptom. Whether it is in constipation dominant or a diarrhea dominant, it has to be decided based on the Bristol stool chart. Those who are familiar, it divides the stool chart into 7 types, from type 1 to type 7. 1 and 2 are more likely to be a constipation dominant, whereas 6 and 7 are more mushy, watery, mucus kind of diarrhea, dependent IBS. Coming to the epidemiology, it is a very common disorder where prevalence is from 3 to 20%, where younger people have a higher prevalence, and there is a definite female preponderance in most of the studies. In various studies across India, it has been reiterated, and the fact is, it is just not necessarily being urban disease, but also largely seen in the rural population. But the female preponderance has generally been emphasized in most of the studies. Coming to the pathogenesis. The pathogenesis has multifactors involved, like visceral sensation, hypersensitivity, psychosocial factors, environmental factors, all play an important role in the production. The gut flora changes, prior infection, pre and postnatal factors, psychological stress, and most important being the gut-brain axis, and diet and food sensitivity. Coming to the genetics, there is some degree of genetic predisposition. The heritability is studied in various aspects. Some amount of genetic polymorphism have been recognized, whether it is a serotonin uptake receptor or uptake molecules, or with inflammatory response molecules, and produced when these are being fairly well defined. Example, monozygotic twins have 15 to 20% concordance with the background of environmental influences. Coming to the environmental contributors, early life stressors, gut infections, food sensitivities, and gut microbiome imbalance. Coming to the very important thing, brain-gut axis, there is definitely a connection between the CNS and the enteric nervous system. It is an intimate connection between CNS and ENS, where an understanding of this intimate connection is important, as a lot of pharmacotherapy depends on extent of involvement of this brain-gut level. Coming to the role of diet in IBS, as we all know, FODMAPs, the diet has a significant role. It is the mainstay of treatment in irritable bowel syndrome. One of the things we advocate is diet low in FODMAPs, which are fermentable oligosaccharides, disaccharides, monosaccharides, and polyols. Probably we can advise patients to have diet rich in vegetables, onion, garlics, potatoes, fruits, apples, mangoes, and watermelon, and cereals rich in wheat and rice. Hence, diet is an important component. When we come to the management of IBS, a doctor-patient relationship is very important, and lifestyle modifications. These two are the mainstay of the treatment, regardless of the symptom severity, and probably sufficient in the management of the mild symptoms. when in a busy OPD, one must give an ample amount of time to the in establishing a patient-doctor relationship and rapport, which is of which is of paramount importance in the long-term outcome of IBS. Often they are mistaken to be malingering or to be having something in their head, but it is about having some organic causes triggering the brain-gut axis and pushing the patient to be symptomatic, moderate, or severe. For moderate symptoms, pharmacological therapies may be added and aim to relieve predominantly bowel and visceral. But for severe symptoms, patients with refractory symptoms and psychopharmacological agents and psychotherapy can be used. Some non-pharmacological measures for irritable bowel syndrome include yoga, hypnosis, cognitive behavioral therapy, and diet changes. When it comes to the treatment options, as I said, first and foremost, the option would be the doctor and patient relationship, spending time with the patient and remains consistent and will never change. Explaining the patient about dietary modifications in the form of low FODMAPs, physical activity, and avoiding stress and sleep deprivation are the mainstay. Treatment is divided into 3 categories depending on the IBS type. About constipation, mixed, and diarrhea. Some drugs overlap in all the 3, which are and some have specific particular subset of patients. About IBS, constipated patients, use of certain osmotic laxatives like polyethylene glycol are the mainstay of treatment. Certain secretagogues like lubiprostone, linaclotide are very useful. Beyond a point, if they are not responding, there is a role of selective serotonin reuptake inhibitors or tricyclic antidepressants, which act in the neutral gut axis and do decrease the visceral sensation, reducing the bloat and psychosocial stressors which are related to the symptoms. When it comes to the mixed variety, the antispasmodics, rifaximin, and which also have the role in IBS diarrhea type, usually we give a pause for 2 weeks and subsequently we have to repeat the rifaximin dose. Previously there was a drug called allocetron which was stopped as there were reports of ischemic colitis in the elderly patients, still available but not frequently used these days. There are definitely promising results with the use of ondansetron in IBS diarrhea type, tricyclic antidepressants, and SSRIs. Psychotherapy has the definitely important mode of treatment, adding to the therapeutic armamentarium. As there are a lot of overlap of drugs between IBS diarrhea, constipated, and mixed type, depending on the underlying symptom, we may have to tailor our medication. Just to re-emphasize, there is no single drug which fits into every patient. As we have to modify and enmesh our medications, we need to spend a good amount of time with the patient and develop a good rapport to address their needs. Some patients present with non-ulcer dyspepsia, so a role of PPIs and anti-H. pylori treatment and prokinetics is the key. Patient profile who has not lost a significant amount of weight, no drop in hemoglobin, normal appetite, and no occult blood in the stool, recurrent episodes of pain abdomen, vomiting, all these factors probably suggest more likely IBS. Coming to the newer drugs of IBS, olorinumab, these new drugs add to the horizon, in which promising one is olorinumab, which is a cannabinoid receptor 2 agonist, which is peripherally acting. The next one, interesting one, is dextromethorphan, which is a benzodiazepine non-sedating agent. The future directions, role of live biotherapeutics, fecal transplantation of microbiota, probiotics have always a role in treatment of IBS. The patient selection is important as they should have a low dysbiotic index for fecal transplantation, and efficacy is fairly high, like 3 to 6 months period. To conclude, IBS is a distressing disease to have. A recent study by the American Insurance Group revealed patients out-of-pocket expenses amounting to $750 to $7,500 a year, along with the loss of man days and loss of work hours. Hence, IBS is merely not an irritating or an irritable disease, but it requires a lot of consideration and empathy. Thank you. Yes.
Any questions from the audience?
What is the role of pre and probiotics in IBS?
So definitely they have a role in IBS, sir. Usually with mild and moderate symptoms, can be managed with pre and probiotics, sir. Along with, it depends on the type of IBS, whether it is diarrhea or constipated or mixed variety. But pre and probiotic definitely have a role, sir. Pardon?
Market is flooded with so many pre and probiotics.
Yes, sir. Yes.
Lard is better or in this capsule is sachet is better?
Sir, sachets are more better because it's a granular form, so absorption is faster with the granular form.
One thing, Dr. I would like to emphasize that at present these cancers are emerging very fast in our society, whether it is the gastric cancer or the colorectal cancer. So, and the most of the features mimic this IBS. So, what are the important symptoms, red flag signs you can differentiate from its cancer in the already established IBS cases?
Sir, as you rightly said, there it is multifactorial, sir. It is just not. It is lifestyle related, environmental factors, your stress related, and also definitely a genetic predisposition. And diet is very importantly one of the main part of preventing cancer, sir.
No, I am not asking about its causes. How will you differentiate from this cancer, the IBS?
Sir, IBS is a what the body says it's a functional disorder, sir. Whereas in cancer there are classical symptoms like weight loss, despite being.
You must insist only the two things:
Yes.
the weight loss and the rectal bleeding. If these cases happens in your such cases, then cancer is more likely to.
Yes, sir. Usually in IBS, in long-standing IBS,
In the history taking every time,
yes,
especially after the age of 40, you must ask weight reduction and the rectal bleeding. 2 points are very common.
yes.
Okay, thank you.
Thank you.
Dysbiosis, sir.
Yes.
Dysbiosis. It is a understanding of the understanding of the gut anatomy and physiology with other diseases. Dysbiosis. Now there is an imbalance between the normal commensals and the body. So there are so many diseases being coming up now. So say gut, they say is the peripheral brain. It has been less studied, less understood. Now as much you understood about the gut, you will understood about the diseases. So now most of the diseases is coming around. One of this thing is irritable bowel syndrome also because of the dysbiosis. There is an imbalance between the gut microflora and the other disease developments.
As they commonly say, happy gut is a happy brain.
Yeah, happy gut is a happy brain. Currently, the dysbiosis it is coming up very, very. Thank you.
Okay, thank you so much, Dr.
Thank you.
Sir, I request the speaker to stay back, sir. Please do have the felicitation now. I request the chairperson to felicitate the speakers. Dr. Satya Babu, sir. Dr. Srikanth, sir.
Dr. P. Chandrasekhar Rao sir and Dr. Sarkar sir, please come out to this stage. Our chairperson, Dr. Jyotsna Kalra Madam of the PCMT Western Railways. She has given the highest number of E-Trade camps in Western Railway, total of 99. And she belonged to 1990 IRHS batch. And she almost has 35 years of clinical experience. And she has worked in all levels of IR healthcare in different zones. Her areas of interest is management and quality control. CMO, Banaras Locomotive Works. He is an able administrator. He has conducted numerous health camps as a preventive measure, and he belonged to 1990 IRHS batch. He has almost 34 years of clinical experience. His areas of interest are hospital administration and preventive medicine. Thank you, sir.
Of Railways to meet Dr. Trupti Vishal, take the QR code scan and take the membership and by paying ₹1,000. Kindly do it today itself. Thank you.
One more announcement, the stalls are all open there, and especially the sari stalls. Lady Redigates, if you are interested, you can get some authentic South Indian saris. Please utilize this opportunity.
Thank you, ma'am. Dialysis may sustain life, but preventing diabetic kidney disease preserves quality of life. Now I welcome Dr. Radha Vijay Raghavan, ma'am. Diabetes to dialysis, breaking the chain. Welcome to you, ma'am.
Thank you. Respected chairpersons, PCMDs, PHODs, and my dear friends. I'm going to talk on a very important topic, diabetes to dialysis, how you break the chain. Greetings from Railway Hospital, Perambur. My flow of presentation would be, I'll start with context and importance, go on to definition and terminology, pathogenesis of disease, management strategies, and what do we do in the real life scenario. Madam was talking about SOP for even the health units, and I would conclude. Why is it important that we talk about chronic kidney disease and diabetes? This study estimated the overall prevalence of CKD among patients with type 2 diabetes in India at 44%, which means that every other diabetic patient is going to have CKD. And this study by the International Diabetes Federation showed that Southeast Asia is going to see a 74% increase in type 2 diabetes by 2045. So we all know that diabetes is going to increase. And what is the trend in the global burden of CKD with diabetes? The upper graph shows type 2 diabetes, about which we are talking about mostly. And the incidence of the first graph shows the death, and the second one shows the DALYs, disability. And you find that we are in 2026, and see in 2050, there is going to be an exponential increase in the burden of CKD with diabetes and the number of deaths and disabilities. What is the cost economics? This study done by Vishwanathan et al. In Chennai divided diabetics into 4 groups. If you have a diabetic without complications, your cost for the 2 years would be 30,000 rupees on an average. But if you have CKD non-dialysis, that is stage 1 to 4, the cost would go up to 1 lakh for 2 years. And if you are on dialysis, the cost is 5 lakhs. And if you have undergone transplant, the average cost is 3.45 lakhs. This does not take into account the man days lost, the hidden cost due to man days lost of the employee, of the caregiver, and all the other hidden charges. So we are looking at a pandemic of CKD with diabetes and a tsunami, which we have to tackle, and we have wonderful drugs to halt this trajectory. So the current terminology as per KDIGO is CKD in diabetes or diabetes and CKD. We do not call it as diabetic nephropathy, which is a pathological diagnosis. We do a biopsy, and if you find the hallmark of diabetes, we call it diabetic nephropathy. We do not call it as diabetic kidney disease. Why? We know that in type 2 diabetes, the cause for renal failure is not only hyperglycemia. These patients also have obesity, which can cause renal injury. They have uncontrolled hypertension. They have recurrent episodes of UTI pyelonephritis, which cause scarring to the kidney. They are vulnerable to acute kidney injury, and every episode of acute kidney injury pushes them into CKD. And elderly population also have a small area of atherosclerotic renal artery stenosis causing ischemia. And so in type 2 diabetes, we find that it is a multifactorial problem which leads to chronic kidney disease, and so the terminology. And all of us know about the definition of CKD in diabetes, which is based on the urine albumin creatinine ratio and the eGFR. Only to say that the term microalbuminuria is no longer used. We call it as normoalbuminuria or moderately increased albuminuria or severely increased albuminuria. So it is mandatory that we look at the urine albumin creatinine ratio. And we all look at the creatinine in type 2 diabetics, and we calculate the GFR. Few caveats are: just look at the serum creatinine value, the authenticity of the lab, and the method by which it is done. If it is done by an enzymatic method or the Jaffe kinetic reaction, you use the MDRD equation for calculating the GFR. If the lab uses an IDMS method, which is the gold standard, use the CKD epi with race equation and calculate the GFR and place your patient in this heat map. This heat map shows the patients who are in the red orange are at increased risk of CKD progression, cardiovascular risk, and mortality. Now, a few words on the pathogenesis of the disease to understand the treatment. We know that high blood sugars cause oxidative damage and damage to the DNA and mitochondria, causing damage to all cells. The advanced glycation end products combine with the receptors and again cause an endothelial stress. This is the metabolic pathway. There is also a hemodynamic alteration leading to a glomerular hyperfiltration, which leads to damage. So on the right side, you can see the normal glomerular capillary versus the diabetic kidney. You find that there is mesangial expansion, there is a glomerular basement membrane thickening, and a damage to the podocytes leading to proteinuria, and all these take place at the cellular level. Whenever there is a kidney injury, there is a release of damage-associated molecular patterns, which is recognized by the pattern recognition receptors, which produce an inflammatory response, cytokines and chemokines, which recruit bone marrow-derived monocytes and macrophages, which trigger the inflammatory pathways through nuclear factor kappa B, MAPK, TGFB, causing fibrosis. This is not only relevant for the kidney, it's also relevant for the heart. So coming to the management strategies, which is the core focus of today's talk. First, rule out a non-diabetic kidney disease, a diabetic who has an active urinary sediment, who does not follow the usual timeline, who has symptoms and signs clinically of another disease like a vasculitis or a connective tissue disorder. Elderly, think of multiple myeloma, you do a biopsy. The 4 pillars of management of diabetic kidney disease are RAS inhibitors, SGLT2 inhibitors, non-steroidal mineralocorticoid receptor antagonist finerenone, and the incretin-based therapy. First is the pillar is the RAS inhibitors. How do the RAS inhibitors work? So this diagram tells you what happens in a normal glomerulus, what happens in a diabetic glomerulus, and what happens when you give RAS inhibitors. For want of time, I will not go into the details, but know that the RAS inhibitors are the sheet anchor or the first pillar of management. They are very cheap drugs available in all health units, enalapril, ramipril, and we have telmisartan, valsartan. You start with a small dose, monitor the RFT and monitor the potassium and go up to the maximum dose. Note that the maximum dose of enalapril, which is beneficial for the kidney and heart, is 40 milligram. Ramipril it is 20, whereas for telmisartan it is 80 and losartan it is 100. So it's easy when you give an ARB to escalate the dose, whereas it is difficult when you give a RAS inhibition. Always monitor the potassium when you are giving RAS inhibition. If there is hyperkalemia, do not stop the drug, but make sure it is not pseudo hyperkalemia. Make sure to get mitigative treatment for the hyperkalemia. We have the novel potassium binders including sodium zirconium cyclosilicate or Lokelma available in our country. And if all other measures don't work, then consider stopping RAS inhibitors. The second pillar is the SGLT2 inhibitors. These have multiple mechanisms of action. They have hemodynamic beneficial effects and reduce the glomerular hyperfiltration. They have antioxidant and anti-inflammatory response. They have a salutary effect on erythropoiesis and oxygen consumption. Also, they have a good reduction of glucose toxicity. So, by this pleiotropic effect, they are beneficial in patients with chronic kidney disease, and they are not only useful in diabetes. They bring down the blood pressure. They have a favorable effect on lipid profile, on the metabolic syndrome, on liver disease and macrophages and obesity and the mitochondria. And that is why the 3 large double-blind randomized control trials on CKD, Credence, DAPA-CKD and EMPA-Kidney conclusively proved that they are beneficial in reducing the renal endpoints. So I urge all the physicians here to be active flowzinators. You start gliflozins when the GFR is more than 20. And as the GFR drops to less than 20, you need not stop the flozins unless the patient goes on dialysis or kidney transplant. The next blockbuster drug is the non-steroidal MRAs, finerenone. So, mineralocorticoid receptor activation is the culprit for endothelial dysfunction, renal disease, cardiac disease, macrophage activation and sodium retention. And so when you block this with mineralocorticoid receptor antagonists, we have the non-steroidal antagonists which are more potent, which have more benefit on the kidney and a definite role in heart failure with preserved ejection fraction. So 2 large studies, Fidelio DKD and Figaro DKD, and the combined fidelity with 13,000 patients, a double-blind randomized control trial with very, very strong signals, showed a definite decrease in cardiovascular endpoints and renal endpoints when we use this drug. The only problem with finerenone is the potassium. So you start it when the potassium is normal and closely monitor the potassium. If the potassium is 4.9 to 5.5, be cautious. Use at a smaller dose and make sure that the patient takes a potassium restricted diet. You can take away all other drugs which can cause hyperkalemia and try to manage. Still, if it is high, you use the potassium binders. As I told, we have Lokelma which can be given for a long time. The only problem is that if the patient has a significant heart failure with reduced ejection fraction, still spironolactone or eplerenone are the drugs of choice. If a patient has diabetes with CKD, albuminuria and a heart failure, will you choose a non-steroidal MRA or a spironolactone? That depends on which clinical disease is more pressing. If he has more heart failure with reduced ejection fraction, of course you go with spironolactone. But if the albuminuria is more pressing, CKD is more pressing, you go with finerenone. The blockbuster drugs, incretin-based therapy. Yesterday the oncologist spoke, the gastroenterologist spoke, the cardiologist spoke. So it is also beneficial to the kidney. I am not going to dwell into the pathogenesis by how incretin-based therapy helps. So this study, the FLOW study using semaglutide, clearly showed that there is a 24% decrease in the major adverse kidney endpoints in patients who were giving semaglutide versus placebo. A point of caution: when you use GLP drugs, incretin-based drugs, they have GI side effects. The GI side effects are dose dependent, and they can have an injection site reaction and tachycardia. You should not use them in patients with a history of medullary carcinoma, thyroid, MEN2, or an acute pancreatitis. Diabetic retinopathy can worsen with these drugs. And we have now dual incretins and triple incretins. Dual incretins are the tirzepatide, which target both GLP and GIP, and we have triple incretins, but the studies on chronic kidney disease are ongoing. Now we come to the real life scenario. So you can initiate all these guideline directed therapies together, like this dumpster which will dump everything, or whether you can give in a refined manner as a precision based therapy. When you give all the drugs together, RAS inhibitors with SGLT2, with finerenone, with incretin based therapy, the advantage is that you are maximizing the benefits early and you have lesser hospital visits and lesser investigations. But the problem is you cannot monitor the stepwise side effects. You cannot pinpoint which drug is causing which side effect, and that is the problem. But when you are giving a stepwise therapy, you can monitor the side effects properly. You can pinpoint the drug which is causing the side effects, so it's more safer to the patient. But the patient has to make more hospital visits, more investigations, and we are maximizing the benefit later, and so the patient compliance is less. This study, why should we use all the drugs together? So this study, sub-study of Fidelity, showed that if you give finerenone alone, compared with finerenone with SGLT2, compared to finerenone with RAS with SGLT2 with GLP, the maximum benefit was seen when all the drugs were combined together. And the confidence study, which put both SGLT2 and finerenone upfront in patients with diabetes already on maximal RAS inhibitors, showed that when you combine the drugs, there is a synergistic effect and a more better drop in the urine albumin creatinine ratio, and also a lesser hyperkalemia when you put finerenone alone, because SGLT2 inhibitors do have a caliuretic effect. So what do? When a patient with diabetes comes, you give a comprehensive strategy. First is the lifestyle management, weight reduction, smoking cessation, diet and exercise. Next is the foundational pharmacotherapy, which consists of RAS inhibitors, SGLT2 and statins. Then you go to the additional risk-based pharmacotherapy or the precise depending on the patient. You can give GLP-1, you can give NSMRA, antiplatelet therapy, and treat to target the blood sugars, the blood pressure and the lipid. So I end up with a case study where you have a 52-year-old male who is a diabetic, CKD stage 3B with A3 albuminuria on maximally tolerated RAS inhibitors, but continues to have albuminuria. You want to give a guideline-directed medical therapy. What do? This is the algorithm which I devised. Look at the heart. If the echo shows an ejection fraction which is less, congestive cardiac failure. Next, look at the potassium. If the potassium is normal, you can start SGLT2 with finerenone as evidenced by the confidence study, and then add an incretin based therapy. But if the potassium is already a little bit high because of the RAS inhibitors, add an SGLT2 inhibitor, which itself might bring down the potassium. Still, if the potassium is high, introduce potassium mitigating strategies, and once the potassium is normal, start NSMRA and then incretin based therapy. Suppose the patient has an atherosclerotic cardiovascular disease in the form of coronary artery disease, SGLT2 inhibitors and incretin-based therapies are the first-line therapy, and then add NSMRA depending on the potassium. If he has a cerebrovascular disease or stroke, the evidence points strongly to incretin-based therapy. So you will start a GLP-1 analog, add on an SGLT2, and then depending on the potassium, add a finerenone. If the patient has peripheral vascular disease, this is one place where I would be scared to use an SGLT2 inhibitor, because the CANVAS study showed more risk of amputation and still there is a black box warning for SGLT2. So I would use incretin-based therapy, add on an mRNA depending on the potassium, and would be cautious in using SGLT2 inhibitor. If my primary comorbidity is obesity, I would upfront use an incretin-based treatment and add on an SGLT2. Finerenone does not have any effect on the obesity. If hyperglycemia is the main problem, again incretin-based therapy should come first, followed by SGLT2 and last by NSMRA. So, future direction of CKD in diabetes, we have endothelin receptor antagonists, we have the atrasentan. We have pharmacological activation to block the inflammatory pathway NRF2 target, where we have bardoxolone, and even our common household spices like cinnamon has an effect. Gut microbiome. Yesterday, the gastroenterologist told that gut is the start of all evils. So, gut microbiome as a novel and modifiable target in the treatment of CKD. Lot of research is going on. Ceramide synthetase 6 pathway inhibitors are there. Stem cell based interventions with mesenchymal stem cell transplant. And as Dr. Satyababu said, incorporating AI and machine learning in every step, from screening, from diagnosis, from treatment and monitoring is there. So take home message, all diabetics type 2 and type 1, check the urine for albuminuria. You might be in a health unit where you have only a dipstick, or you might be in a tertiary care hospital where you can do the spot albumin creatinine ratio. Irrespective of it, check the urine for albumin and do a baseline creatinine for all diabetics so that we pick up CKD early. Emphasize on lifestyle modification. Institute primary treatment. I find that most patients are not on RAS inhibitors. All patients should be on RAS inhibitors and SGLT2 unless there are contraindications. Then add the risk-based or customized pharmacotherapy in the form of incretin-based therapy or NSMRA, and be abreast of the latest developments. Every year new developments are coming and new guidelines are coming, and treat to goal. So we are facing a pandemic, we are going to face a tsunami of CKD, and if we fail to prepare, we will fail the railway beneficiaries. Hope this talk helps you prepare to break the diabetes to dialysis chain. Thank you.
Thank you, Dr. Radha. Sorry we couldn't introduce her. Dr. Radha is Chief Specialist Nephrologist from Perambur Hospital, Southern Railway. And she has been, before doing her DM nephrology, she was practicing nephrologist for more than 15 years and very dedicated. She has started CRRT program, hybrid SD also in the Perambur Hospital. And before we go for the question answer session, I want to add one more thing. If the patient of diabetic or any CKD patient coming with worsening of creatinine suddenly, you should ask first the history of taking alternative medicine. That is most important thing, which is very rampant in our India. So that thing we have to keep in mind. And
so we are in a tropical country, so dehydration is more common, renal calculi are more common, and unregulated use of NSAIDs and native medications. All these also add insult to injury, and that is why the terminology of diabetes and CKD. So it is our bounden duty. Any diabetic who comes even to a health unit, type 2 diabetes you see, you look for end organ damage and make sure that they get the preventive medications. It's available everywhere. RAS inhibitors are cheap, gliflozins have become very cheap. So N-acetylcysteine and taurine, they are not in the guideline directed medical therapy for chronic kidney disease. However, they have a very small protective role. So if the patient is on guideline directed medical therapy, you can add on. It is more for a tubular disease. If somebody has an acute kidney injury due to hypovolemia and takes time to recover, or even in diabetics, alpha keto analogs have a definite role. So the KDIGO has told that if you put a patient on a very ultra low protein diet and give an alpha keto analog, it can help in the prevention of progression of CKD. But the N-acetylcysteine taurine do not have a guideline directed therapy. However, when you tell a patient who comes with chronic kidney disease, they think that their creatinine can come down with medicines, like how you give blood sugar medicines and BP medicines. So I tell them that your creatinine will not come down, that you have an irreversible damage. And then they ask, why don't you give medicine for the kidney? They don't understand that the RAS, they look at the RAS inhibition as antihypertensive medication. They look at the GLP-1 as anti-diabetic medication. Even many doctors and physicians think that they don't think that the RAS inhibition is an anti-proteinuric drug. So when the patient asks, I want some medicine for diabetes, for him to come back to you and to be on follow-up, we have these medicines are in our formulary and they don't do harm. And they have a small benefit, though it is not there on the guideline directed therapy. We do use N-acetylcysteine taurine. Alpha keto analogs have a definite role.
Because now
which one, sir?
Probiotics.
Yeah, so the
very costly.
gut microbiome is still in the research, and still it has not proven beyond doubt that it is beneficial. And so outside they use, but in railways we are not compelled to have all these compulsions. We should use guideline. Many times we find patient not getting RAS inhibitor or SGLT2, but getting all these drugs which are very costly, which is not correct. It is still under research, sir. Gut microbiome and kidney disease is still under research.
Madam, a question.
Yes, sir.
Ma'am, during diagnosed case of diabetic mellitus, you told check for creatinine and albuminuria, proteinuria. What about GFR?
So the GFR is a calculated GFR. From the serum creatinine, you have validated equations by which you can calculate the GFR. Some labs have it incorporated and they give the eGFR, otherwise you have to calculate. So you have apps which can be downloaded. The MDRD equation and the CKD epi equation are very complex equations which is very difficult for us to calculate. So you go to the National Kidney Foundation app where you have an eGFR calculator. You can choose whether you want to use MDRD equation or CKD epi equation. For children, we have a different equation, and you enter the age of the patient and the serum creatinine value. If your lab does the creatinine by modified Jaffe kinetic or enzymatic method, which most labs in railways would do, you use the MDRD equation. If the lab does by IDMS, isotope dilution mass spectrometry, that is the gold standard, but it is costly and many labs don't do, you use the CKD epi equation, and that equation will give you the eGFR. It is a calculated eGFR. If I have to measure the GFR, it is done only in research situations using inulin or using radionuclide assays, which is not necessary for a routine screening of patients with type 2 diabetes. Just get a simple serum creatinine in a good lab and you use the eGFR equation and calculate the eGFR and put him in the category, whether he will be in G1, G2, G3 and A3, A1, A2, and put him in the heat map so that we will know the risk and we can give a guideline directed medical therapy.
Any role of USG, madam?
Ultrasound will only show a structural defect. Suppose you are thinking of an obstruction, or you are thinking of scarring, or you are thinking of an atherosclerotic renal artery stenosis, you do. We do an ultrasound mainly to rule out an obstruction or some other cause. Many of these patients will have diabetic cystopathy. They can have a significant PVRU with hydronephrosis. So ultrasound is done in all CKD patients to rule out obstruction, or if there is an asymmetry of the kidney, you can think of atherosclerotic renal artery stenosis. Many of our patients are elderly patients. They do have an atherosclerosis also. And the moment you put a RAS inhibitor, their creatinine will jump up and potassium will jump up. That also is a clue. And ultrasound, if it shows asymmetry, you can do a renal Doppler and angio and confirm that it is renal artery stenosis. If there is bilateral renal artery stenosis, it's an absolute contraindication for instituting RAS inhibitors. There are methods like we do a renal angioplasty. You can try to correct that also. So we do an ultrasound in all CKDs basically to rule out an obstruction or to rule out whether there is something else. In diabetes, generally the kidneys will be normal in size or bigger. There will not be any major asymmetry. You won't find scarring unless the patient has had pyelonephritis or a renal stone disease, which can very well occur in patients with diabetes.
So one thing, madam, non-diabetic is sometimes we refer for ultrasound for another causes such as. Most of the time they usually write MRD grade 1. उसका सर पेशेंट आगे सर खाने लगता है, सर मुझे तो किडनी बीमारी होगी, KFT is normal, what to do?
So the kidney disease is not diagnosed radiologically. It is diagnosed only by urine albumin creatinine ratio and the serum creatinine. But when the radiology tells that, please look at the urine albumin and creatinine, and if they are perfectly normal, you can tell the patient, though you are at risk of developing renal disease because of diabetes, at present you are okay, but you come for follow-up. All patients every year should undergo end organ damage assessment. So many times the radiologist and the ultrasound and CT will say perinephric fat stranding, they will say so many things, but it is not correct. So that is actually we need to take up with our radiology colleagues and see. And each radiologist, different centers, it's very different. But the diagnosis is only by urine albuminuria and serum creatinine.
Thank you.
Madam, whether screening for hypertension and diabetes in every adult, every year, will help in early diagnosis?
Yes, so that is primary prevention. So if we want to prevent CKD, we have to screen. So the railways are doing the AVAC. So we are screening all employees for the hypertension, diabetes, dyslipidemia and a urine routine also. So if you can screen and find out diabetes early, hypertension early and treat, then all the other end organ damage like stroke, like cardiovascular morbidity, like renal disease, we can prevent in a large way, and that is the primary prevention which we should aim for, and that is where the health units and the physicians, always I say that in a tertiary care hospital you see dialysis patients, you see cardiac patients, and it is very depressing. Whatever you do, their quality of life will not improve. But if you are in the preventive stage in a health unit where you can detect hypertension, detect diabetes, and screen them and treat them effectively, you would be doing a great service in preventing renal failure, preventing cardiac disease, preventing liver disease, and all the other non-communicable diseases which have a very high morbidity and mortality.
And then whether SGLT2 inhibitor can be used as a first line.
Yes, so the American Diabetes Association also says earlier it was only metformin. Now they say you can use metformin with SGLT2 because more than metformin, SGLT2 inhibitors have a proven cardiovascular and renal outcome. And since all diabetic patients are at risk, we saw 44% are at risk, and coronary artery disease, we do not know. There is no direct correlation with hyperglycemia. And since SGLT2 inhibitors are widely available in all health units, cost has come down with the takeoff of the patent. We should use, only thing we should know the side effects. So patients can develop euglycemic ketosis. Patient can develop a little bit of dehydration and a little bit of fall in GFR in the initial days, which will subside. And if a patient has a peripheral vascular disease, we should be cautious, and always when you put on SGLT2 inhibitors, follow the sick day rule. Whenever the patient gets admitted for any intercurrent illness, give a sick day holiday and then restart the SGLT2 inhibitor. It has come even in the guidelines, sir, that you can start it upfront.
At what stage of CKD, that is CKD, should we start aspirin and atorvastatin?
So aspirin is given for primary prevention of all diabetics, irrespective of the status of CKD. So that is the foundational pharmacotherapy which I showed. All diabetics should be on statin plus aspirin plus RAS inhibition if they have albuminuria or hypertension. So and you always individualize. Suppose I have an 80-year-old man who has had a UGA bleed or who has an acid peptic disease and he has only diabetes. So this is where the difference between the guidelines and the patient care comes. The guidelines are there to help us to guide. But when I see an individual patient, I always assess the risk and the benefit of the drug to the patient. So I would weigh the benefit and the risk. So suppose there is an 80-year-old man who has had an UGA bleed or he has a bleeding pile and he would not come for a regular follow-up and he does not have any coronary artery disease or CKD, I would hesitate or I would explain to him, see, this drug is indicated in the guidelines, it will prevent the risk of strokes and CAD, but these are the side effects. So always you have a conversation with the patient and take him into the decision-making process and then institute the therapy. That is true for all the guideline-directed medical therapies which I talked about.
Thank you, sir. Due to paucity of time.
Thank you, Radha Madam, for taking such an important topic on diabetes, kidney disease. It's a briefing and this multi-pronged management. You have already touched such an important topic, which is too important for the railway populations, because we have got a very big treatment cost on the diabetes, kidney disease.
Yes.
Thank you very much.
Thank you, sir.
Mark is an open book. You can have questions in the audience. Thanks, sir. Now I call upon. The kidney often becomes the battlefield where the severity of SLE is truly revealed. Now I call upon Dr. Aditya Kumar, sir, for his next session. Thank you, sir. Over to the chairpersons.
So our next speaker is Dr. Aditya Kumar. He is a nephrologist from South Central Railway only. He is gold medalist in nephrology, and he has got experience of more than 13 years. He is 2012 batch IHS officer. Now I will invite Dr. Aditya Kumar.
Good morning, chairpersons and all dignitaries and all my dear colleagues. When I was given the topic to talk in APRCON, so I was thinking what topic to talk about. Diabetic kidney disease, I know, was already covered. Then I was thinking which topic to choose. Then I thought that I will choose a topic which holds very dear to me, and of course, this topic which I am going to talk about, lupus nephritis. It generally affects mainly the younger population. All the diseases which we have so far covering generally cover middle age and elderly age. This is a disease which particularly affects the future of India, especially the women of India. This is a disease which affects 15 to 45 years of age group, and reproductive age group. This is a disease where the patient is not at all at fault. You can blame metabolic factors for diabetes, you can blame lifestyle diseases for other things. This is a disease where the patient is not at fault. Yet he is cursed with this disease and it presents in such a myriad ways. We have seen a happy-going patient suddenly diagnosed with the disease and his entire life collapses in front of him. But nowadays, thanks to improvement in advances in medicine, this disease is now getting slowly under control. Why I wanted to present this disease in front of physicians is, one thing, this is an iceberg phenomenon. This is a disease, I'll tell you, when I was in MBBS, many years ago, the prevalence of lupus in Harrison was 3 per 1 lakh population. When I was doing my PG, it came to 10 per 1 lakh population. By the time I finished my DM, now they are saying 70 per 1 lakh population. So what has changed? Nothing. It is now we are more recognizing the disease. Now more awareness is coming. That means in this hall also there might be people who are having subclinical lupus. We are not able to diagnose it. So that is, I hope in the next few minutes we will be able to see. Now, I have no disclosures. The outline of my talks will be KDIGO 2024 guidelines and what is the pathophysiological basis of newer therapies and what is the future outlook. So let us go over the evaluation and treatment of SLE and lupus nephritis. So it was fairly recognized in the early 1900s only, SLE. Initially they didn't know what to do, so they were just giving aspirin. Later on with the advent of steroids, and then HCQ. Next, what happened? Till 2011, if you see, there was no FDA approval drug. So from 1955 to 2011, there were many trials like steroids, cyclophosphamide, MMF, azathioprine and all. But none of them were FDA approved because the trials were being done, but they were not so significant for FDA to approve it. In 2011, it was the first belimumab which was approved. And later on, 2020, belimumab was further approved for lupus nephritis. 2011 was for SLE, 2020 is for lupus nephritis, and 2021 is voclosporin. And whatever drugs we are giving, azathioprine, abatacept, cyclosporin, cyclophosphamide, leflunomide, MTX, MMF, Ritux, TAC, thalidomide, these are all off-label drugs as per FDA. However, KDIGO does recommend these drugs. So we all know about the class of lupus nephritis. If you have a class 1 or 2 lupus nephritis patient, you have to go by the proteinuria. If it is low level proteinuria, what will be the treatment? The immune suppression will be guided by the extrarenal manifestations of SLE. That means if the patient does not have any extrarenal manifestation, please do not give anything except HCQ and RAS inhibition. RAS inhibition is mandatory. GDMT continues. Whatever madam was telling about diabetic kidney disease, that GDMT, that 4 pillars will continue to be part of lupus nephritis treatment also. But if the patient has nephrotic range proteinuria, then we have to think of lupus podocytopathy. See, what is lupus podocytopathy? It is like MCD only. The picture is normal, but there is immune deposition. In class 2, there may be mesangial deposits, and if you see IF, there may be full house also. Especially C1q must be present. That is how you differentiate between MCD versus lupus nephritis, podocytopathy. And when you do electron microscopy, you will realize that there is loss of food processes. So you have to then treat as MCD. However, this is generally steroid non-responsive, so you will have to consider additional immune suppression like MMF or cyclophosphamide. So that is why, that is the importance. Now, in class 3 and 4, which is the most common and which is the dreaded lupus nephritis. So if your biopsy is showing class 3 and 4, and if there is concomitant TMA, then the patient will be, plasmic score will be done, and patient might require even plasmapheresis, rituximab, apart from the standard immune suppression. However, TMA incidence is pretty low. The classical what is seen is activity and chronicity score is seen. If the patient is showing activity index, so you require immune suppression. If the patient is showing only chronicity without active, that means it's a burnt out lupus. So you will not go ahead with aggressive immune suppression. So at that time you will label that as CKD and you will start supportive treatment for CKD. And if the patient has concomitant for high, that is it is 4/5 or 3/5, you are supposed to treat because that 5 is causing proteinuria. It is a membranous nephropathy. So you are supposed to give immune suppression. And what is the treatment for lupus nephritis 3 and 4? As per 2012, if you see, which is what most of the physicians must be following, you see and everybody knows, we just pulse it of the patient, high dose pulse, 500 to 1 gram per day for 3 days, followed by 60 mg roughly, because we take average body weight as 60 kg, and then NIH protocols, IV cyclophosphamide 1 gram per meter square for 6 months, or oral cyclophosphamide or ELNT protocol 500 mg 2 weekly for 6 doses, or MMF. But there is a change in 2021. This is a sea change. Now the dose of steroids has reduced. So kindly do not pulse the patient with 1 gram, which was earlier. You see a patient who is having active disease, even if suppose if it is class 4, activity index is pretty high, you see even crescentic lupus nephritis. The maximum IV methylprednisolone is 500 mg. It is not 1 gram anymore. In nephrology, we are now moving towards lower steroid. It was earlier 15 mg per kg methylprednisolone dose. Now it is 7.5 mg per kg. This is a sea change in nephrology. And why? Because we are seeing now more infections, more bone damages, more diabetes mellitus. And then oral prednisolone also, it's not 1 mg per kg, we are going down. And we'll have to go rapidly taper it off. And see, there is no NIH protocol now. It is either ELNT protocol or MMF. So kindly do not start NIH protocol unless guided by nephrologist. Unless say it is a very rapidly progressing crescentic lupus nephritis, NIH is out. That is another change. Now, so this is now what we are supposed to do. Methylprednisolone, as I told you, 250 to 500 mg per day, and then low dose prednisolone, and we have to start with other maintenance dose. Now, what are the 2024? This is 2024. In 2024, they have added voclosporin and belimumab to the armamentarium. So either you can go for ELNT cyclophosphamide, which is the standard of care, or MMF. MMF I would prefer, as I will show in the data, where it is working good for Indian patients. For voclosporin is not yet available in India. The main advantage of voclosporin is, unlike cyclosporin and tacrolimus, it does not require trough level monitoring. But it's a costly tablet, but I am pretty sure in 2-3 years it will be available in India and it will become the standard of care. Why cyclosporin is important? Especially because cyclosporin stabilizes the podocytes of the kidney. Therefore, the proteinuria is reduced. The goal is always to reduce proteinuria. In any kidney disease, the goal is to reduce proteinuria, nothing else. So that is why we are adding cyclosporin plus MMF or belimumab. We will see the role of belimumab further. And if there is unsatisfactory response to initial treatment for active, first thing, verify the adherence to treatment. Please do not directly jump to it is resistant lupus nephritis. Please verify the adherence. It is quite possible you have prescribed MMF to 2 grams per day. The patient must be taking just 500 mg per day. Why? Because MMF causes diarrhea. The patient is too shy to even tell you that she is having diarrhea. So please verify it. Always make it a habit to ask for the empty pills. The pill sachet. We have literally seen in transplant patient, we make it a rule. We always tell the patients, please show me the pills strips. Otherwise, we cannot be really sure whether the patient is taking. Then we can do drug testing, but that is fairly on a research basis. Repeat biopsy if there is concern for proliferation or other active disease setting it, and then you consider switching to alternative recommended treatment. And if finally it is refractory to first line regimen, then you have to add rituximab, extended course of IV pulse cyclophosphamide. This is where NIH protocol then starts to come. So that is the induction therapy. Now what about maintenance therapy? Once you have given induction, maintenance is reduced prednisolone. What is the first choice? MMF. It is changed. It is no longer azathioprine. It is MMF. Unless patient is not tolerating MMF, patient wants to become pregnant, other factors, then you can go for azathioprine. But AMS trial, which was lupus maintenance trial and maintain trial, they clearly said that MMF is superior. Then we have the Aurora trial. Aurora trial is for voclosporin. So we will see that later. And finally, if MMF or azathioprine is not tolerated because of GI side effects, then you may consider tacrolimus. If the patient has developed complete response to more than 12 months, you should stop even steroids. So earlier people used to keep giving steroids infinitely for lupus nephritis. I have seen prescriptions where even patient is 10 years into lupus nephritis, she is receiving steroids. No, KDIGO is very clear. Patient has achieved complete renal response. It is sustained for more than 12 months. Please stop steroids. And that is the only immune suppression which is stopped. MMF will continue. Now if it is class 5 lupus, which is membranous nephropathy, then again proteinuria. If low level, nothing. Monitor the level and prevent complications. Use anti-protective measures like RAS inhibitors, warfarin if required, and for edema diuretics. So, and if nephrotic proteinuria, then apart from that, you have to use MMF and steroids, and HCQ has to be given for everything. If proteinuria worsens, then we have to again biopsy and consider additional immune suppression therapy. Now, what is the definition for response to therapy? Complete response is reduction in proteinuria less than 500 mg. UPCR is sufficient. You don't have to even give it 24 hours. Stabilization of improvement of kidney function is plus minus 10% of baseline within 6 to 12 months of starting therapy, but could take more than 12 months. So please do not label anybody without giving an adequate trial of immune suppression. Partial response is reduction in proteinuria by at least 50%, but it is less than 3 gram, but it is more than 500 mg. And stabilization of creatinine with 10 to 15%, and within 6 to 12 months of starting therapy. So now we are seeing, if a patient has failed to develop even partial response up to 12 months of starting therapy, that is where you label that patient as not achieving response, and then you shift for alternative. So apart from this, there is a PERR, primary efficacy renal response. This was the BLISS trial which gave the new endpoint. PCR is less than 700 and DGFR is no worse. Then we will have to use for this is now modified. So earlier we said that less than 500 mg. ELNT said less than 800 mg. As now the BLISS trial is saying that if you achieve less than 700 mg, you are doing pretty well. So that is the thing. And what about in outcomes in India? What exactly happens? So these are the various studies which have shown. So this clearly says that in India earlier, see, this is a 2012 study actually. So at that time it was blindly IV pulse plus cyclophosphamide. So they used to achieve good remission, but people do not know what exactly happened afterwards. People then came with infections, malignancies and all. At that time MMF was starting to get introduced. So initially, therefore, all the physicians here used to, even some people even prescribe cladribine also for lupus nephritis. But now it has undergone a change. Now we compare MMF to IV cyclophosphamide. As you can see that it is almost comparable. It is almost comparable. So because cyclophosphamide causes malignancy in the long run, loss of cytopenias, MMF is oral. So therefore we are shifting to MMF. Now, these are the graphs which will compare that, and we can see that this is the ARMS trial which I was talking about. This clearly said that MMF is good as compared to the standard treatment of cyclophosphamide. Now, what is the pathophysiology? Quickly, I will tell. It is because of loss of self-tolerance and because of defective apoptosis. There is the failure of clearing of the dying cells, because of which the nitosis happens, because of which extracellular antigens are exposed, and because the body fails to respond self versus non-self. So we develop antibodies against it, and once antibodies are formed, then complexes are formed, and then interferon signature happens, and it is complemented mediated pathway. Because kidney carries the bulk of plasma serum in the body, everything gets deposited there, and once immune complex start deposition, the pathway towards fibrosis sets in. This is furthermore, this is the interferon pathway which I was saying. This is the dendritic cell, interferon alpha, which regulates that. So these are the various pathways where we can treat. The point of importance is the role of B cell here. This B cell is now becoming more functioning B cell. This is basically, it is, we have to somehow inhibit the role of B cell. Just depleting B cell won't work. Why? Because of the factor of Bliss or BAFF, B cell activating factor. If you are reducing B cell, the B cell activating factor is increasing. This B cell activating factor, whatever B cells are left, it will continue to act and they will become more longer in duration, and because of this, the rituximab primarily failed in primary treatment of lupus. That is why the Luna trial was a failure. Although rituximab is used in refractory lupus, the primary treatment is inhibition of Bliss factor, which is by belimumab. And now because we realized, and rituximab does not inhibit plasma cells. This rituximab only inhibits the circulating B cells. So obinutuzumab has now come up in a big way, which is a better suppression of B cell, and it doesn't act by complement mediated pathway. It is ADCC killing of the B cell rather than a complement mediating pathway. Already there is hypocomplementemia in SLE, so you cannot use rituximab to clear. So we'll have to use obinutuzumab. And the other roles of hydroxychloroquine, it is TLR anti-7 antagonist, MMF azathioprine, they all inhibit the immune complex formation. And this is the, once they develop the factor, so as I told you, once they go into kidney, inflammation starts. So there, this is the role of steroid. So you see, this steroid is a last role. Once the complex has generated, it has reached the kidney, it is preventing just the inflammation there. Now the treatment is to inhibit the formation of interferon, inhibit B cells. You block it at the upper pathway, not at the lower pathway, to prevent the overall progression of lupus nephritis. So that is why these new drugs have all come, abatacept, belimumab, obinutuzumab, and even bortezomib is being tried because plasma cells we have to inhibit. Now rituximab, this is what I was saying, that it was a failure when only 78% is there. So it was a failure, it was there, but refractory lupus, it is still working. So this is that is the difference between rituximab and obinutuzumab. See, it is moderate. That's a strong ADCC action is there for obinutuzumab. It is not yet available in India, but it will be available pretty soon. This is the latest trial, Nobility trial, which has said that obinutuzumab is giving good results. This is the phase 2 of that. Rituximab, as I said, this is the Luna trial. See, no difference in CR plus PR. Rituximab failed initially, now it has come up again in a big way. Rituximab, there they have initially given induction with MMF and then they have given rituximab. Now, treatment targeting B cells, this is what we have already covered. Now, belimumab, it is a bliss factor antagonist, so therefore it helps better and it is now recommended by FDA. Voclosporin, as I already told you, it does not require any monitoring. It's a very good comparative safety profile, especially more than 500 mg proteinuria, more nephrotic range proteinuria, voclosporin plus steroid plus MMF. Proteinuria less, belimumab plus steroid plus MMF. So this is the long-term, it is all saved. Now how cost effective you may see, this is the US data. See, they have said that lupus nephritis is a costly disease, I must tell you. It requires a lot of cost. If you do not treat it properly, you will probably end up spending more. You better treat it early with good immune suppression, you save yourself. Otherwise, once lupus nephritis sets in, you will start, every organ will deteriorate and you will have multiple admissions, multiple critical care admissions, and that is why. So this, compared to restorative and caps, belimumab was cost effective. Voclosporin is still not cost effective, but patent has expired for voclosporin. So I believe that probably in a couple of years voclosporin will help. What do Indian nephrologists do instead of voclosporin? We give tacrolimus. There is an MDT therapy. We do give tacrolimus. In fact, we treat lupus nephritis like transplant patients. No other disease in nephrology gets triple immune suppression except lupus nephritis. It is the only disease which gets triple immune suppression along with transplant patients. That is the importance of lupus nephritis. And as I told you, interferons we have to target. So anifrolumab has the newer drug which targets the interferon signature, and therefore, even though if autoantibodies are generated, they are not able to move forward. You are not able to stimulate the B cell and the T cell to produce the further damage. So this is the anifrolumab. This is the TULIP trial, so which has come up in a big way now. Now, what is precision medicine in lupus? This is what I wanted to emphasize. See, you see the second example, heartburn. Esomeprazole, we all give pantoprazole, esomeprazole whenever patient has chest pain. See, after how many patients, only one is getting really affected. Rest are all just placebo. So that is, and if you, on the other hand, if you see other newer drugs like adalimumab for arthritis and all, they have a higher precision. That means they are affecting far more. Because why? Because they are hitting the pathophysiology, they are hitting the biology of the disease. They are not treating the symptoms. So the modern concept is to understand the pathophysiology in greater detail and try to block the pathway at its starting at the highest level. We should not be, hitherto all the discoveries we were treating at the last level of the pathophysiology. Now the concept is we have to understand the pathophysiology in a greater detail. That is why I always tell my physicians, if you want to become a good physician, you have to understand the pathophysiology of the disease in great detail. Absolutely, and that is what is going to be the future of medicine. We are entering the era of target-based medicine, precision-based medicine. And see this infliximab versus esomeprazole. We may think infliximab is far more better than even that pantoprazole which we keep giving day in, day out. Now this is for the PGs. Why cyclophosphamide we give hydration and all? Because this acrolein is found. And this is the interferon signature which I was telling. So if you give in anifrolumab, 300 and 1000, the interferon signatures are respond. So last I want to, so the key takeaways from my thing, early diagnosis and treatment of lupus nephritis is important to preserve nephrons. HCQ is recommended for all patients if there are no contraindication. Class 1, 2 is immune suppression guided by extrarenal disease rather than renal disease. Class 4 is initial, I have explained, and glucocorticoid dosing is lower. 6 is long-term immune suppression is required. At least 36 months immune suppression is required. Class 5 is again guided by proteinuria, apart from routine measures. If there is unsatisfactory response to treatment, it can be due to non-adherence, but of course there are multiple problems, and now we have good medications because now we are targeting the pathways. If patient has ESKD, the kidney transplantation is slightly delayed in lupus nephritis. This is probably one of those diseases where we do not go for immediate kidney transplant. We wait till the lupus is burnt out. Unless the lupus is totally burnt out, we then go for kidney transplantation. Despite that, after transplantation, there is recurrence of lupus nephritis. That means that pathophysiology is still there. See, after transplantation, patient is on triple immune suppression. Despite that, patient is having recurrence of lupus nephritis. So that's a point. And in pregnancy, good pregnancy outcomes are possible with treatment of lupus nephritis, but that should be under treatment of nephrologist. We should achieve a complete response for at least 6 months prior to planning of pregnancy, and MMF cyclophosphamide should be stopped 3 months at least prior to pregnancy, and during the entire pregnancy, patient should receive azathioprine, HCQ, and steroids, and complete monitoring. ACE inhibitors can be stopped just before conception of pregnancy. It is a myth that it has to be stopped earlier. Even if the patient has conceived on ACE inhibitor, it is not a contraindication for MTB till the first cycle has passed. Right. So conclusion, current immune therapies fall short in providing lasting remissions. Newer therapies seem promising. Precision medicine may be the future. I rest my case. Thank you.
Thank you, Dr. Aditya. You are giving very excellent presentation on lupus, treatment of advanced lupus. But I want to tell all the physicians who are sitting here, if you have any patient having weird presentation, think of, especially young females, think of lupus and think of tuberculosis. These two things are very, very important. Unless you diagnose, you cannot send patient to Dr. Aditya. So be aware. Patient may go to psychiatrist with weird psychosis, patient may go to dermatologist, patient may go to gynecologist, patient may go to orthopedician. But physician is the one who has to recognize this weird presentation is because of SLE. And first thing you have to see that patient, whether the patient is having lupus nephritis or not. And then you send patient to Dr. Aditya. Thank you so much.
Yeah, I want to really emphasize that SLE is one of the answers in Vivas also. If you are stuck and you don't know what is the answer, please answer SLE. Like TB. Sir, yes, CAR T-cell therapy was introduced in 2024 for SLE. It has shown excellent results. It is the only therapy so far which has completely resolved lupus nephritis. It is coming up in a big way. Only challenge remains is financial considerations. Probably by the next decade, we may get CAR T-cell therapy which will cure lupus nephritis.
Now, like India and CMC Velorat, they are doing
Yes.
at 18 lakhs.
Yes.
So 18 lakhs, if you treat with voclosporin and all these drugs, you will spend more than that.
Yes, sir.
So probably now we are giving for liver transplant everything, we are giving 15 lakhs, 18 lakhs for even for TAVI and TAVR we are giving.
Yes, sir.
So CAR T-cell therapy, if it is affordable, we can.
We should, but so far CGHS has not approved. Once it is approved, probably we can go for that.
Thank you, Dr. Aditya, for an excellent presentation. Especially nice was the way you linked the different therapeutic options to the pathophysiology and which part of the pathophysiology you link the treatment to get the maximum response. So it was very well done, and I thank you very much. And I think without any questions, we can conclude this session.
Thank you, sir.
Thank you, sir. Now we'll felicitate our speakers. Request Dr. Raja Vijayaraghavan ma'am to please come up on stage. Request Santagan Guru ma'am to please felicitate the speaker.
So
Dr. Saisa to please felicitate the chairperson. Also is PCMD from Western Railway, West Central Railway. His areas of interest are health and family welfare and medical examination. He has 35 experience in railways and studied from IRS's batch 1990. Please come on to the stage to felicitate Dr. Savita Gangadhar. She is ex-ACHD and ex-HOD Department of Medicine and Family Medicine from Jagjeevan Ram Hospital, Western Railway. Ma'am played a critical role as a quality manager in NABN accreditation of JRS. Ma'am is from IRS's batch 1993 and Dr. Sarkar sir, Dr. Padma ma'am to please felicitate Dr. Sarkar sir. Sir is senior professor for health and management, 3 times recipient of GM Awards 2005, 2010, 2014, and sir is an outstanding contribution to Railway Health Service. Sir is from IRS batch 1993. SP Chaudhary sir. Sir is also professor in health and management. Sir is a recipient of GM Award and 3 times recipient of PCMD Award. Sir is from IRS batch 1997. Areas of interest are training and development of IRS and training of IRS professionals. Now, we'll continue the sessions. Tea is being served downstairs. So, delegates can please have a break as and when necessary. It's a working tea break. So, we'll proceed on to the next session. The next session, we request Dr. G.S. Ramchandra sir, Dr. NBBK Sai sir, Dr. Padma ma'am, and Dr. AVSK Prasad sir to please chair the next sessions. Prasad sir, please come on the stage. Dr. Sai sir, to please chair the session. Dr. Padma ma'am, to please come on the stage to chair the next session. And request Dr. G.S. Ramchandra sir to please come on to the stage.
At the outset, I feel very happy and proud that in this conference, we could give chances to so many railway physicians and railway super specialists as speakers.
In spite of so many pressures from the sponsors for their particular speakers, I stood to my ground and said, we are going to speak. And okay, you don't come as sponsor. In the worst case, I will do a webinar. But otherwise, my railway speakers will be the speakers. And all of them have done very well. I feel very happy today. Thank you so much. And this is the medical
examination lecture, physician's perspective. Next one. Next one, okay. And for the medical examination session, I also feel very happy that Dr. P.S. Prasad sir is here. And all of us know that, in fact, he has written the medical manual 2000. 2000 IRMM was almost done by Dr. P.S. Prasad sir, and I am very happy that when we are discussing the medical examination physician's perspectives, he is there in the audience.
A gentle reminder, please, all the delegates who have not done your registration process for today, please do go and register yourself, otherwise your credit hours will not be available.
Now, our next speaker is on adult vaccination, closing the immunization gap. So, request Dr. Kapil Sarde sir to please come onto the stage for his presentation. Chairpersons to please introduce his speaker.
Dr. Kapil Sarde, DMO, working in Central Railway Headquarters Hospital, Baikula.
He's a very good physician, and he's recipient of Central Railway GM Award 2023 and Devdut Award for work in COVID by Railway Running Staff in 2023. He's a medicine PG guide to numerous DNB students, his hospital being a center for DNB training in general medicine. He's the head of the Department of Medicine at Central Railway Headquarters Hospital, Baikula. He's also the National Secretary of the Association of Physicians of Railways, and he belongs to the IRHS batch to 2016, and with more than 12 years experience in railways, and areas of interest are infectious diseases, cardio-diabetic care, non-invasive cardiology, critical care, and neurology. Dr. Kapil Sarde, please.
Thank you, sir. Thank you, all the chairpersons for the kind introduction. So basically, from after diabetic kidney disease and SLE, this is a slightly lighter topic, but the topic which has got a vast potential and a topic which has been ignored for years, that is adult immunization. So we know that we have a universal immunization program for children, and it is widely implemented and it is sponsored by the government also, and we take UIP program very seriously, and we have seen the results of the UIP very well. But as against to that UIP, हमारे पास for adult immunization we have as far as healthcare professionals are concerned, as far as patients are concerned, or as far as policy makers are concerned, there is less awareness as far as adult immunization is concerned. तो हमारे पास एडल्ट इम्यूनाइजेशन के लिए बहुत कम ऑप्शंस है, या फिर हम उसको ज़्यादा प्रोपोगेट नहीं करते. सो एज अ हेल्थ केयर प्रोफेशनल, it's our responsibility to initiate discussion regarding adult immunization when a vulnerable patient comes. We think that the kids are only vulnerable, or they have a huge lifespan to live. But let me tell you that in few cases, when the age is more than 50 years and added comorbidities are there, in such cases, these patients can also become vulnerable. Few patients with comorbidities like chronic respiratory disease, chronic liver disease, chronic renal failure, patients with transplant recipients, all these patients, alcoholics, patients with diabetic even. So all these patients, they are at high risk for developing this vaccine preventable disease. So they also become vulnerable. So I will be focusing on major vaccine preventable disease, which are the major killers. Basically hepatitis A, hepatitis B, hepatitis E, then influenza, then human papillomavirus, then pneumococcal disease, and herpes zoster. So if a normal patient with hepatitis E comes, there is no problem. But if a patient who is having underlying CLD, chronic liver disease, who is in decompensation, he suffers an hepatitis A infection or hepatitis E infection, in such cases his mortality doubles, and there is a huge morbidity as well and mortality as well. There is escalated healthcare cost for such patients. So we have to address all this issue. Why adult immunization matters? It is because the immunity wanes after childhood, and there is a high burden of vaccine preventable disease in adults. Like I said, hepatitis E, hepatitis B, hepatitis A, pneumococcal disease, herpes zoster, and influenza. And this is a worrisome figure that adult vaccination coverage remains less than 2% despite achieving high childhood coverage. And aging and immunosenescence increases susceptibility, and it increases the burden of respiratory infection and non-communicable diseases. There is reduced morbidity, mortality, and healthcare cost, and there is a major preventive healthcare gap. So what is the current adult immunization landscape and challenges in India? As I said, there is low awareness among public. Even patients come to us that we need this vaccine. Very few patients, among even the diabetics patients who are more learned or educated, they only come to us when they say we need this vaccine. There is a low awareness among public, and there is inertia from the physician side to initiate the vaccine in the aged in the population more than 18 years or more than 50 years. There is inertia among the treating physicians also. Because patients have to bear the out-of-pocket cost for the vaccine, so they are less reluctant to take the vaccine. Then there is adult vaccine not stocked routinely. There is limited cold chain visibility. Then there is absence of national adult immunization program, vaccine hesitancy and misconception among the patients, and there is a lack of adult immunization records. We have seen in COVID that initially there was so much of resistance for the public, for the general public to come forward for the vaccine. But later on, after counseling, repeated counseling, and after repeated results, which were seen in the patients who had received the vaccine, COVID-19 vaccine, many patients come forward for the COVID-19 vaccine, and we could control the pandemic in a better way. And it is a good example of control of adult diseases with the use of vaccine. For hepatitis A, for classification purpose, the age group is basically classified into 18 to 49 years and 18 to 50 years or more than 50 years. And there are few groups of patients, that is at-risk individual, high-risk or immunocompromised conditions individuals, lifestyle-related problems, and special population. So these 4 points we have to see when a patient comes. At-risk individual is a patient who has chronic respiratory disease, chronic heart disease, chronic liver disease, and diabetes. Then high-risk or compromised individual are chronic kidney disease patient, nephrotic syndrome patient, hemodialysis patient, HIV patient, autoimmune inflammatory rheumatic disease patient, then malignancy, then recipients of hematopoietic stem cell transplant, patients of other organ transplants, then lifestyle related like alcohol use disorder and smoking, and then there are special situations like us, that is healthcare professionals, women of childbearing age, student travelers traveling to endemic areas, occupational exposure to animals, mass gathering, and occupational exposure. So for hepatitis A, these at-risk individual, high-risk individual, lifestyle-related, and special situation, all these categories we have to see when a patients come. And then key consideration among hepatitis A, it is a inactivated vaccine or it is a live attenuated vaccine. It is given at a dose of 0.5 ml, single dose. 2 doses are given 6 months apart. Then which are the patients who are to be given this vaccine are chronic liver disease, fatty liver disease, then alcoholic liver disease, and then this is most ignored, fatty liver disease. autoimmune hepatitis, and this is also one more criteria is that the rise in ALT/AST levels greater than twice the upper limit. This is also one of the key consideration. Then food handlers or who are exposed to the food or caregivers to high risk groups, HIV infection, MSM, then injection or non-injection drug use, person experiencing homelessness, then work with hepatitis A virus in research laboratory. Hepatitis A can also given with hepatitis B in a combined schedule. Then post-exposure vaccination is recommended in MSM and other high-risk situation in adults. It is contraindicated during pregnancy. Hepatitis A as such, it is recommended for age group from 18 to 49 years who are at risk. That is patients with chronic respiratory disease, patients with chronic heart disease, chronic liver disease and diabetes. It is lifestyle related, alcohol abuse is there. Then also it is recommended special situations like travelers traveling to endemic area and occupational exposures to animals. In those situations also it is recommended. From 12 to 18 years it is also recommended. It is not recommended during pregnancy for patients more than 50 years. There is additional risk of administration of this vaccine. Additional risk means there are chances because of some personal factors or because of some medical factors, there are chances that such patients may develop more adverse reactions, or such patients fail to develop a proper immune response to the vaccine. So in such cases there is additional risk, and in such cases we should exercise cautions while administering hepatitis A vaccine to such patients more than 50 years of age. Then hepatitis B, this is a recommended DNA plasma derived inactivated subunit vaccine. It is also given as a 0.5 ml dose in three doses schedule, that is 0-6 month. Recommended for pregnancy, at-risk patient, high-risk, immunocompromised, lifestyle-related special situations, and also recommended for adolescents 12 to 18 years. And there is additional risk while administering this vaccine to patients more than 50 years of age. And in this hepatitis B, a booster dose is required, recommended every 5 years for high-risk individual, that is immunocompromised healthcare professionals, individuals with chronic kidney disease, and patients on hemodialysis. Hepatitis E, again 0.5 ml 3 doses schedule, 0-1-6. It is recommended for patients more than 50 years of age. Among the patients who are between 18 to 49 years, at-risk individuals, it is recommended. High-risk individuals, it is recommended. Special situations, it is recommended. And it is not recommended for individuals between 12 to 18 years of age. Human papilloma virus, this has to be taken seriously because nowadays there are national guidelines also for the administration of human papilloma virus. It is not just for females. Even it is recommended to give the human papilloma virus for males also. So it is available in bivalent form, then quadrivalent form, and nanovalent form, which protects against all the HPV phenotypes. And it is given as intramuscular doses. Dosage schedule: girls beyond aged 9 to 14 years as a 2-day schedule, at least 5 months apart. And from age 15, if age is more than 15 years, a 3-day schedule is indicated. That is 1 to 2 months, and 5 to 8 months. So key consideration here are try to initiate discussion regarding the human papilloma virus vaccine administration before the first sexual intercourse. HPV vaccination is advised for all people that includes male as well as females up to age of 26 years, and depending on the age at the first immunization or the condition, 2 or 3 dose series is advised. At 15 years or older, at the time of initial vaccine, 3 dose series is advised. And for adults more than 27 to 45 years, based on shared clinical decision making, a complete 2-dose series or a 3-dose series is advised. There is again not recommended for more than 50 years, not recommended in pregnancy. At risk individual it is recommended, high risk it is recommended, lifestyle related it is recommended, and for 12 to 18 years it is recommended. Influenza virus, as we see yearly the strain mutates and the new strain comes up. So yearly it is recommended for the patients who are at risk, that is more than 50 years of age. It is a quadrivalent influenza virus, quadrivalent influenza vaccine, which contains inactivated viruses from 4 different strains, 2 type A strains, that is from H1N1 and H3N2, and 2 type B strains, Victoria and Yamagata. Then a trivalent influenza vaccine protecting against the 3 influenza strain, type 2, 2 type A strains, H1N1, H3N2, and 1 type B strain, Victoria. It is given annually, 0.5 ml dose. So more than 50 years it is recommended, pregnancy recommended, at-risk individual. This is the only vaccine which is recommended from age group 18 to 49 also, and it is also recommended for age group more than 50 years also. Pneumococcal disease, then the vaccine has come, initially the schedule was PCV 13, that is a conjugated vaccine of 13, followed by the polysaccharide vaccine of 23. Now the pneumococcal vaccine has come, PCV 20, which is given from in age group from 18 to 49 years with chronic medical conditions, at risk, high risk, immunocompromised individual, lifestyle or special population, or all more than 50 years. Single dose of PCV 20 will suffice. Previously vaccinated with any pneumococcal vaccine, single dose of PCV 1 year later. For patients who are vaccinated with PCV 13 or PCV 23 schedule, 1 dose of PCV 20 5 years after the last dose of polysaccharide vaccine 23 is recommended. For PCV, that is conjugated vaccine 13, and the other vaccine PCV 23, above 50 years PCV followed by polysaccharide vaccine 23 1 year later. For high risk or at risk individual, the duration of the second dose, that is PCV PPSV 23, is 1 year later. For more high risk individual, the duration can be shortened up to 2 weeks. Herpes zoster, again there is a direct correlation between cardiac patients who are having cardiac disease can have more risk of herpes zoster infection, and patients with herpes zoster infection are at more risk of getting a thrombotic event. So in which the relation is bidirectional. So this is a very painful disease, and we should always initiate discussion regarding this vaccine for people more than 50 years of age. So again, it is available in 2 doses, 2 to 6 months apart, and then recommended for more than aged population more than 50 years. At risk, it is borderline recommended. Then for population more than from 18 years to 49 years, it is recommended in high risk, immunocompromised individual, lifestyle related, and it is not recommended in age group more than 12 years and less than 18 years. We should think about the hospitalization cost, because the patient, if he suffers from herpes zoster, he will get hospitalized for at least 2 weeks. The hospitalization cost, the medicine cost, the stress to the family members, all these costs, if you consider the administration of vaccine and prevention of this infection, all these infections like pneumococcal pneumonia or the shingles infection, it is more economical and more beneficial for the patient. He will not suffer from the agony of the complications, like it can, in cases of herpes zoster patients, the patients can have post-herpetic neuralgia, which can persist for more than 3 months, and it is a very painful condition. So we should always give it a thought to, so that the patients are avoided from these complications. Then these are the recommendations for chronic disease patient for diabetes. All these vaccines are recommended: influenza, HPV, Tdap and TD, hepatitis A, hepatitis B, pneumococcal, COVID-19, MMR, varicella and shingles. For CLD patients, hepatitis A, hepatitis E, influenza, Tdap, pneumococcal, COVID-19, MMR, varicella and shingles. Then for patients with chronic heart disease, the same vaccines are recommended. For patients with chronic kidney disease, these vaccines are recommended. The same vaccines are recommended. For patients with individuals with cancer, as per guidelines, the vaccination should ideally precede any planned cancer treatment by 2 to 4 weeks. However, non-live vaccine can be administered during or after chemotherapy or immunotherapy, hormonal therapy, radiation therapy or surgery. The vaccines before chemotherapy which are recommended are pneumococcal, Tdap, H influenza B, hepatitis A, hepatitis B, hepatitis E and COVID-19. Then after therapy, the vaccines which are recommended are influenza, Tdap, influenza B, pneumococcal, COVID-19, MMR, varicella and shingles. Then for patients, recommendation for immunocompromised individuals. In general, most inactivated vaccines are safe for immunocompromised individuals, and these individuals should receive all age appropriate vaccine. For patients with hematopoietic stem cell recipients, vaccines like Tdap, hepatitis A, hepatitis B, influenza B, HPV influenza, then meningococcal conjugate, MMR, pneumococcal, varicella and shingles vaccine. For patients with solid transplant recipient, both donors and recipient should be vaccinated with pneumococcal vaccine, meningococcal vaccine, HIV, influenza, hepatitis A, hepatitis E, then shingles, typhoid, COVID-19. For HIV infection and other immunocompromising conditions, influenza, inactivated Tdap, hepatitis A, hepatitis B, hepatitis E, pneumococcal, HPV vaccine and shingles is recommended. For pregnant females, influenza, Tdap and hepatitis B is recommended. For healthcare professionals, which is important for us, we often ignore our own health. So annual influenza vaccine is recommended for healthcare professionals. Then typhoid, Tdap, hepatitis A, hepatitis B, hepatitis E, MMR, varicella and pneumococcal vaccine is recommended for all healthcare professionals more than 50 years of age. For travelers, vaccines are recommended for traveler for India travel to protect against diseases prevalent in the region and to prevent potential health risk. Routine vaccination ensure basic immunization, while other target specific infections like hepatitis A, typhoid, Japanese encephalitis commonly found in India, hepatitis B and rabies vaccine are advised based on the potential exposure risk. Cholera vaccine may be recommended for travels to outbreak prone areas. List of recommended vaccine are hepatitis A, typhoid, hepatitis B, hepatitis E, Japanese encephalitis, rabies, polio, meningococcal meningitis, yellow fever. Then recommendation for students traveling from India to international destination: MMR, hepatitis A, typhoid, yellow fever, rabies, meningococcal meningitis, poliomyelitis, cholera, COVID-19. These vaccines. For pilgrimage, mandatory vaccines are yellow fever and meningococcal and influenza for Hajj and OPV for Indian traveling to specific countries. Mandatory vaccine for mass gathering within India for everyone: typhoid, hepatitis A, hepatitis E, influenza, pneumococcal. Prolonged stay, hepatitis B and Japanese encephalitis. Mandatory vaccine for mass gathering outside India for everyone: quadrivalent meningococcal vaccine, influenza and polio. So upcoming few minutes for the upcoming vaccine, that is chikungunya vaccine is in the pipeline, dengue vaccine is the pipeline, then respiratory syncytial vaccine is in the pipeline, leprosy vaccine is in the pipeline, malaria vaccines are in the pipeline. So basically to summarize, opportunities are there within the healthcare system. There is a vast opportunity for the development of national adult immunization framework, and it has to be integrated with the national program, that is a non-communicable diseases program or geriatric health program. There should be inclusion of selected adult vaccine in insurance coverages. Then every clinic visit is an opportunity for discussion of these vaccine. among the vulnerable population. Adult vaccination clinics can be set up to address these issues. Then digital and technology tools, that is adult immunization card, digital health record, and reminders can be given. And healthcare workers' roles is physicians remain the most trusted source of vaccine advice. Strong recommendations significantly improves the uptake. Then strengthened awareness campaign. Healthcare organizations should invest in awareness campaign that educate adults about the importance of vaccine, and investing in robust public health campaign can help overcome the misinformation. Thank you.
One question, Dr. Kapil. We understood that COVID-19 vaccine annual booster dose.
Are you giving there any?
No. For only COVID-19, it should be as per the local guidelines. What are the guidelines given by the particular government? The booster doses should be according to those guidelines. It is not applicable to India as such right now, COVID-19.
It's only clarification I wanted, and it's a very good lecture covering the adult vaccination. Thank you.
How many patients of herpes zoster must have been admitted?
Every 3 months, sir, we at least admit 2 to 3 patients.
Of herpes zoster?
Herpes zoster.
I think, okay.
Every 3 months.
Mostly OPD.
Most of the patients are on the OPD basis, but who have got severe herpes zoster with complications, with secondary infections, who cannot be managed with oral medications, all such patients require hospitalization and monitoring also, especially this facial herpes or which is involving the herpes zoster ophthalmicus. All such patients, they require hospitalization.
Any take on dengue vaccine?
So dengue vaccine, actually it is US based vaccine is available, but which is effective against only 2 serotypes of dengue, that is 1 and 2. And one more, and it is it cannot be used in a treatment naive patients. So this is one vaccine that which is currently available, but one more vaccine is coming, that is DEC4, which is effective against all the 4 serotypes of the vaccine, 4 serotypes of the dengue, and it can be used in both treatment naive as well as infected patients. So that is added advantage. So maybe that vaccine offers a better prevention for dengue patients. The studies are there, it has shown efficacy. So in the trials it had shown efficacy. We have to see the real world evidence after that addition of the vaccine in the clinical practice. Pardon? Role of VCG, actually it is given in children only. So adult as such it doesn't have. Already the patients are infected, so it doesn't have any role in adult population.
We'll move on to the next talk as we are shortage of time. Any further questions? So Dr. Kapil will be glad to answer over lunch.
Thank you.
Now we move on to the much awaited session, I think, for all the physicians. Medical examination, a physician's perspective, Dr. Jyotsna Challa. I think this is one session where all the questions will be directed to the panelists rather than the speaker. Request the please chairperson to introduce the speaker.
Dr. Jyotsna Challa, she is DMO physician of the IRHS 2018 batch. She is recipient of GM Award 2024 for outstanding contribution to railway medical services and patient care. She is the main pillar of one of the main pillars of this conference and one of the main pillars of the general medicine department in Central Hospital Lalaguda. Her areas of interest are cardiac medicine and geriatric medicine. I was thinking you will write neurology also here, but you have not written. Cardiac medicine, I am happy to say that she is my student. She has learned very good cardiac echocardiographies and she performs now very nice cardiac echocardiographies. So over to Jyotsna. This topic is very important, medical examination, physician's perspective. from the daily working of our Indian Railways, because physicians are always overburdened with the whether he's fit or not. Kindly give fitness, kindly give fitness. We get all these requests from everywhere. So I think some senior physicians are also here. I'm happy. And last year the same topic was covered in Perambur, APRCON, but speakers were very good there. But unfortunately, what happened was it became an interactive session and this rhythm of the speakers were repeatedly interrupted. So the speakers lost their rhythm. I request all the delegates not to disturb the speaker during this talk. At the end of the talk, we will have a good interactive session. Thank you.
Thank you, sir. Thank you for your kind words. Good morning, respected dignitaries, senior faculty members, colleagues, and delegates. Today I'm going to discuss a very important but often the gray area of physician, that is medical examination from physician perspective. This session is not about the diseases, but about the patient safety, public safety, functional capacity, and administrative responsibility. Many of these situations are not clearly written in IRMM. So our real challenges is how to take a safe, ethical, and practical decisions. Thank you, sir. So our topic will be discussed in few sessions, like cardiology. In case of, in every topic, we'll discuss what is the risk factor and how the decision is being taken in a candidate and an employee. Coming to ischemic heart diseases, the main risk factor of ischemic heart disease, recurrence of the disease, and the safety profile. So these, as a candidate, if you find any ischemic heart diseases, they are unfit for appointment. As an employee, usually we avoid public safety related duties. So now the next question comes, is it all A? I mean, what we say public safety is like category A, A1, A2, A3, that is what. But as per IRMM, A1 and A2 is, they are unfit for A1 and A2. If the cardiac reserve is good, then we can allow them in A3. That is, like how do you assess the cardiac LV function is that by 2D echo. If LV ejection fraction is more than 50%, then they are fit in A3. If the LV function is less than 50%, then we have to assess and we have to give the proper treatment like GDMD treatment, and we have to reassess the patient whether any chance of improvement is there or not. If there is a chance of improvement, still we can wait for the time, we can give time for the employee with the treatment. And even after 6 months, we are not seeing any good improvement in the ejection fraction. Then the question comes, is it because of the myocardium, scarring of the myocardium, or the incompliance to the treatment? So that we can assess by doing a cardiac MRI. If you do a cardiac MRI and if you find completely scarred myocardium, the chance of LV function, improving of LV function will be very less. So in such cases, we can take a decision early saying that the chance of improvement is very less or remote. So hence a decision can be taken, they should be avoided a physical exertion also along with public safety. So the further decalibration of the patient from A to B will come at this session. And next coming to heart blocks. So all the heart blocks, the risk is syncope. So any patient having a syncope are not fit for public safety data like A. And as a candidate, they're completely unfit for appointments. And what happened if they undergo treatment like a permanent pacemaker? So they should avoid duties like avoid lifting heavy weights or climbing or giving a pressure on the limb where the pacemaker is being placed to avoid displacement of the pacemaker. So if you avoid all these duties, they may further decategorize to C and below. What happens if the patient undergoes post-AICD or CRT? So even in these situations, the candidates, as a candidate, they're unfit, and as an employee, they will go directly to sedentary duties. Arrhythmias. It is very clearly mentioned in IRMM that if the patient is having an AF, they are not fit for train working and passing, and they are given duties of sedentary duties. Next point of discussion will be SVT. What if patient is having SVT? Here the point is that when if you're having a single episode of SVT, that we say like paroxysmal SVT, then on a single episode, we need not decategorize the patient. So we have to see the high risk groups. Who are the high risk for having the complications and recurrence of SVT is that if the patient is having WPW syndrome, AVNRT, AVRTs, or very young age of onset. If these persons are having SVT, the chance of recurrence of SVT will be higher. So they should be given a chance that they should undergo EPS studies. If you have done an successful EPS and if you find out an aberrant pathway and if you're going to ablate the patient, the chance of recurrence of SVT post-ablation will be less than 1%. Successful, I meant to say successful ablation. So this gives us that if a patient undergoes post-EPS and RFA, and the chance of recurrence of SVT is less, except for public safety, the other duties can be allowed in these patients. Coming to aortic valve diseases, AS and AR, the risk is like syncope. The syncope occurs late in the disease in these categories, only when the patient is having some bicuspid aortic valve or younger age of onset like aortic root dilatation, the patient may develop AR. In these categories, we may take a decision early, directly decategorizing them in the early stages, but only when in severe AS or in AR in a young age group, the duties will be taken like they are allowed only for sedentary duties. In case of mitral valve diseases, the natural history of the disease is that even in the mild mitral stenosis, we are going to have an LA dilatation, which is a major risk event for the development of AF. So the MS is not the criteria for decategorization. It's the LA enlargement which is posing the risk of AF. AF is a risk for the decategorization of the patient, not the MS. So if we are having an MS patient with LA size normal, then still we can consider them as a mild disease only. Only if you're having a LA size more, LA enlargement, then we can consider that they are a high risk for AF, and the duties we advise them is like sedentary duties. And tricuspid and pulmonic valve, the same thing, functional capacity matters here. Like functional capacity in terms like functional, like we do a 6-minute walk test and NYHA classification and the risk of pulmonary hypertension. All this matters before we take up a decisions in these patients. Congenital heart diseases at appointment, if the patient has acyanotic heart disease and if they are corrected without any residual shunt, they can be taken into consideration. If they are having a cyanotic heart disease at the point of appointment, they are unfit. As an employee, if successful acyanotic heart disease being treated without any shunt, they can have a normal category as per the visual standards. There is nothing from our side. And only if it is cyanotic heart diseases, if it is corrected or uncorrected, they cannot go for routine duties. It should be given only sedentary duties. Cardiomyopathies. A case of DCMP, they should be directly given sedentary duties. As a part of employment, they are unfit for appointments. And what happens with post-PTC and post-CABG? Here the things is that we are treating the disease, not the risk factors. Suppose the EF is good, we can take the A3 and below. EF is less than 50%, like heart failure with ejection fraction. Then the decision will be as per improvement or not. Hypertension, as per IRMM, if BP is more than 140/90, it is written in IRMM that they are unfit for appointment, but due care should be taken in these patients because we maybe there's one point called white coat hypertension. It should be ruled out by doing an ambulatory BP or rechecking the BP after taking 1 or 2 sessions. And as an employee, except for alpha blockers, other drugs are being allowed. Coming to the topic of diabetes, here the question is like as per IRMM locopilates, it's only metformin 2 grams is being allowed. The main reason behind the allowing metformin in locopilates is the risk of hypoglycemia is less than 1% as per the literature. But with the advent of new molecules like DPP4 inhibitors, GLP-1 inhibitors like SGLT2, all these drugs are also having a risk of hypoglycemia 1 to 3%, but they are not taken into consideration. Maybe in future they may also come into the list of the drugs. At present, local pellets only metformin 2 grams is being allowed. A2, all the OHs are being allowed. Regarding insulin, the risk of hypoglycemia is like almost 30%. So there are some class of group of people, they say they allow in A3, and some others says it's like B1 and below. So it is as per the decision, case-to-case basis. CKD at the time of appointment unfit. And regarding as an employee, if they are on medical management, all the drugs are being given, which are given are allowed in all categories. Only if the patient is on a hemodialysis, the patient will be having an AV fistula, which pose the risk of they should not be using the hand for the routine duties. So these patients, they give sedentary duties, and post-transplant, they advise for light duties. CLD, here we have to assess only functional capacity, whether the patient is having recurrent decompensations or not. And we have to give an option of liver transplant before we take up a decision of invalidation. Coming to neurology, which is the most important topic of vigilance. Here there comes like CVAs. Any patient having a CVA, they are as a loco pilot like A1 public safety related duties, we are going to avoid them. And regarding other like A2 and below, we have to do a functional assessment. We have to give proper time for the patient to completely recover and do a complete motor neurological assessment, see what are the functional disabilities he is having, then assess whether what duties he can do, rather than just giving that, okay, C or B. You just have to know what is the functional capacity of the patient. Epilepsy, next important topic will be like epilepsy. So because the most common point of patient presents to us is like patient having a seizure. Do really they have a seizure? That we have to document it. Either we should have a video recording of the patient having a seizure, and it should be shown to a neurologist and make it clear that they are real seizures, not pseudo seizures. And we should have a neuroimaging like MRI brain with which shows a gliosis, and EEG, which shows the correlation of the gliosis and EEG recording abnormally. Suppose the patient is having a frontal lobe gliosis and showing a temporal lobe spike pattern. So it doesn't correlate both the things. So there is no meaning in combining these two. So there should be a gliosis combined with EEG abnormality, or we should ask them, the person go for video EEG to have a video recording with EEG at a center where we are more confident enough, like government centers or centers with 2 or 3 neurologists, before we take up any decision. Here the duties, because once a patient is branded as epilepsy or seizure, and the neurologist says that he requires a long-term AEDs, then directly the employee will go for sedentary duties, avoiding all the duties, like he'll be given a chair and pen. So next will be like whenever we see the case of any diseases, we have to make our neurologist, or we should write like that little scope of improvement and not to have a meaningful services before we take up for invalidations. And next will be topic of giddiness. Giddiness, also the common complaint, employee come to us having a giddiness, chakkar aaya hai, main gir gaya hai. So before we label that patient is having some pathological disease, they should have an proper evaluation to know what is the cause of giddiness. Is it cardiac, is it neurological, or is it because of BPPV or postural hypotension where we can correct with using medications, or is it malingering, before we take up for further. Next is Parkinson's. This is one more typical case what we have seen in recent. Parkinson's patient will have a typical classical symptoms like rigidity and fine tremors. So because of rigidity, they will not be doing a fine rapid movement activity. So usually they will be given sedentary duties. But the point of here is that they will not be doing a fine motor activity also. Suppose if you give simple like advice sedentary duties. So the person was given a duty like artisan, where they require the fine motor activity. So sedentary, simple giving a sedentary duties will not play the role. So we also have to add one more point, that they should be avoiding a fine motor activity, because whatever we say A, B, C, what we say as a fitness regarding the fitness categories, they are not big for the medical physicians. They are for the visual standards. Our things are we give a functional capacity whether the person can do this activity or not. Suppose a person, like if you say an artisan is a trained skilled employee who comes in the category of C, nothing but sedentary. But he cannot do any fine motor activity because the Parkinson patient cannot do any fine motor activity. So they cannot be given a duty of artisan. So the proper description of the disease is most important from the physician perspective to decide regarding which category or which job they are going to allot after the screening process. I mean, coming to rheumatology and all GI systems, with the advent of biologicals, the system has completely changed because now we are not seeing any deforming rheumatoid arthritis, right? And all these biologicals are allowed in almost all categories. So the point is here, when we see any patient of rheumatology like without any deformities, we can we do a classical functional assessment whether they can do the activity or not. And if he is able to see that okay, they are able to do all the fine activities, they can be sent for duties. Only if they have a deformities and their recurrence of flares are high, then the decision to be taken whether they should be undergoing AEMG or not. Next important topic will be OSS. With the advent of metabolic syndrome and obesity, the risk of OSA is increasing nowadays. So before we take up this, first we have to take the opinion from the pulmonologist whether the patient's really having OSA, like we do a polysomnography, sleep studies, advise them weight reduction, advise them CPAP and give a trial, and after complete weight reduction we again reassess the patient, and if they are able to come out of without any requirement of oxygen, then okay. If they're having continuous requirement of CPAP, the decision will be they should be avoiding complete public and personal safety duties. PLWHA, there is no discrepancy in view of PLWHA. There should not be any discrepancies in these cases. So all the duties are being allowed in PLWHA except if they are having a neurological deficit. Neurological deficit should be treated, not PLWHA. And psychiatry, there are letters from the, as per senior circulars, they should have at least 5 years of disease record and 5 years record from the superiors saying that they are having like mood disorders during their duty hours for the seniors, colleagues, and the CMD should constitute a psychiatry board. This is all taken because they should be ruled out from true psychiatric disorders and malingers. And regarding malignancies, when we diagnose any malignant patients, we do a functional assessment of the patient and like performance. Like there are many scoring systems for doing a performance status, and if you see the poor functional capacity, they should be given, and they will be given as light duties. And the point of invalidation will be considered only after completion of the treatment and if the patient is completely moribund. So general guidelines is we should have an adequate waiting period to allow the patient to completely get treated before we give a decision. So it's not like you take a decision within 3 months, 6 months. That is not taken into consideration. We should give proper time for the recovery, and we have to be sure whether the disease is progressive or is it non-progressive, and whether the disease is irreversible or reversible, because this matters. If the disease is reversible, we should give time for the completion of the treatment. If the disease is irreversible, then we can take a decision at that point of time and avoid invalidation during last year of service. And we should exercise caution in these cases like epilepsy, RPF, and during first 6 years of services, loco pilots, and because these employees will have a hard and unfavorable jobs. So before we take up a decision, there are 3 pillars. Know that not, because we should know, suppose any person will come with the duties like I'm doing technician, what technician he's doing. So what are the duties he's doing, what is the kind of work he's doing, and what's the disease he's having, and what's the functional status of the patient, whether he can do the job or not. Then his performance report from his superiors. So we should always ask a specialist opinion from in this, like whether the candidate is having like disease which is whether he can perform the duty or not. Malingering, if you have in any case of doubt, if you want to prove or disprove malingering, you have to take time and take a decision. So what are the areas of reform we request is like there should be something called temporary AMG, because suppose if I see a patient, a case of MI undergoing PTCA, the EF is very less, but we should at least have some sufficient time, not like exactly 6 months or so. We should give more time beyond the 6 months to allow the patient to completely treat before we take up any decisions. And there should be more description of the jobs rather than giving a category. So always discuss with the knowledgeable seniors, listen to your inner voice, avoid pressures, be cautious or good Samaritans, and don't keep matter pending. Thank you.
Very nice presentation, Dr. Jyotsna. So employees in the last years of service, that's a very important topic I wanted to emphasize. For so many years in my service, everybody used to tell there is nothing written anywhere, that employee in the last year of service should not be so easily decategorized. So I also was thinking that there is no circular like that. But about a year back, I don't remember exactly, either Dr. Harish Srivastava, retired PCMD, or Dr. Bharat Lal, present PCMD of Northern Railway. One of them posted the circular. It's a 1992 circular, I gave it to you also. It's on a Remington typewriter. So in 1992, the retirement age was 58 years. So they said that circular clearly states that when an employee is 57 years age, I think Dr. BCS Rao is here, he knows about that circular. We discussed about it once. So when an employee is beyond 57 years of age, care should be exercised by writing invalidation, because the entire concept of invalidation is like this. Suppose there is a 40 years of age individual with the common sense and point. Suppose 45 years individual not able to do any duty. Then his residual service is so many years, about 15 years. So in that residual years, he is an employee, he cannot do meaningful service. So his ward, who is a very fit person, can come over and take the job. That is the concept. So what is the point in invalidating last year of service or one day before service? Even so many pressures used to come from employees unions, this, that and all, that on the last day patients were kept pending for 1 year. Why are you not invalidating, not taking decision? And the last 1 month of service, last day of service, this invalidation file comes up. So clearly Railway Board also has given many circulars that no such cases should, this decision of decategorization and invalidation should not be kept pending beyond 6 to 9 months. That's one circular in serial circulars. And secondly, the circular which I am talking about, it says that in the last 1 year of service, that is 57 years onward in that circular, because 1992 it was 58 years of retirement, now it is 60. So we have to interpret as 59 years and above. In the last 1 year of service, only he has given for total invalidation for advanced malignancies and massive limb loss, not for other conditions. So this circular is there, it's in Remington, and I gave this circular to my CMD also, and it's a very good circular to counter such cases, she also commented. So Dr. Prasad is here, he is an expert in medical examination, Dr. Padma, another expert in medical examination. Any doubt I have, consult both of them. So I hand over the mic to the other chairperson.
Excellent presentation, Jyotsna. So we had elaborate sessions on medical examinations, and yet it is still a very big topic to be discussed and elaborated. I request all my learned seniors and colleagues to shoot out your questions so that we can have a fruitful discussion if it is warranted. Sir, please.
Can I have the mic, please? I think it's an excellent talk for the railway group of people and the railway group of doctors. But I feel that this topic can be discussed for 2 days. I don't think, because the time is up, so it cannot be. Even one slide, if I ask her to present, then that may take also 15-20 minutes of discussion.
Yes, sir.
So I think maybe, and one of the APRCONs should, I think, devote only on this medical examination topic, where we can have a full discussion and one can think of revising, because each disease, we are talking of all or none phenomena. Each disease has got a spectrum from mild to severe disease patients are being decategorized because of just for the circular, they are having a fight disease and they are unfit. I don't think that's the case. There is a case of AB block. You said all AB blocks are decategorized. First degree AB block, 0.22 PR interval, why he should be decategorized? He should not be decategorized. Right bundle branch block with no structural heart disease, why he should be decategorized? Patient, they should be seen to rule out any structural heart disease. If there is no structural heart disease, patient having a first degree AB block, patient having right bundle branch block, they should not be decategorized. I think there are long way to go for each disease. There has to be a clear-cut discussion. That's my, I think, Sai may respond to my saying.
Well noted, sir. We will have one webinar because we will have one webinar in medical examination with physicians' perspective after some few months. Second point is there's one circular about RBBB and all regarding local.
RBB is allowed. They are.
I think we have
Yes,
to
sir.
EP study, is it not?
Yes, sir.
Complete EP study. There's one serial circular.
Yes.
And new one said complete RBB will be made to a one free original.
There's one serial, I gave you one serial circular
Circular,
on RBB.
RBB.
There's one big list on where all, which asterisks, where all we should do a EP
Sir,
study and all.
if EP study shows an aberrant pathway.
No. Complete new one said complete RBB
Sir.
or LBB at any point of time. If in normal can be made fit in a or other than that circular new
Circular is there.
Only thing, sir, I want to know if we are making unfit for a candidate for a hypertension, which is completely curable, which is absolutely reversible also. But we are not doing simple ECG to everybody. We are not doing simple echo. Think of an adult dog. Think of a VAT. Think of a AD.
I agree with you.
And how can you make a person fit having a congenital heart disease? Simple do a echo, which take 2 minutes, 3 minutes, and you do ECG to everybody. You are taking a blood pressure and making unfit, but allowing a person which is severe hole in the heart, congenital heart disease, rupture of the heart.
She did not say
Absolutely wrong. The IRM should be changed and all
I think you misunderstood about candidates. She did not say make them.
No. I am telling in our practice. I am telling. Not what she
Don't
knows.
say that point. We can.
No.
Sir, actually, ECG is not part of first medical examination. But sir, in Lalagoda, whosoever comes, he said A, B, C. Whosoever we are doing ECG
Then
and
wrong. If somebody asks you and you do a ECG and find something, they will ask you, why did you do ECG? But so will the IRM. They will go to the court.
Yes,
Then
as per IRM, we are not supposed to do ECG for C.
For RPF, some people have done in PAB.
Yes.
There was a board letter that but one thing I can say for officers, we don't have after initial appointment there is nothing, no standard maintained. Because I know there was an officer, a secret officer whose vision was nil. And one fine day, GM asked for a medical board. He was a case of retinitis pigmentosa, vision was nil. So GM asked for a medical board. Asked for our year because there is no PME standards for officers. Then he has to be examined as per initial standard. So in initial standard also he is unfit. So we wanted to give him unfit. Then my PCMD told, no, you don't write like that, you write a letter to board. So we wrote a letter to board and as usual no reply came from board. So one fine morning, GM told, you make him fit. So he worked for another 2 years without any income. Yes, initial standard, when I looked at it here, during his appointment, his vision was there. But before that, he had a retinitis pigmentosa. He showed one paper. I just went through his paper. I got one. But you see, an initial appointment in an officer whose vision is okay, who is going to do a fundus? We are not going to do a fundus if he is not here. But retinitis pigmentosa can worsen during the years. So that has happened. So for officers also, at least physically we are sending letters to boards. Because there was another standard, somebody came for promotion from group A to group B.
So there the policy is that you have to write to the members of the board. If he agrees, then you will. So I wrote a letter. It didn't come back. This is recent times. It never came back, and their fellow came repeatedly, sir, you give me fitness or something, I have to appear in my interview.
No, I agree with you, Pradhan, all discrepancies will be there. But what I feel is, as chairman of Association of Physicians of Railways, this is very important topic. All of us should sit together and arrive at common guidelines, because there are a lot of vigilance angles into this. Of late, there are so many cases, vigilance cases, CBI cases related to epilepsy. You are having epilepsy seizure, his EEG is normal, his MRI is normal, he is having seizure. There are so many vigilance cases. And then also in diabetes area, a loco pilot who wants to go to duty, he takes insulin outside, he happily goes back to duty. And those who do not want to go to duty, even though they are only on metformin, they want decategorization, they bring outside reports that they are on insulin, and they claim that they are on insulin. So all these things are there. How many years our Harrison is revised? Every 4 years. How many years our textbooks are revised? Every 4 years. 2000 IRMM cannot cover all these aspects, because in the year 2000 that was the best book. So we all should sit together in 2026 and rewrite and add up some pages with the serial circulars, and then make up a common policy, because tomorrow any vigilance case comes against anyone, we should have some common guideline to be referred to.
Because one side vigilance is there and the other side court is there. In a candidate, when you are not doing, court is giving a decision. Regarding hypertension, you see, now we are making people fit in diabetes for every, if there is no target organ damage. For hypertension, no guideline is there, because nobody has gone to court. Because this decision regarding diabetes came after a court case. So for hypertension, because there is no court case, we have not done anything for that. No common nowadays. And I remember in a APRCON in Eastern Railway, when Dr. D.K. Das and Dr. Hariharan was there. So Dr. Hariharan told, if somebody is a hypertension, you have detected, you are making you unfit. But if he knows that, if he is a calling person who knows he is hypertensive and he is taking medicine and come, so he is making us fool and you are making them fit. So yes, after 5 months, 6 months, he come for a review, then he is fit. Even if you do a BPM. So that is the thing. So all these things, what we for a candidate, we make him unfit or something, or fit like epilepsy, we send it to AIMS or somewhere where you have even if you vigilance tell, you tell that AIMS, the premier institute has written that he is having epilepsy, he is make fit. So you have to keep your onus on somebody else in a properly governed setup, and where you can have something to defend. Because it is a government institute of repute. No, you are government institute, but you have a vigilance.
We will have discussion at lunch. We are having 2 more talks. We'll close this.
Not a single physician or the psychiatrist not willing to write or give an opinion of the patient. Even the eye doctors of the central hospital, they don't write to give an opinion.
My request to all senior physicians is,
आप नहीं भेजेंगे तो ठीक, आप विजिलेंस पेश कीजिए. I don't have any problem.
Sir, regarding that last year invalidation, I think I have got in Central Railway one circular, 1990 circular. You are talking about 98. It is 1990, wherein it is said GM is empowered for this.
It is there.
So the file goes to GM,
but
last signature is of GM.
My personal opinion is, please do not entertain junior physicians. My personal opinion is, please do not entertain last 1 month invalidations, last date invalidations and all. You will be in trouble. Everybody will get away, only you will be in trouble, I am telling you with experience. Let us close it here.
Sir, there is a letter in personal department book also that at least you should have 5 years of meaningful service left before we take up for invalidation.
They won't tell us because they have their own interest. They won't tell us. But junior physicians, take home message is, do not entertain these cases. Let them, you go on leave for 2 days, let that fellow retire.
Sure, sir. Sir, that is the reason we have asked for temporary EMG, sir. That is
Sir,
the point where we have asked
Sir,
for.
with due respects to all, we'll close the discussion here.
Sir, just-
Because last year also in Perambur, even the speaker was interrupted, they lost their rhythm. We'll discuss our lunch, Shishir, please.
Sir, no, sir, this
We'll
is just
continue
out
with
of
the
it.
next talk.
Sir.
Shishir, we'll have a discussion in lunch, please.
Okay. Thank you, everyone. Maybe as Sir advised, we can have a webinar on this topic on further days. Next topic is by Dr. KVS Harikumar. Request the chairperson to please introduce the speaker.
Ma'am, we can skip the introduction. I'm comfortable. Thank you. In the interest of time, it appears actually more of a homecoming. My apologies to chairpersons for starting. I served in Indian Army for 25 years. Such things actually keep happening. You will never reach a consensus. Be very clear. Everybody has some opinion to have. Only thing is you need to have guidelines. Everybody is entitled or interested or have that landmark document to fall back, okay? And you keep revising it. That is the only way to work in such scenarios, because what you do with hypertension, what you do with hypertension with retinopathy, we all face these problems, we all categorize. I mean, we dealt with soldiers, so that's how it is. Nevertheless, I'll move gears slightly. Integrating evidence into clinical practice. These are my disclaimers pertaining to this talk. These are my disclosures of this talk. You look at, there is something known as a GLP-1 tsunami going in the world as of now, okay? So it is like, what is the best possible way to lose weight and what are the options available and how do you choose evidence-based medicine in the current world? So we'll discuss some of the relevant cases. Janvi, who tried multiple times to lose weight and possibly have a difficult to control glycemia. Okay, why should you consider Monjaro for this patient? If you look at it, the approved indications for Monjaro, that is the tirzepatide, which is a GLP-1 as well as the GAP-1 receptor agonist, is one is type 2 DM who is not well controlled with the existing medications. Or if you are looking non-diabetic spectrum only as a weight loss agent, you require either a BMI of more than 30 or more than 27 with comorbid ailments, which includes all others, dyslipidemia, hypertension, all other things. Okay. Now you look at the trial data, which whenever you fall back and look at what are the spectrum, who have improved, all those things. Surpass is the one which looked at the entire spectrum of using the Monjaro in different subset of type 2 DM patients. You can use, it is used either as a monotherapy, as in comparison with semaglutide, in comparison with degludec, in comparison with glargine, in comparison with placebo, different ways. And you can see they're almost close to 6,000 odd patients across about 45 different countries who have used this, okay? I'll concentrate only on the Surpass 2, which compares usage of Monjaro versus semaglutide, the second injectable weekly preparation, which these two are the ones which are the weight loss agents or anti-diabetes agents as of now. Surpass 2 is the one what is being shown. You have 4 different arms, Monjaro 5, 10 and 15 depending on the gradual up titration, and semaglutide 1 milligram in a background of metformin, okay? And if you look at the primary endpoint, superior A1C reduction when compared with semaglutide, all the 3 strengths of your Monjaro have shown a more A1C reduction, and you can see that more number of patients achieved normoglycemia, almost 51%, that is half of the patients whom you have used have actually reached non-diabetic status. So that is important to understand. And you have sustained weight loss, which is almost close to 13% at the end of 40 weeks. So you can have gradual weight loss, and all 3 doses of Monjaro has given you a more weight loss than when compared with the semaglutide. This is as far as how many percentage of patients who have achieved 5, 10 or 15%. And if you compare onto your right side, the weight loss with the Monjaro 15 milligram is almost close to 40%. Okay, so you can see though much patients who have received their weight loss targets. And obviously, if you lose weight, your waist circumference also comes down. And again, there is almost a significant dip in the waist circumference of close to 10 centimeters, which is a huge number if you look at it. And that is why this data to say that what is the composite endpoint, how many would reach the composite endpoint of having a weight loss, of having a A1C normal, and having no significant hypoglycemia. That is what whenever we manage patients with diabetes, we want their A1C to be good, we want their weight to go down, and we don't want them to have any problems. So if you look at it, 60% of patients who have used Monjaro 15 milligrams have got this objective as a composite of all three put together. Okay. I will try and go fast. One, interest of time. Two, to have some questions from audience. Okay. Adverse events, if you look at it, most of the GLP-1 based therapies have got the GI based adverse events. There is not much of other adverse events which I'm sure some of you would have seen in the WhatsApps, but those are not there in the published evidence. Important thing, somebody you need to go slow when you are up titrating the dose, and GI side effects are the commonest ones. It can be either nausea, vomiting, or it can be constipation, it can be diarrhea, it can be burping, it can be flatulence, some of those things. Okay. And incidence of nausea, if you see over a period of 1 year, you can see the graph. I'm not sure, you will not be able to see, but the severe ones are only restricted to about 7 to 10% of patients. So this is as far as the SURPASS-2 data, which looked at the management of diabetes with the use of a injectable Monjaro, which has shown superiority over semaglutide of 1 milligrams dose. Now we'll come to plain and simple obesity without diabetes. Okay, this is again a hypothetical case, Anjali, who looked at trying to lose weight. I'm sure most of you would be having some of these either in patient profile or in your relatives profile, who always says whenever you meet, you say, I've been trying for last 15 years, I have not lost. So that is how these people will come. And why should you consider a weight loss medication for them? Again, mind you, the indications are very clear. It is if you are looking at only as an anti-obesity agent, as of now approved indication in India is BMI more than 30 without any comorbidities, BMI more than 27 if there are associated comorbidities which include prediabetes, dyslipidemia, OSA, all those things. SURMOUNT is an acronym which looked at the use of Monjaro in only obesity spectrum. SURPASS is predominantly in the diabetes spectrum, SURMOUNT is in the obesity spectrum, and here again there is different comparisons versus placebo in patients with obesity or overweight, SURMOUNT 1, SURMOUNT 2 is with overweight and diabetes, SURMOUNT 3 against comparison with the intensive lifestyle, which all of us do have to emphasize whenever we are prescribing them, and what happens, SURMOUNT 4 maintenance, reduction, all those things, and SURMOUNT 5 is versus semaglutide. Again, the active comparator, as I said, there are only two molecules which are widely available, widely being used, only these two. Okay, so the comparison of Monjaro with semaglutide in SURMOUNT 5, again here the difference there was we have used only 1 milligram semaglutide, that was a highest approved dose for a type 2 DM. But for a weight loss indication, you have 2.4 milligram as the highest approved dose, which has gone up to 7.2 milligrams a couple of months back. So you have comparing the highest possible dose of Monjaro of 15 milligrams, highest possible dose of semaglutide, that is 2.4 milligrams. So you have active comparator, highest possible dose to remove the bias of an individual using one arm less or one arm more. So if you see 40% higher mean weight reduction with Monjaro compared to semaglutide maximum tolerated dose. So maximum tolerated, you keep escalating the dose in the clinical practice. It can be 5, it can be 7.5, it can be 10, whatever be the maximum tolerated dose, where the patient is getting the benefit, that is the time you need to use and stop. You can see that people who have used Monjaro have lost more weight than when compared with the semaglutide maximum tolerated week 72, 1 in 3 patients have lost more than 25% weight. Okay, so that is every third person, which is fairly good number. And mind you, that is why in the last 3-4 years, the bariatric surgeries have gone down tremendously courtesy these drugs, because earlier we used to get only these results with the only bariatric surgery, conventionally sleeve. The Roux-en-Y is not that widely done in initial stages, but sleeve used to give about 15 to 20% weight loss, which these drugs would give you in 1 year of continuous usage. And superior reduction of weight circumference reduction of almost about 20 centimeters reduction of using Monjaro at the end of 1 or 1.5 years. And you can again the maximum tolerated dose. The safety profile is the same. There is not much of a difference. It is only the gut related issues which the patients have to be educated, and you need to handhold initially whenever you are prescribing, so that they are able to take the maximum dose properly. And this is the first and only GLP GIP RA. The semaglutide has got only GLP-1 receptor agonist properties. Here you have both GLP as well as GIP receptor agonist. Proven superiority over standard of care. In persons with type 2 DM, you have superior A1C reduction, and 51% of patients have achieved normoglycemia. And in persons with obesity, 40% greater relative weight loss and 20 centimeter reduction in waist circumference. Okay, so it's a huge numbers. So somebody who have not used, this is Monjaro to start with is a 2.5 milligrams for 1 month. Each pen comes with a pre-filled 4 doses pre-filled in them. So you will start with 2.5 and you will go up to 5 milligrams. You can maintain at 5 or you can use the subsequent dosages depending on whatever is the necessity. Okay, as I said, based on the tolerance, based on the weight loss. There will be a plateau phase at every point of time whenever you are trying to lose, but you need to overcome that set point whenever you have to use them. Okay, individualize beyond 7.5 up to a maximum of 15 milligrams weekly dose. Okay. Special populations, not much of an issue. The only absolute contraindication is beyond pregnancy and lactation is somebody with a history of medullary thyroid carcinoma, somebody with a past history of pancreatitis. These are the 2 situations where we don't go into this area. So otherwise, most of the other places, they would be better, and you will have more data emerging as far as the cardiac protection, renal protection, liver protection, all those things are common. So you don't actually have to stop if other patient has got any of these other comorbid ailments. Pancreatitis, as I said, you need to be careful. Pregnancy and lactation, no. Renal impairment, generally not a contraindication, but considering the nausea and vomiting as a side effect, you just need to be a bit more careful, and you don't hardly find anybody who is a very obese CKD. You'll find some, but not very much. Okay. So these are some of the advices which you should give to the patient in the initial stage, especially in the first month of the starting of therapy. Eating small portions, eating only when required, drinking more fluids, having more of spacing out the meals rather than stuffing at one time and then waiting. So all those things are important whenever you start. By and large, when you inject today, the side effects, peak side effects of the gut related are on the 3rd or 4th day. So you need to generally educate the patient about using them on either on a Thursday or Friday, so that even if they have a gut related side effects, they can actually handle them during the weekend. And what to do in case of a missed dose, this is my last slide. It is important, these are weekly preparations. Okay, so if you have happened to miss the dose, within 4 days, if you happen to reach your destination where you can take again, you just use and then go back to your next dose as per schedule. But if you have missed completely, then you go to the 15th day, that is 1 week later only, you take your next dose. So that is important. By and large, it gives you a plus or minus 2 days cushion where you can inject, because it's a weekly dose. If you are traveling out, you need not carry this pen. Maybe you come, you take a day prior and go, or you come 2 days later and then take also. You will not lose out the efficacy of it. I have finished here. Any questions or comments, I shall be happy to take.
Thank you, sir. Very nice talk. You finished ahead of time. Any questions?
Yes, ma'am.
One thing, I think these are very good drugs, no doubt. But I think one side is the rosy picture about the weight loss. The other side is weight gain after you stop the drug. I think both the sides should be explained to the patient very well before starting the drug, because we start the drug, patient loses weight, he's happy, we discontinue the drug, and then patient again gains weight. He has lost all the money. So I think one should be told very clearly that they have to have the lifestyle modification from the very beginning, and if they discontinue it, they are going to gain weight and they will lose all the money. I think that should be told very clearly.
Yeah. Absolutely correct, sir. I'll just slightly modify to your prescribing the drug. So that is number one, mandatory. Just because somebody is taking a drug, they will not lose weight unless they follow the diet and lifestyle, number one. Number two, the weight regain, whatever is happened, it is not 100%. Even some of the studies have shown that 15 to 20% regain does happen when you stop the drug. There are enough evidence to it. It is not that they gain 100% back. As I said, when you are going up also there is a plateau phase. When you are going down also there is a plateau phase. The hypothalamic set point will reach to a certain level where you don't tend to gain more or lose more. So that is why if you try and suppose somebody comes with 100 kgs, you keep him at 80 for 1 year, it is very difficult for him from 80 to go back to 100. He will go to 85. So that is what these drugs do. Yes, ma'am.
Sir, I have one question. When you are using semaglutide versus Mounjaro in diabetics, don't you think considering the MACE reduction, semaglutide will be a better drug in diabetics?
Absolutely. See, as of now, the cardiovascular label is only with the semaglutide. But as I said, the cardiovascular label is with semaglutide because there is no dedicated study with the tirzepatide. But the root cause is, like sir said, it is a weight loss. The moment you have weight loss, your liver will be good, your heart will be good, your kidney will be good. Who is giving you the maximum weight loss? The maximum weight loss the Mounjaro is giving.
Sir, one more thing I have observed, I have used both the drugs. In postmenopausal women, the effect of weight loss with both drugs is little less. I don't know whether you have observed that. Second thing, if you are going from 2.5 to 5 to 7.5, from 5 to 7.5 there is not much weight reduction in Mounjaro, but 5 to 10 there is more weight reduction. The 5 to 7.5 the dose it is little costlier, 7.5. So if you are not getting enough weight reduction response, and if the patient is not tolerating 10, I feel like it is better you go back to 5 because the weight reduction effect is same. This is what I have observed. Like I have
I agree. On podium, I can only speak what is the evidence-based medicine. But in practice, things are different, okay? Because there are multiple ways how people do the escalation or de-escalation. But as I said, you need to document the weight loss. There is a plateau. As long as you are not in that plateau, you need not escalate also, because that's why that individualized slice is important. If somebody is losing at 2.5, which we don't generally expect, there is no point going to 5 milligrams. You're absolutely comfortable in continuing 2.5.
Thanks.
If somebody is a lean diabetic, you are not able to control with your regular drugs like and the GLP-1 are being here. So with GLP-1, because I don't want a weight loss there. Because he is a lean diabetic, he does not have a obesity related complication. And with GLP-1,
See, the GLP-1, any GLP-1 will be best as far as the anti-diabetic potency is concerned. Other than insulin, this has got the best A1C reducing capability. Depending on your affordability and availability, you choose any of the GLP-1 molecules which are there for diabetes control. Both have got equally shown equal efficacy as far as the A1C reducing capabilities are concerned. See, he will not have that much weight loss in a normal weight individual. That is why in type 2 DM indication, it is nothing to do with BMI. It is difficult to control with the existing drugs. You can straight away go to GLP-1 depending on whatever is the use. You are not going, if suppose somebody has got BMI of 21, he will not go to 18 with this. He will at the max become 20.8, that's all.
So what is triple incretin is on the horizon. When do you think it is going to be lost, triple incretin, and what is your view on muscle gaining drugs? Sarcopenia is an issue. Triple incretin plus basogrumab or something is there, which is now being latest trials. US phase 2 data has come out. And what is your experience with Monjaro with irritable bowel disease?
Okay, see, triple drug phase 3 have completed retatrutide, which will likely to come somewhere end of 27 or maybe 28, number one. As far as the sarcopenia and muscle loss, whenever you lose weight, irrespective of whatever be the modality, be it your diet, lifestyle, drugs, surgery, there will be a portion of fat, a portion of muscle, a portion of fluid which will go from your body. Now the idea is you need to lose more of fluid and fat and preserve some muscle. So in that bargain, those those things have been tried, but that has been stopped because of the side effect profile. Conventionally, we advise resistance exercises, adequate protein intake. Unfortunately, none of us take 1 gram per kg daily intake. If you advise resistance exercises and adequate protein intake, you would have done wonders to the patient. You don't require any fancy protein powders. We don't subscribe to them much. Just regular exercise, which is part and parcel of your prescription along with your drugs, along with some physical activity. Aerobics will give you fitness, but resistance will preserve the muscle. So you need to put some weightlifting, some yoga postures, all those things are also important.
Irritable bowel syndrome and...
Thank you, Dr. Harikumar sir. We will proceed on to the next topics.
Thank you, ma'am. Thank you. Thank you.
We welcome our next speaker, Ms. Haripriya Rajaram. We welcome you. She is our daughter. She is the daughter of our PCMD Madam Nirmala Rajaram. She has done MDS in periodontics and implantology, and she is now working as assistant professor at Mallareddy Dental College, Hyderabad. Over to Haripriya.
So, good afternoon to everybody present here. Thank you, first thing, you all are sparing your lunch break and listening to me talk. So, I would like to thank you for that. So, the topic that was given to me was oral manifestations of systemic diseases. But you know, that is quite a wide topic and I could talk about it all day. So, I thought to narrow it down to one specific topic. So, I thought I'll talk about diabetes and periodontitis. So, yeah, let's start. So, I need not tell you what diabetes is. So, I'll start by telling you what periodontitis is, okay? So, first thing, what is a periodontium? So, everything that surrounds a tooth is called a periodontium, okay? So, that includes our gums, the bones, the periodontal ligament. And any infection or inflammation of the periodontium is called periodontitis. Okay, so the periodontitis is one of the leading cause for tooth loss. So suppose if a patient comes to you with a mobile tooth, you know the diagnosis, it's periodontitis. Okay, now how does this periodontitis occur? So this periodontitis is actually initiated by a group of microorganisms. So there is microbial plaque deposit around the tooth that initiates periodontitis. Okay, next thing, does periodontitis occur in all individuals? So suppose I take two individuals, okay? Two individuals of the same gender, same age, same socioeconomic status, okay? But one individual develops periodontitis, whereas the other individual does not develop. What do you think? Why do you think that one individual developed the disease where the other person did not? Okay, so I'll answer. So the person who developed the disease basically was immunocompromised, okay? So if a patient is immunocompromised, like any of the diseases, if the patient has any systemic condition, one reason mainly being diabetes, the patient is more prone to develop periodontitis, okay? So that elaborates what periodontitis is. Periodontitis is basically the inflammation of the periodontium. It is caused by microorganisms. It is initiated by microorganisms, but it is sustained by an aberrant host immune mechanism. So in my topic for today, in my lecture for today, I'm going to show you a few cases, few patients who came to me who had diabetes and periodontitis. Some patients were aware that they are diabetic, some patients were not aware. Okay, so all of you know what are the manifestations, the symptoms of diabetes, okay? But do you all know that there are a lot of oral manifestations of diabetes as well? So, you know, a lot of times when patients come to us, they have no clue that they are diabetic. Okay, they just come with some specific or non-specific oral complaint. Like some patients will come with saying, I have bleeding gums. Some patients say that my gums are swollen. Some patients say that my salivary flow has decreased. Some patients say that I have recurrent infections. So all this are actually the oral manifestations of periodontitis. So you all know what are the complications of diabetes, right? We have nephropathy, retinopathy, macrovascular diseases, altered host, altered wound healing, diabetic neuropathy. Do you know what is the sixth complication of diabetes? It's the topic that I'm talking about. It's periodontitis, okay? So the sixth complication of diabetes is periodontitis. So it has been proven that diabetic individuals are 3 times more prone to develop periodontitis than a non-diabetic individual. Okay, so now I'm going to show you a few cases where the patients have come to me. Some of them knew that they were diabetic, some of them had no clue that they were diabetic. Okay, so this is the first case. This patient came to me when I was doing my PG. Patient's complaint was very simple. Patient complained of bleeding gums. You can see that the gums are swollen, red. Okay, there's also a periodontal abscess there. So that's it. That was the complaint of the patient. So what did I do? So first thing that I did was just do a normal basic scaling, that is professional cleaning that we call. Okay, so I did the scaling. Then when I checked the x-rays, I found that there was some amount of bone loss. And this patient required a surgical intervention. Like any other surgical intervention, I require blood reports for the patient to do a surgery. So I asked the patient, go get your CT, BT, CBP and HbA1c levels done. When the patient came back to me, with a HbA1c report of 7.2. That's when I realized that, okay, this is not just periodontitis, it is also, patient also is diabetic and patient is unaware. So then I asked the patient, go to your physician, get medications for it, and then visit me again after 3 months. Patient came back to me after 3 months. Now his HbA1c was 6.8ish something. Then I did a procedure called laser curettage. Now what is laser curettage? It's basically removing the infected gum tissue with the help of a laser. And then you see 6 months post-op. It doesn't even look like the patient's own gums. Like, see the difference. The first time when the patient came to me, patient's gums were red, bleeding, swollen. And after 6 months, it was like this. Now, do you think this is only because the exceptional work of the dentist, or do you think it's because of a comprehensive treatment where patient got the medications and got the dental treatment done? Okay, so some of you might argue, some of you might think that it is only because of the dental treatment and diabetes has nothing to do with it. So, my next few cases, I'm going to show you where we did our best treatment, okay, but the patient's blood glucose levels were not under control and hence the periodontal status did not improve. Okay, now see the second case. You can see that the gums are swollen. So now this patient's complaint was again very basic. Patient came with a complaint of swollen gums, okay, and patient is a known diabetic. His HbA1c was 8.2. What we did was first thing basic periodontal treatment, that is scaling and root planing. We did that. Patient came back to us after 1 month. Generally after 1 month the periodontal status should improve. But when the patient came back to us, it's again the same thing. Then that's when I realized that okay, only periodontal treatment is not going to help this patient. I asked the patient, go back to your physician, get your medications changed, higher up your doses and then come back to us. Now next case, again in this patient, you can see that there is a periodontal abscess there. Now this abscess was drained twice. Okay, this is again a patient of known diabetic. He's been diabetic for 4 years now and his HbA1c was 7.9. This is the X-ray. So the X-ray clearly shows that there's a lot of bone loss and especially in this area where there's a periodontal abscess. So for this patient also again, after draining the abscess twice and giving systemic antibiotics, generally the periodontal status for a non-diabetic individual improves. But for this patient, it did not. And for this patient, I have to do a surgical intervention, right? So I asked the patient, just go back to your doctor, get your HbA1c levels corrected, and then only we can do the procedure. This is another case where this patient is 65 years old, came to me with a similar complaint of swollen gums. You can also see a gingival polyp in that area. For this patient, again, I did a scaling and root planing, thought it would improve in 1 month, but it did not improve. So again, asked the patient to go get her HbA1c levels corrected. This is her radiograph, which shows severe bone loss. So why is it that patients with diabetes have a higher risk of developing periodontal disease? So let's see that. So there are three main things that happen in a diabetic individual. One thing is bacterial dysbiosis. Now, in a diabetic individual, we see that the local environment is so good for the bacteria to grow that the bacteria causing periodontal disease start growing in that environment. First thing. Second thing, we all know about the advanced glycation end products. Now, when these advanced glycation end products act on certain cells, the cells start producing more amount of inflammatory mediators, creating a hyper-inflammatory environment. Okay. Third thing, we know that the advanced glycation end products, when they cross-link with collagen, they basically hamper the collagen turnover, causing periodontal destruction. Third thing, also we have known that neutrophils are defective in diabetic individuals, so that makes the bacterial clearance a little more difficult. So because of all these reasons, patients who are diabetic are more prone to developing periodontitis. Now I also told you that periodontitis also has an influence on diabetes, okay? So how does that happen? So there are a lot of systematic review and meta-analysis where they have seen that a person who is people who are having chronic severe periodontitis and uncontrolled diabetes, in such individuals, when you do a periodontal treatment, the HbA1c level improves. Okay, so I picked this up from one of the systematic reviews where you can see that at baseline the HbA1c was 9.2, then at 3 months it became 8.5, and in 6 months it became 7.4, and this is because of periodontal treatment. So how does that happen? How is it that chronic periodontitis is worsening the diabetes status? Now, like I told you, periodontitis is an inflammatory condition. So during inflammation, what happens? A lot of inflammatory mediators that are released. So now in periodontitis, the inflammatory mediators are just not increased locally but also systemically. So because of this increase in systemic inflammatory mediators, that results in impaired, that worsens the insulin resistance, worsening the diabetic status of the individual. So, when we do a periodontal treatment, the inflammatory load decreases and the diabetic status improves. So, what are the clinical management strategies for this? First thing is integrated screening. That means every time a patient comes to me with a chronic periodontitis, I will always ask the patient to go get his blood sugar levels tested. Second thing, interprofessional referral. So, if a patient comes to me, I refer to you. If a patient comes to you, you refer the patient to me. Third thing, frequent maintenance. I advise all the diabetic individuals to go to visit a dentist for at least once in 6 months to get a oral checkup done, and at least once a year to get a professional cleaning done. Fourth is the adjunctive therapy. That is sometimes just scaling and root planing. That is the basic periodontal treatment that we do will not be enough. In such cases, we do additional periodontal treatments as well. So to conclude, diabetes drives periodontitis, like I said, and periodontitis drives diabetes. Thank you.
Excellent presentation, Dr. Haripriya.
Very nice. We often neglect the oral hygiene. Like you said, it is very essential. Thank you.
So one more thing is important. These diabetic patients kindly take the history of hypertension as well.
Yes.
Especially if they are on calcium channel blockers.
Exactly.
They may have.
Yes, correct. Gingival hypertrophy. Yes, very correct. Yes. Yeah, we can recommend mouthwash, but the thing is what, mouthwashes cannot be given for more than 15 days because mouthwashes also come with a lot of adverse effects, yeah. So for that reason, Yeah, for oral dysbiosis, definitely we can use mouthwash, but not for a longer period of time. Yes, yes, yes. Yes, both are chronic inflammatory conditions, so that is the reason they have good linkage.
I have a question, Dr. Haripriya. How often do you ask the diabetic patients to come for oral examination as a dental examination?
Yeah. So, diabetic individuals, we should advise them to come for a dental screening at least once 6 to 9 months and get a professional cleaning at least once in a year.
Thank you. I request the chairperson to felicitate the speaker. Other speakers also, please. I call upon Dr. Kapil Sade, sir, please, to come onto the stage. Dr. C.H. Padma Madam is CMS Hyderabad. She belongs to 1993 ARHS batch and she has got more than 31 years of experience in railways. She is very good medical examiner. We used to, any doubts in medical examination, we used to go to her and she readily helps us in clearing all the cases, even long sick also. ARHS batch 1995. He has worked in various capacities and he worked almost for 12 years in PCMD office and he is also a very expert in medical examination. And he has conducted so many conferences regarding medical examination in our zone. Thank you, sir. Session. We will break for lunch and we'll have 4 more talks after the lunch. I request all the delegates to stay back after the lunch. Yeah, we will 2:30.
Me just recollect the definitions. What is INH resistance? Any biological specimen resistant to INH or isoniazide. Monoresistant is single drug. Multi-drug, both INH and rifampicin with or without other drugs. Okay. Pre-XDR, MDR, RR plus resistant to any fluoroquinoline. Extensively drug resistant, same MDR plus fluoroquinoline plus at least one of the group A drugs, either bedaquiline or linezolide. If you remember these things, our subsequent discussion would be easy. So why we are very much worried about MDR TB? Because the response is not good. There is longer course, usually 2 years, up to 2 years. So there is high pill burden, and these pills also very much toxic, and financial constraints also. Because of all these factors, treating MDR tuberculosis is very troublesome. So what is the purpose of treating the MDR TB is, first of all, we have to break the chain of transmission and to decrease TB related deaths. So what WHO recommends is all MDR patients should benefit from oral regimens. Even this also being adopted by our government, National Tuberculosis Expert Group under National Tuberculosis Eradication Program. They also adopted all oral regimens. Now no more injections. So in that 3 regimens are there, that is BPAL regimen, 9 to 11 months shorter oral regimen, and 18 to 20 months longer oral regimen. Only 3 regimens are right now available. These 3, if you remember, that would be good enough. So every patient in India, whoever get suspicious of tuberculosis, they should undergo these minimum tests. That is, they should have the access of universal drug susceptibility, so that rapid DST for at least rifampicin. If that is there, next test will be drug sensitivity to fluoroquinoline. Because if rifampicin is there, we can label as MDR. If fluoroquinoline is there, we can label him as XDR-TB. So these 2 test availability is a must for any patient. So how do we diagnose MDR-TB? These are some of the laboratory aspects I will just briefly touch upon. The first and foremost is, everybody know, microscopy, that is gene luminescence. But if you are using fluorescence microscopy, your yield will be increased additional 10%. So AFP culture by MGIT, that is liquid media, this is the gold standard nowadays. Even it becomes 10 to the power of 2 also, culture will grow. But if the less than that one, smear will not detect. Only problem here is it will take time, at least 6 weeks, and for further drug sensitivity another 3 weeks, means 6 to 9 weeks of time it takes. So because to reduce this turnaround time, molecular tests have been introduced. These have high specificity and they are very much accurate. Diagnosis you can make even MDR also within 48 to 72 hours. What are the methods available? One is probe based method, in that we have CB0 line probe, and sequencing based method, pyrosequencing and whole genomic sequencing. Gene expert, you all know, it is a cartridge based assay. Results are available within 2 hours. It identifies to the tune of 72%. Okay, what is more important is it identifies the mutations in RPO gene. Thereby you can detect the rifampicin resistance. So it is recommended for the diagnosis of pulmonary as well as extrapulmonary TB. So one should be aware there should be false positives, but number is very small, that is approximately 5%, and the false resistance to the tune of 2%. So just to highlight this one, if your sample is showing AFB detected in that sample very low, then this is resistance is not reliable. So if the specimen shows AFB detected low and rifampicin resistance detected, you have to take with a pinch of salt. Again, you better send that culture to conventional methods, that is MGIT. So coming to the line probe assay, first line it detects the sensitivity to rifampicin, INH, high dose INH, ethionamide, and second line it also gives the information about the quinolines. If you have first line and second line, then you can clearly identify whether patient is as MDR or XDR. So one word about this first line LPA, if only CAT-G resistance is there, it will be sensitive to ethionamide, prothionamide. If only INHA is there, so you can give even high dose INH. That is the advantage of knowing first line LPA. Second line LPA, definitely it gives sensitive pattern to fluoroquinolines. Pyrosequencing is has become a novel approach for the detection of TB infection and tuberculosis resistance. Genome sequences, now it is the trend. It identifies almost all the drugs, A, B, C, all the drugs, but it is available only in very few center, and the financial issues also more with this genome sequencing. TrueNAT, it is a chip-based handheld battery operator, very much useful for especially for the program conditions and it to use at the community level. Gene expert Omni, this is a smaller, very lighter thing which a health worker can carry and can supplement the samples at the field level. So, expert MTB RIFE, it detects rifampicin resistance. Expert MTB XTR, it detects the resistance to other drugs also. The main one is the fluoroquinolines, even second line injectables. So, if you subject these two tests, your reports will be ready in 2 to 3 days. Thereby, you can formulate the MDR regimen. Gene Expert Ultra, this is advanced one which is more sensitive. Even 16 bacilli also it can detect. So one word about genotypic tests, these are DNA based, they will not detect the activity of the disease. Only thing is, it helps to confirm the disease, not for follow-up. But whereas this phenotypic test, that is conventional cultures, it confirms not only it is useful for the follow-up, also you can test all the drugs, whatever the 13 drugs available for TB treatment, you can test with this phenotypic test. So coming to the other part, that is the management part. So my topic is what guidelines say. So we have American Thoracic Society guidelines, we have WHO guidelines, we have Indian National Tuberculosis Eradication Program guidelines, but all are almost same in whenever we are coming to the management of MDR TB. So based on this trial, TB Practical Genix trial, and this is a landmark publication in the New England Journal of Medicine. This is TB practical study where they have studied bedaquiline, pretominide, linezolide and moxifloxacin. So in this big randomized trial, it has proven that it is very much tolerated and toxicity also less. So to summarize these study findings, that is next TB trial, these 3 drugs, what I just mentioned, have shown 90% efficacy. But one problem was the linezolide, which was given 1200 milligrams, was causing peripheral neuropathy and myelosuppression. So the next Genix trial, they have reduced the dose to 600 milligrams, which also equally shown the efficacy rate, but less side effects. In TB practical study, that is 6-month BPAL-EM regimen showed favorable efficacy. After this study, total treatment of MDR TB has totally changed. Earlier, we were giving 2 years treatment, injectables, what so on. So this landmark study, this drug studies, which has given 90% efficacy, totally changed the scenario of management of MDR TB. Now almost all the countries, WHO recommendation to follow these regimens. So in the modified BPAL trial, even they have given 300 milligrams to reduce the side effect, which is also equally efficacious to the original regimen. So whenever there is the case of MDR TB, we generally counsel them in detail, total family also taken into account. So Pre-treatment evaluation consists of thorough clinical examination, and also we need to assess their nutritional status, neurological evaluation, ophthal evaluation, sugars, HIV, and LFT, RFT. These are all baseline and especially pregnancy test, because we cannot give some drugs in pregnancy. So initiation, once you decide to give the regimen, these are the three options what I have told: BPAL M, 9 to 11 months shorter oral, 18 to 20 months oral regimen. So this is the integrated algorithm, how to start, what is the regimen to start MDR-TB. This I will explain in subsequent slides. So BPAL regimen is the first eye treatment. Whenever there is MDR, always consider to start BPAL regimen. The inclusion criteria is age should be more than 14 years, and there should not have been any exposure earlier to bedaquiline, linezolid, or predominant, and QT interval in ECG should be less than 40 milliseconds in males and less than 470 in females, and patient should not be non-pregnant or non-lactating. These are essential criteria to start BPAL regimen. Other exclusion criteria: below 14 years, any documented resistance to the first-line drugs, bedaquiline, linezolid, and predominant, any liver dysfunction or severe forms like CNS tuberculosis, skeletal tuberculosis, miliary tuberculosis, or multi-disseminated tuberculosis. These things, cases should be not considered for giving BPAL regimen, or any significant cardiac conduction abnormalities. So some other relative contraindication, if patient is on other drugs like antifungals, antiarrhythmic, antipsychotic, these also drug-drug interaction will be there. Better these cases should be avoided. Other contraindications like severe anemia, thrombocytopenia, after transfusion we can consider these cases, but simultaneously severe renal failure and neuropathy cases should be avoided giving this BPAL regimen. So BPAL regimen administered all orally with food with adequate water. Pyridoxine should be supplemented to prevent neuropathy. So these are the dosages in the BPAL regimen. Bedaquiline, first 2 weeks 400 milligrams once daily, from week 3 to 26 weeks, that is for 6 months, which may be extended to 9 months, 200 milligrams 3 times a week, plus predominant 200 milligrams daily, plus linezolid up to 26 weeks 600 milligrams, may be extended to 39 weeks, moxifloxacin 400 milligrams once daily, and addition of pyridoxine as per this body weight. So bedaquiline, predominant, linezolid, moxifloxacin, these 4 drugs. So bedaquiline, it may cause QT prolongation, hepatotoxicity. Predominant, it may give hepatotoxicity, peripheral neuropathy. Linezolid, we have discussed, it may cause peripheral neuropathy, myelosuppression, optic neuritis. Moxifloxacin, we all know there may be chance of tendinopathy, CNS effects, and QT prolongation. So sometimes if patient not tolerating linezolid because of myelosuppression or peripheral neuropathy, after 9 weeks you may reduce the dose, not before the 9 weeks. If you are not tolerating, you want to change before 9 weeks, then it is considered as treatment failure. If at all you want to give less doses, only that is after 9 weeks only. So this is how we grade a peripheral neuropathy. I am not going to do detail. This is once you keep the patient on the BPAL regimen, these are the follow-up tests like clinical examination, CPP, cultures, X-ray, ECG, all these things should be followed meticulously as per the time frame recommendations. So if patient is not eligible for BPAL regimen, for example, if he is less than 14 years, extensive TB, or already I might have exposed to this BPAL regimen, then what are the other options? Now we are coming to the second short oral. In these cases, first option is 9 to 11 month all oral. Okay, so the eligibility, rifampicin resistant must be there, chloroquine resistant not detected, no history of exposure to these drugs, no extensive disease, no severe form of extrapulmonary, INH, CATG mutations are there, and non-lactating and non-pregnant women. In these cases, we can consider this short 9 to 11 month oral regimen, that is 2 months linezolid, 4 months can be extended to 6 months levofloxacin, clofazimine, pyrazinamide, ethambutol, iodose, INH, and 6 to 9 months bedaquiline. And in continuation phase, 5 months levofloxacin, clofa, pyrazinamide, and ethambutol. Same way, if you want to give ethionamide, If patient is not tolerating linezolid, you can replace with ethionamide. Then that is the course like this: 4 to 6 months levoflox, clofazimine, ethionamide, pyrazinamide, ethambutol, high dose INH. This is in the intensive phase. In the continuation phase, 5 months levoflox, clofa, pyrazinamide, and ethambutol. This is the weight band adjustments. So these are the various doses and various according to the weight bands. So for this 9 to 11 months, again baseline follow-up with the ophthal evaluation, CBC, all these things are mandatory before starting the regimen. So coming to that is long oral, that is 18 to 20 months. This is the landmark paper which has changed the total scenario of management of MDR-TB. Earlier we used to give injections and 2 years long-term course with 6 to 7 oral medication. But after this landmark study, even 3 centers from India, that is from one NTRD, Delhi, Jarir and et al. From Bombay, and PGI Chandigarh group. This group, they have published these results in Lancet. After this, the 18 to 20 months regimen contain all oral medication. In this, 6 months or longer bedaquiline, 18 to 20 months levoflox, linezolid, clofa, and cycloserine. So the inclusion should be who cannot be initiated BPALM regimen or who cannot receive 9 to 11 months shorter oral regimen. These groups should be considered 18 to 20 months all oral regimens. Dr. Rupak Singla, who is one of the main person behind this, he says this regimen is like a grandfather which will accommodate all other non-contraindicated cases. Okay. So WHO has, after this study, grouped these drugs into 3 main groups. That is, Group A, we have Moxi, Levo, bedaquiline, linezolid, and Group B, we have clofa, cycloserine, terizonide, and other Group C, ethambutol, delaminate, pyrazinamide, imipenem, cilastatin, meropenem, amikacin, streptomycin, ethionine. These are Group 3. So, if at all you want to formulate the MDR regimen, the regimen should contain Group A all drugs and preferably Group B all drugs, at least 5 drugs. If you could not make out these 5 drugs, you can carry 1 or 2 molecules from the Group C. But always try to see all 3 must be there, at least 1 from the Group B, 1 or 2 from Group C. So these are the weight bands and dosages. So there are some recommendations to replacing also. If you are not giving the whatever the Group A drugs I mentioned for any other reasons, you can replace like this: delaminate. This is the 6 order: amikacin, pyrazinamide, ethionamide, PAS, ethambutol, imipenem, cilastatin. Like that you can make the replacement. So close monitoring is very, very essential. Monitoring by smear microscopy, culture, radiological, and you have to keep watch of the adverse event. So 1 or 2 words about if there is a high NH monopoly resistance, generally we give 6 months levofloxacin, rifampicin, ethambutol, and pyrazinamide. There is no intensive phase or continuation, all 6 months. Sometimes may be extended to 9 months. In children above 5 years and who are weighing 50 kg, they are all eligible for shorter and longer oral MDR regimens. In pregnancy lady, I have discussed. So above 32 weeks, or if they are ready for MTP, we can give all longer oral bedaquiline regimens. BPAL regimen is contraindicated for pregnant women. So if people living with HIV, after diagnosis, we must initiate heart therapy within 2 weeks. There is no need of delaying. Surgery, even after 6 to 9 months of treatment, there is no conversion. You can send the patient for surgical resection. So these are some adverse events. How to monitor the liver disturbances. So we have to monitor the treatment outcomes. So after finishing the treatment, we can label them as a treatment failed, or cured, or treatment completed, or death, or lost to follow-up. Cured is with the evidence of bacteriological response and no evidence of treatment failed. So to summarize whatever I have discussed in the 15 minutes, just to give this, so whenever a suspicious case of TB is there, you first subject them CBNAT test. If there is R resistance not detected, you can give first line treatment, that is 2 HRZ followed by 4 HRE. If H resistance is there, continue first line. Not detected, continue first line. If H resistance is there, you can send Can I take 2 minutes? This is the last slide. So if H resistance is detected, you can try all oral H mono poly drug resistant TB regimen. If rifampicin resistance is detected, again you send for first line and second line LPA along with the liquid culture drug sensitivity. If this is available, you can try all oral regimens. If less than 14 years, you can start a shorter MDT regimen. So to conclude, early and accurate detection of rifampicin and polacin resistance is using rapid genotype method is essential before initiating therapy. Treatment selection in MDR TB, pre-XDR TB and XDR TB should be individualized based on resistant patterns, patient profile and drug tolerability. BPAL and BPAM regimen is now the preferred first line option wherever eligible. Alternative options include shorter 9 to 11 month regimen or longer oral regimen. Preference should always be towards short to oral regimens. And rational use of modern diagnostic should be for the individual regimen, and it is the key to improving cure rates moving towards TB-free future. Thank you for giving me this opportunity. Once again, my greetings to APRCON for giving me this opportunity to speak before you on MDR tuberculosis. Thank you so much. Any questions, I am happy to answer. Sir? I could not listen. Yeah. Yes. Actually, in private setup, these bedaquiline, these drugs are not available. So, whenever we diagnose the patient with the MDR TB, most of the times we are referring to the state TB center. They are following the cases. If there are any adverse effects, they are coming to us and following with us. So, there they are updating all these apps and other follow-up, everything they are taking care. But our job is we have to inform them. All TB confirmed cases, MDR cases, we will report them.
Thank you, sir.
Yeah.
I request the chairperson to please felicitate the speaker. Over to you.
Dr. Vedaranya is a young dynamic enthusiastic pulmonologist working with us in Central Hospital, Alameda. She belongs to IRHS 2014 batch with experience in railways of 10 years. Her areas of interest are hepatitis, pneumonias, interventional pulmonology, tuberculosis, HIV, AIDS, and malignancies and chest fever. Without wasting much time, I quickly hand over to Dr. Veda to start her presentation.
Thank you so much, sir, for the kind introduction. And at the outset, I want to thank our Sai sir for giving me this opportunity to talk about vital issues in the field of pulmonary medicine. So, these are my disclosures. The talk is sponsored by AstraZeneca, but the contents of the actual sessions are not influenced by the product of sponsorship or by any pharmaceutical companies. So, to speak about the molecule of discussion here, we are talking about the breast-free aerosphere inhaler device. Aerosol particles in metered dose inhalers, they are deposited in the airways at different rates, at different places, depending on the size. So particles of more than 5 micron size, they get deposited in the oropharynx. They do not reach the airways. And the aerosol particles of size 1 to 5 microns, they are the ones that actually goes and deposits in the airway and show the action when we prescribe an inhaler. And the extra fine particles of less than 1 micron, they are largely exhaled in the exhaled air, sometimes get into the bloodstream directly. So this bloodstream molecule, it has a light foam nanostructure, and the size is about 3 microns, which is optimal. And the corrugated surface which binds with the active molecule is making the molecule absorb into the airways, which is the target airway. And upon gamma scintigraphy studies which are done about the molecule, this inhaler with aerosphere technology is showing a minimum of 55% drug deposition. When a conventional meter dose inhaler will give 10 to 20% of drug deposition. However, this molecule is showing at least 55% in deposition. And the recent study shows that the bloodstream molecule is 2 times having more absorption into the airways when compared to the fluticasone medium and vilantrol composition, which is the most approved single drug inhaler therapy for severe COPD patients. Moving on to the main topic of the day, it is needless to say how interventions in pulmonology are booming every day. With striking innovative approaches to precision medicine and Hyderabad becoming the country's sophisticated health hub, pulmonary interventions, they are marketed globally as very innovative, and also it's let's take a minute to understand what these interventions are and how really they are useful in our day-to-day practice. The pulmonary lesions are broadly classified into central airway diseases and peripheral lesions. So how do we approach a central airway obstructive diseases is shown in this algorithm. If the central airway obstruction is having emergency situation where there could be a potential blockage and respiratory insufficiency because of the obstruction, then we go ahead and try to identify if the lesion is a submucosal valve or an endoluminal one. The submucosal or extraluminal lesions, we use dilatation, endobronchial dilatation methods and stenting methods. However, if the lesion is endobronchial, we use dilatation, coring, laser resection, electrocautery, organ plasma coagulation. These are the latest modalities that are available widely. And if the lesion is not emergent, and we look at the curative intent of the lesion, so if possible, we go ahead for surgery and resect the situation, resect and control the situation. If curative surgery is not possible, then, and again, if the lesion is endobronchial, we go for laser resection, cryobiopsy, and electrocautery, photodynamic therapy, dilatation, coring, organ plasma coagulation, brachytherapy. Most of the times, it is not one intervention that is being used, it's a multimodality aspect that is being tried. So with the help of a rigid bronchoscopy and a flexible bronchoscopy, with the rigid bronchoscopy acting as a channel to secure the airways, we use these 1 or 2 of these modalities to get the lesion endobronchially or transbronchially. And we try to secure the airway, either be it a biopsy or taking away debulking situation. We can use all these recent modalities. And similarly, if the lesion is peripherally based, in the lungs, then we can we can try percutaneous biopsy. Now we have CT guided biopsy, that is the usual mode of diagnosis for all the peripheral pulmonary lesions. Or if possible, at an early stage, any surgical resection is a possibility, is what we look into. And bronchoscopically, there are many interventions that we do. So conventional bronchoscopy or image-guided bronchoscopy or ultra-thin bronchoscopy where we can target the peripheral lesions. And in image-guided bronchoscopy technique, we do EBUS, radial ultrasound, guided biopsy, or confocal endomicroscope, virtual bronchoscopy, or electromagnetic navigation bronchoscopy. So these are the usual bedside procedures depicted here. So it's the lymph node FNAC or the biopsy, the thoracocentesis. These are the usual procedures we do in pulmonology. And the needles depicted here are the Abrams needles and the Cope needles used for pleural biopsy, nowadays almost obsolete with the advent of medical thoracoscopy. So the most commonly performed procedure in pulmonology for non-resolving pneumonias, persistent pneumonias, malignancies, tuberculosis, foreign body aspiration, fungal infections, or bedside ICU procedure is the bronchoscopy. Sometimes when we need a stable situation, we first go ahead under GA, we intubate the patient with rigid bronchoscopy. And upon that, we can go ahead for what next investigation is required, what next procedure is required for the patient. So the last 2 decades have been showing a lot of advent of newer technologies into the field of bronchoscopy. So this is one of the thing, endobronchial or transbronchial cryobiopsy. So cryobiopsy is a minimally invasive bronchoscopic procedure where the tip of the cryoprobe is rapidly cooled to extreme sub-zero temperatures. And by that repeated freezing and thawing mechanisms, the endobronchial lesion can be picked up in large chunks. There's a little video of how endobronchial cryobiopsy with bronchoscopy is being performed in patients, and this is also one of the GA procedures what we are talking about here. The patient has already been intubated with a rigid bronchoscopy. Inside that, we are going inside with the flexible bronchoscopy, and the target lesion, the endobronchial lesion, is shown here. And with the cryoprobe, they are freezing the tissue, and while we freeze the tissue continuously, we come out en bloc with the flexible bronchoscopy. We should not stop freezing, we should not thaw it. Otherwise, whatever the tissue we are trying to take it out, it will fall back into the airway. So multiple chunks can be easily removed. En bloc it can be removed. The benefit with cryobiopsy is, if we are taking a biopsy, we can maintain architectural preservation is what maintained with the procedure. So electromagnetic navigational bronchoscopy is one of the advanced modalities where CT scan images are loaded into the system, and the system gives us the way to navigate to the lesion. Peripheral lesions are well diagnosed, where the biopsy of peripheral lesion become very easy with this procedure. The autofluorescence bronchoscopy, it is a technique where specific wavelengths are used to locate pre-malignant endobronchial tissue for biopsies, the ones that are not visible with white light bronchoscopy. So confocal laser endomicroscopy and optical coherence tomography, these are other modalities used for diagnosis of early malignant situations. And robotic bronchoscopy offers many advantages. It has some technical limitations. The size of the robotic arm instruments may limit the access to certain areas of the airways. Otherwise, the bronchoscopic sits in the console and he operates with the robotic arm, and it can go into the peripheral lesions also. We can get a very adequate sample, and the navigation becomes very easy. This technology also uses navigational bronchoscopy. And EBUS, TBNA, laser ablation or endobronchial biopsy, all the procedures are done very easily with very good precision with these procedures. Endobronchial ultrasound, needless to say, this is one of the latest procedures, and with the advent of endobronchial ultrasound, the mediastinal lesions and the peripheral lesions, biopsies or the diagnosis or the staging for lung cancers, everything has become very easy. So if I am talking about endobronchial ultrasound, transbronchial needle aspiration, EBUS TBNA, it is most sought after the interventional procedure of today, and the sensitivity and specificity of the procedure is comparable with that of mediastinoscopy without having the morbidities of the mediastinoscopy procedure. We can say that this procedure has almost removed mediastinoscopy's uses. This is intranodal forceps biopsies under endobronchial ultrasound guidance, where we can see in the picture, this is how the so this is how the ultrasound image looks, and the one we can see a sharp needle kind of thing is the one we are piercing intranodally, and we are taking a biopsy from there. Transbronchial cryobiopsy under EPAS guidance. As I have already said, the biopsy specimens are larger with the technique, and the pathological final report becomes very easy, and almost rare diagnosis can be found out with this, and molecular characterization can be possible. We can get IHC and NGS specimen very adequately with cryobiopsy technique. Radial EBUS uses a SIAM fluoroscopy, and with a two-dimensional visualization, a real-time biopsy is performed. And if we combine rapid on-site examination, what we call as ROSE, rapid on-site examination of the biopsy slide at the OT itself, the sensitivity drastically increases, the diagnostic yield is very good. There has been a lot of noise about the procedure, cone beam CT guided lung node biopsy. So what EBUS and radial biopsy is doing under fluoroscopy is a two-dimensional picture where there is a chance of missing the biopsy specimen. With this, it is a three-dimensional picture. We locate the lesion with all three dimensions, and the chances of losing a specimen is almost zero, is what they say. But again, this needs lots of training, and obviously this is how they do in the three-dimensional picture. They locate the lesion and they go into that. This needs a lot of backup in case if the thing fails, we should be ready with all the other backup procedures. And once we have finished the mediastinal lesions, then talk about peripheral lesions. Medical thoracoscopy is one of the common procedures which we do today. I'm talking about 7 cases that we have diagnosed in our setup, and this is one of the first procedures that I have done in my OT, a 71-year-old gentleman, a retired technician, and he walks in with a cough, shortness of breath of 3 days duration. But the X-ray is not convincing, so we do a sputum evaluation, which was inconclusive, and a normal flexible bronchoscopy under local anesthesia is yielding CB-NAT positive. To talk about TB Mukta Abhiyan, still we are in a stage where every day we are diagnosing new cases of tuberculosis. It's a long fight, it's a long way to eradicate tuberculosis. Needs the will and work of almost everyone who is into the health system. Because this is what we are saying. Once the sputum is negative, we should not abandon the case right there. We should go ahead. Invasively also, we have to evaluate the patient and get the diagnosis. And the second case is a right moderate pleural effusion. The pleural fluid analysis was inconclusive, and upon thoracoscopy, this was done in our own hospital. We find multiple pearly white nodules along the costal pleura, mediastinal pleura, biopsy from which has given us a diagnosis of adenocarcinoma. And a 74-year-old gentleman with massive pleural effusion. But upon CT scan, we have seen that there were multiple large pleural-based opacities in the CT scan. So we went ahead, taking high-risk consent, we went ahead for the procedure. Upon medical thoracoscopy, we have found that there was so much of pus-laddered large masses throughout his lung cavity, and biopsy from that has given us a diagnosis of adenocarcinoma once again. And this one was a case with a 71-year-old with mild pleural effusion bilaterally. Upon close observation, you might see that there is a lesion on the right apical zone. And on CT, it was very clear. A CT-guided biopsy was performed, and a diagnosis of malignant mesothelioma was established in this case. A 61-year-old male came for a pre-anesthetic checkup. Upon the X-ray, I saw that the right hilar mass was there, and we sent the case, we referred the case for an EPUS guided biopsy, which showed a stage 1 adenocarcinoma. a 61-year female who presented to our hospital with a right lower lobe non-resolving pneumonia of 1 year duration. The CT scan was telling it was pneumonia, but we just did not get convinced with the diagnosis. We went ahead and got an EBUS done, and the patient turned out to be stage 1 carcinoma, adenocarcinoma. And this is one interesting case where a 52-year-old female with a cough and shortness of breath of 2 weeks duration showed a right mid-zone collapse in the CT. And upon bronchoscopy, she shows a mass that is blocking the whole of the right middle lobe. We took a biopsy from the endobronchial mass, and it turned out to be a caseating granuloma as well. A mass, a very good mass, which gives us a probability of a malignancy turned out to be a tuberculosis. So what we see is probably what is not there. We have to be vigilant until we get a pathological diagnosis. We cannot be sure of what really it is. And this was the paper I have presented this year in ERS India Summit, the clinical spectrum of thoracic malignancies in our central hospital. And obviously without our radiologist, our pathologist team, this would never be possible. So from January 2022 to July 2025, all the cases of lung malignancies that have been diagnosed in our chest clinic have been studied. And there was a male predisposition for the study, and the usual age, the most common age of malignancies was 60 to 70. And mostly they did not have much of any comorbid conditions. And the mode of establishing the diagnosis of malignancy was, most commonly used mode was CT-guided biopsy, and then bronchoscopic biopsies, and then there were many cases for them we had to use EBUS-guided biopsies, EBUS-guided cryobiopsies for establishing the diagnosis. And if we studied the 145 cases of malignancies, the most common one in our hospital was an adenocarcinoma with 86 cases, mostly majority of them are like that. And then came the squamous, almost hardly 35% were smokers. So majority were non-smokers, and the cancer which we could diagnose was also adenocarcinoma. There were other type of carcinomas, also mediastinal carcinomas and metastatic lesions also we could diagnose in our hospital. And 99 patients of 145 patients were having metastatic, that means the stage 4. So this again, I just want to put forward a message that the last 2 cases which I showed, we have diagnosed them in a stage 1. So with active supervised situation where if we put more focus onto that, more and more of stage 1 or stage 2 cancers, if we can diagnose, this can potentially be a curable situation. Probably surgical resection is the way forward. So our emphasis should be on early detection, and the screening programs usually include smokers, but looking at the new scenarios, not just in our own hospital, but the data also say adenocarcinoma has become the more prevalent cancers among the lung cancers. So how can we include only smokers and screen them? We should include non-smokers also. So it is a time to think what could be the best way of screening these patients. So ending the talk, with continued research and development, the future of intervention pulmonology holds great promise. Procedures like EBUS, bronchoscopic volume reduction, endobronchial valves, coils for emphysema, bronchial thermoplasty from bronchial asthma, endobronchial stenting for tumors and stenosis, they are all improving the quality of life for patients with pulmonary diseases. So we must ensure adequacy of expertise and equipment for delivering such promising outcomes. And only by embracing such advancements, we can truly commit to our mission statement, total patient satisfaction through human approach, shared commitment of every doctor and paramedic to provide quality healthcare using modern and cost-effective techniques and technology. Thank you so much for the opportunity.
Thank you so much, Dr. Vedaranya.
Sir.
It's an inspiration for the youngsters to publish more.
Sir, you are an inspiration, sir.
As we are running short of time,
yes, we'll go ahead.
To the next
Thank
talk.
you, sir.
Questions can be taken later.
I'm sorry, I cannot hear you.
Ma'am, you had shown one case where you did a pre-anesthetic workup for a OIE
Yes,
and you did a
yes,
stage 1
yes.
Do we have some institutional protocol to screen for CLM? Because once by the time they present with some symptom like cough, they must be already in an advanced stage. So do you have anything like that?
See, we do not, to establish a screening program, we should have a backup of dealing with the whole thing. Once they diagnose, we diagnose with the malignancy, do we have the technology, we can have the treatment options for them. And nobody is stopping at the diagnosis of malignancy. They want molecular analysis, they want the biologics. Are we ready? Can we afford? Is all what we have to back up a screening modality. So as the whole country doesn't have a screening program because of, and we have a tuberculosis situation also. So all the lesions that we see, most likely they can be a fibrotic lesion, post-tubercular, post-COVID situation, not that they are all malignant. And evaluation is a cost, it's not a cost-effective solution, it's a costly affair. So once we have to develop such a protocols, it has to be properly backed up with all the investigations, while we have surgical modalities also and biologics that we need for dealing with those things also. So as of now, we do not have a protocol. This was an incidental. I make sure all the PAC cases will go for a chest X-ray, and if required a CT also. This is one of the opportunity where the patient comes to us, and any lesion I do not get compromised. I just have to evaluate, make sure they do not have this. I have a personal interest that after coming here, Lalagura, I have diagnosed so many cases of malignancy. So because there was like no chest physician for quite some time, this has become a open field for me. So yes, so it's going very well. And the X-ray is not optimal for diagnosing or suspicion screening. But there is one Cure AI app is coming. The private hospitals are using it already. They are uploading all the X-rays, all the CT into the program, software program, where they are studying any lesions. If the possibility of malignancy is there, they're picking up the patient, asking them to go ahead for all the procedures of diagnosis. So hopefully our Indian Railways also get some pro software like that, so that it will help, the manpower also comes down, the technology also brings forward.
Since you told about this AI app, we have got an extension recently in the hospital, which is AI integrated, and it will mark all the suspected lesions.
Exactly. Cure also is one of the app. As of now, I know that it uses CT scan, but we are looking forward for something that uses a chest X-ray also, because that is least radioactive situation.
The machine which I was talking about is analyzing the X-ray.
That's beautiful, but false positivity is again very high. So we might land up doing more tests than what is. We don't have facilities to hold up that large thing.
Thank you.
Thank you, Veda. Veda, can you please stay back for the felicitation? I request Chairperson Dr. Rakesh Nigam sir to please felicitate the speaker, Dr. Veda. I request Dr. Sai sir to please felicitate the chairperson, Dr. Rakesh Nigam sir. Dr. Rakesh Nigam sir is PCMD North Central Railway. He belonged to 1994 IRHS batch. He is senior anesthetist and he has almost 33 years of clinical service. Thank you, sir. Next, we'll move on to the last session of the day, for which I call upon Dr. Venugopal Reddy sir, CMS Guntakal, and Dr. Srinivasa sir as chairpersons. And I call upon the first speaker, Dr. Narayanasamy sir, CMS Secunderabad, to deliver his talk on psoriatic arthropathy. Sir, I request the chairpersons to please introduce the speaker.
Good afternoon, everyone. Welcome to the last session of the APRCON 2026. And I thank organizers for including dermatology and orthopedic topic also, because four orthopedicians have come for this conference, two PCMDs and two CMSs. Now, this topic is going to be presented by Dr. Narayan Swami. He is working as Chief Medical Superintendent, Secunderabad Division in South Central Railway. Key achievements are 2 GM Awards, 4 PCMDs Award, 2 Cash Awards, 1 CA Awards. He belongs to 1993 IRHS batch, working specialist since 1995 in dermatology, and his areas of interest are phototherapy and cosmetic surgeries. Now, I request Narayan sir to present his case. Thank you.
Respected chairpersons, PCMD madam, all delegates, good evening everybody. I am a dermatologist. Now, I am looking after the Department of Dermatology in Lalgod hospitals in last 1 year. Before that, I am not attached to any teaching hospitals. If there is any shortcomings in my presentation, please kindly excuse me. So one of the burning topic of today's this thing is psoriasis. Psoriasis is one of the stress-induced skin manifestations, skin disease. So that I have chosen the topic of psoriasis. Psoriasis comprises a family of common immune-mediated and often genetically determined inflammatory skin disease. Characterized by is a distinctive clinical appearances and associated with diseases in other organs, in particular psoriatic arthropathy. Psoriasis is a multi-systemic disease. It affects the skin as well as joints, eye, cardiac and other organs also. So now in this topic you have selected arthropathy. At molecular level, psoriasis is initiated by environmental stimuli such as trauma, infections, stress, smoking and dysbiosis. So basic pathological changes in this psoriasis occurs is the skin sites, keratinocytes, starting from the basal layer to reach the stratum corneum, it takes 28 days. Normal regulation, it takes 28 days. That is called orthokeratosis. Okay. Whereas in psoriasis, because of the loss of regulation, in a matter of 5 to 6 days, the cell which is started from the basal layer, it reaches the stratum corneum. So turnover will be very fast. Why this turnover is fast is because there is no control over the keratinization. That is the main basic this. So there will be more cell turnover. So exfoliation of the skin takes place. This thing is very fast. Okay. Basically, cause of this psoriasis is 99% is unknown. Only stipulated theories are there, but there are some triggering factors which initiates the psoriasis. Mainly nowadays, triggering factor is stress related. This stress induces the cells, endocrine changes, release of cytokines, accidents that causes the activation of the psoriatic mechanism and start the. So other things is trauma. When there is a trauma, all chemical mediators will come, especially T cells and the B cells will come. All they will release the cytokines that will activate the cell turnover. All inflammatory cells will come. Though that is called as a Cobner's phenomena. Cobner's phenomena. That is a trauma, one of the inducing factors. And second one is infections. Any streptococcal throat infections, staphylococcal throat infections. When there is an infections anywhere in the body, all inflammatory mediators will accumulate and they will release the cytokines and psoriasis will trigger. So stress, as I told you, smoking and dysbiosis. Dysbiosis is the balance between the bacterial flora and the skin. When there is a bacterial flora of the gut, especially gut is altered, there is a dysbiosis occurs and it will also trigger the starting of the psoriasis. Then it comes to types of psoriasis. In the types of psoriasis, most common type is psoriasis vulgaris, otherwise called as a plaque psoriasis. Next common is gutted psoriasis, nail psoriasis, nail affecting the psoriasis affecting the nail, and inverse psoriasis. Inverse psoriasis is the one which affects the flexural areas of the body, especially axilla, groin, and all. That is the. And the fifth one is the pustula psoriasis, where the psoriasis will be in the pustule sporums, and the next one is psoriatic erythrodermic psoriasis, where the 90% of the skin is affected and skin is in the form of exfoliation of this. That is called as erythrodermic psoriasis. Then last one is psoriatic arthritis, arthropathy, psoriatic arthropathy. Now today in my topic I will concentrate on psoriatic arthritis. So these are the mechanism showing the psoriatic initiations and early phase. That is injury, infection, genetics, drugs, and autoantigens. So these are the already I told you, that is genetics, one of the and drugs, especially drugs, lithium, AEDs, some of the beta blockers, they are all known to cause the triggering factor for psoriasis. In come to introduction of psoriatic arthritis is an inflammatory arthritis associated with psoriasis and is seronegative for rheumatoid factors. So if the positivity is there, it goes for rheumatoid arthritis. It is a negative for psoriatic factor. That's why it's called it is the psoriatic arthritis. It occurs in 10 to 40% of patients with psoriasis. Mean age of psoriatic arthropathy is 40 years, equal in both the sexes. In 70% of patients, skin features of psoriasis develops prior to the joint involvement. In 20%, joint disease presents first. In 10%, skin and joints affected concurrently. Genetic factors, psoriatic arthropathy is first degree relatives in 100%. There is presence of psoriatic in the first degree relatives. There is 100% risk of arthropathy. HLA B27, HLA B38, B39, B7 and DR4. They are more prone for developing psoriatic arthropathy. Environmental factors and individual factors, that is physical trauma, smoking, obesity, these are all added risk factors. Pathogenesis is autoimmunity against a common skin and joint autoantigens, that is chronic autoreactive T cell derived inflammations. That is what I already told you, the Cobness phenomena, because there is joints will be under continuous minor trauma. Once the minor trauma, when you are using the joints, there will be continuous minor trauma. The autoantibodies will act on the joint space and the arthropathy will occur. Immune activation in the synovium and enthesis of the affected joints, that leads to activation of both the innate and adaptive immunity. That leads to overproduction of multiple cytokines, that is tumor necrotic factor alpha, interleukin 17, interleukin 23. That leads to angiogenesis and increase in the synovium, joint fibrosis occurs, erosion of the bone takes place, abnormal bone formation takes place, and joint deformity with the loss of function of that particular joint. So, psoriatic symptoms of the psoriatic nail changes, that is you can see the pittings, the nail changes, and the swollen joints. Second photo you can see the swollen joint with the erythema. Third one, swollen tendon with the erythema and swollen tendon, Achilles tendon you can see. Fourth one, sausage shaped digit, that is a finger, you can see the shape of this one, sausage shaped digit. And next middle one is heel pain with the swollen erythema is there. Last one, joint destruction, that is occurred as mutilating joints. Next, stiff joints of the back when the cervical spine is involved, that is a stiffness will be there, and swollen joints of the feet, that will be there in the joints involvement is there. The types of psoriatic arthritis, there are 5 types of psoriatic arthritis. First one is symmetrical polyarthritis. In symmetrical polyarthritis affects 5 plus 5 or more than 5 joints in both the sides of the body, that is both knees and elbows. Second type, asymmetric psoriatic arthropathy. So that affects 2 to 4 joints, usually different joints of each side is affected. Third one, distal interphalangeal predominant psoriatic arthritis, affects fingers and toe nails near the finger joints and toe joints near the nails, often causes nail changes. Fourth one is spondylitic changes, that is cervical spondylitic changes or lumbar spondylitic changes. Fifth one, arthritis mutilans. Arthritis mutilans is a rare and severe form causing the joint damage and bone loss in hands and feet. These are the 5 types of psoriatic arthritis. Investigations, most of the time it is a negative. So ESR and CRP rise in only less than 50% of cases, and uric acid will be normal. A rheumatoid factor and CCP antibodies will be negative. Rheumatoid factor is positive, matlab it goes in favor of rheumatoid arthritis. Negative is in favor of So seronegative arthritis. This is one of the type. Psoriatic arthropathy is one of the seronegative type. So synovial fluid analysis we will do. The plain X-ray will take of the hands and feet, detect the erosion of the disease, but have a low diagnostic sensitivity in the early stage. So main diagnosis depends on the MRI. MRI is useful in assessing the enthesitis. That is one of the earliest changes takes place in the psoriatic arthritis. MRI is the modality of choice for assessing the axial disease that affecting the spinal cord. These are the photos showing the involvement of the great toe giant. And second photo is showing that is penicillin cuff deformity. In ultrasound, detect the active inflammation in the joints and entheses, detects the erosions before they appear on the X-rays to guide the injection into the joint. This is the use of ultrasound in the psoriatic arthropathy. MRI imaging modify the choice of spinal involvement, can detect active inflammation, erosions before they appear on the X-ray. Early diagnosis, MRI will be very helpful. There is one criteria for diagnosing the psoriatic arthritis that is called as Casper criteria. In the Casper criteria, a patient is considered to have a psoriatic arthritis if there is an inflammatory articular surface, that is a joint, spine or enthesial involvement. There is within there are 3 or more than 3 points for the following 5 criteria. If it is there, we can diagnose this as a psoriatic arthritis. First one is evidence of current psoriasis, a personal history of psoriasis or family history of psoriasis. Second one is typical psoriatic nail dystrophy changes that include onycholasis, pitting, hyperkeratosis observed on current physical examination. A negative test results for the presence of rheumatoid factors by any method. Fourth one is either current dactylitis or a history of dactylitis that is required. Fifth one is radiographic evidence of juxta-articular new bone formation appearing on ill-defined ossification near the joint margins. So these are the 5 criteria. Out of the 5, any 3 are there, you can diagnose it as a psoriatic arthritis. For differential diagnosis of psoriatic arthritis, mainly there are 4. First one is psoriatic arthritis, second one is rheumatoid arthritis, third one is gouty arthritis, so fourth one is the osteoarthritis. Psoriatic arthritis, so because of sparsity of time, I'll go quick. And treated by multidisciplinary approach, rheumatologist, dermatologist, the domain belongs to both of the. So main therapy of this, symptoms modifying therapy. Second one is disease modified anti-rheumatic drugs. Third one is biological agents. So NSAIDs, that is diclofenac, indomethacin. Corticosteroids, intra-articular injection of corticosteroid, that is triamcinolone 40 mg once in 3 weeks. Methylprednisolone also can be given intra-articularly. Disease modifying anti-rheumatic drugs, that is a methotrexate, is a cornerstone of our any psoriatic treatment. Methotrexate, sulfasalazine, cyclosporin, leflunomide. Biologics recommended for patients with active psoriatic arthritis, spondylitis, enthesitis. The first line biologics are TNF alpha inhibitors, that is infliximab 5 mg per kg per IV infusion on 0 to 6 weeks, then after every 2 weeks. Adalimumab 40 mg subcutaneously every 2 weeks. Etanercept 25 mg subcutaneously twice weekly for 12 weeks, then weekly. Golimumab, that 50 mg subcutaneously for every 4 weeks. Satralizumab, that 200 mg subcutaneously for every 2 weeks. Then comes interleukin 12 and interleukin 23 inhibitors. Ustekinumab 45 mg subcutaneously on week 0, 4, 12, that is 3 months, then followed by every 12 weeks. IL-17 monoclonal antibodies, secukinumab 150 mg per week for the first 5 weeks, then monthly once. Isatuximab, that is 160 mg on week 0, followed by 80 mg on every 4 weeks. IL-23 inhibitors, guselkumab, that is 10 mg at a week 0 and 4, then once in every 8 weeks. JAK inhibitors, the tofacitinib, currently undergoing clinical trials for psoriatic arthritis. Phosphodiesterase inhibitors, the apremilast 30 mg taken orally twice daily in to moderators. These are the biologics which are available in the This is a diagram showing where this biologics act on the cell molecule. This is a flow chart. Initiate therapy. If the peripheral arthritis is there, first choice is NSAID, steroid injections. Systemic treatment include methotrexate, sulfonamide, sulfasalazine, cyclosporin. Last one is the biologics. Axial, that is spinal cord involved, NSAIDs, physiotherapy, and biologics is the last resort. Dactylitis is there, NSAID and steroid injection. There is no biologics in dactylitis. Enthesitis, NSAIDs, physiotherapy, and biologics. These are the new molecule future biologics are coming in the market. So there are so many drugs are coming in the market. Thank you, Nandal, for patient listening.
Thank you, sir. Thank you for your nice and elaborate presentation on psoriasis as well as its complications, especially focusing on psoriatic arthritis. Now I request all the audience, I am very happy and thankful to all the delegates. Still 50% is existing, even though it is the last session of the day. Thanks for your patience listening to our speakers. Now I request all delegates to whatever the number of questions you can ask. There is no problem. As there is no limitation, no short. You are all invited. There is no short time now. Thank you.
Sir, in Central Hospital, we are using secukinumab, isatuximab, we are using. Cornerstone of this thing is methotrexate. So, isatuximab and secukinumab, we are using, sir. So, we have indented, we have got a sufficient amount. These drugs we are using. We have got 9 patients and psoriatic patients, not only 9 patients we are on. Results are relatively good, sir. First initial phase you will give for 3 months, then followed by every monthly or once in 3 months. They are giving good response. We didn't have any complications related with this. So,
Sir, negative. Hello. Then you have two differential. One is a seronegative RA or second is a psoriatic arthritis. There, lot of time you don't get a skin lesion obvious. So you have to look for hidden site like behind the ear, in the scalp, around the umbilicus or the perinatal cleft. All those very small areas where they can give a clue that it is psoriatic. Treatment may be almost similar, but you have to only tell that whether you have to label it whether it is RA or a psoriatic arthritis. Then, like biologics, he told you have to decide the biologics depending on the particular domain. If you have a more of a skin domain, where extensive skin lesion and skin score is PASI is very high, and they are probably IL-17, IL-23 inhibitors will be common. But if it is a more of a arthropathy, and probably anti-TNFs are the best. And now after JAK inhibitors, things are JAK inhibitor already FDA approved and in India also approved, and upadacitinib is still much better than, because it is most cost effective and daily dose is less and toxicity is less. So if you give 15 milligram once daily, it is good enough, and the cost is less than tofacitinib and
Nowadays, the Apremilast has come, sir. It is, yeah, long, but it's good, giving a very good result with the methotrexate.
Yeah, if you
combination.
have peripheral arthritis,
Yeah.
then it is good. But if it is axial, probably you have to go for that.
Yes, sir. Yes.
Apart from stress, the other one main cause was dysbiosis, GI dysbiosis as well as the skin dysbiosis.
Yes,
Nothing
sir.
was mentioned about the treatment part of that.
Sir, along with that, you have to give antibiotics, sir. Most of them macrolide antibiotics. So one of the complications in psoriasis is immunity, affecting immunity. So when there is a exfoliation of the skin is prone for all superficial infections, folliculitis and so macrolide antibiotic you have to give, supplementary with the probiotics, sir. Everything now they are saying that psoriasis occurs because of the changes in the gut. So you have to take care of the guts, give the probiotics. And
Specific probiotic probiotics. Probiotics, all like we take all probiotics, it is not that. For specific diseases, you have specific probiotics. So for psoriasis, you have the
Sir? Okay. Sir. There's so many in the market. I don't want to. Yes, madam.
Sir, what about psoriatic arthritis patients in pregnancy? How are you managing?
Madam, psoriatic arthritis in pregnancy actually will go, there is a chances of regression during the pregnancy period, madam. You will wait till the delivery takes place because these are all highly protected.
Why I am asking is because one of my patients, she's our own DMO. She is on secukinumab. She's doing fairly well. She's planning for pregnancy.
So secukinumab and all is try to avoid, madam.
Yes, exactly.
Try to avoid during pregnancy. You go with the management of NSAIDs only.
Understood.
So NSAIDs, then after the delivery you can go for the full term. There is a chances of regression during the pregnancy of psoriatic arthritis as well as psoriatic skin lesions.
What about if she develops a flare in between, like during the planning of pregnancy?
So,
right. Yeah.
They reduce during the pregnancy.
No, not
reduce.
during the pregnancy. I'm asking, like before the planning of before the pregnancy itself. During the planning, we have to stop, right?
No, you have to stop all antibiotics 3 months in advance. You have to tell them while giving this one, they have to use contraceptive methods. Stop the secukinumab, any biologics for minimum 3 months.
Understood.
Minimum
so during that time, if she develops a flare,
plan.
then we have to go ahead with the steroids only.
Minimum 3 months plan, and they can go ahead with any children.
Right, sir. Thank you, sir.
Thank you, madam.
Thank you, sir.
Okay, ma'am.
Thank you, sir. Before we go to the last talk of this day, let me call upon Mr. Raja Reddy. He will just demonstrate how to use a CGM. They are one of the sponsors of this conference. They are from the Award Company.
He is my colleague, Mr. Satya Narayana. He covers this South India, so I cover West India. So we just do the demonstration of CGMS. We like to highlight a few points about the CGMS. Is the CGMS we got Freestyle Liberate 2 Plus. It's a continuous glucose monitoring, which is ICGM approved now. It is approved by US FDA ICGM. So it can be used for the children about 2 years and above. So usually earlier was only for 4 years and above, now it is 2 years and above, and ICGM approved, and it has got it gives various parameters like logbook, AGP report, time in target range, time in range. Why it has gained prominence is that globally almost 8 million people are using this one. This is the next level innovation in CGM. So as a physicians, when you get a patient, you might be seeing that a lot of patients who are in a basal bolus intense regimen. As a physician, when they come to you, you have apprehension to increase the dose. Why? Because if you increase the dose, again you will not be able to achieve your desired target goal of HbA1c. So this gives you trends and patterns, and it will change the way how you treat the diabetes. So the globally trending, though HbA1c is considered to be the gold standard, it comes with the limitations, like it doesn't give any idea about hypoglycemia, it doesn't give any idea about higher glycemic variability. Whereas this one, it will give you complete idea about what is happening in your body. Why? Because rate of metabolism changes from patient to patient. So which food is making your glucose levels to go high, come down, how medicines are working, like if at all you do any exercise, is there any improvement in glucose, all those things you'll be knowing. And the time in range is that it is like 70 to 180. The more the time you spend between this 70 to 180, less likely complications you will have. So it gives, time in target range, AGP report, and also A1C report, HbA1c report. So all the parameters which are necessary for the diabetic management, it is available in the same one sensor. So I just show the demo how to use it. So I think Pfizer would be like to have a sensor on him. This is the sensor pack. So there is a two components in this pack. One is sensor pack, the other is applicator. I will show you how to apply. It is a very simple, and it comes with the 1 rupee coin size. I am also wearing, you will not be able to feel also. Here is the sensor. What it does now, it records your glucose every minute. After 15 days now, you will be getting 1500 readings. So first you have to unpack this one. So this is the applicator. First what you have to do, you have to peel off this cover. There is a cover here. And after that you have to unscrew the applicator. And you can see one mark here, dark mark. There is one line over here and one line on the sensor pack. So applicator and sensor both need to be aligned. There is one line here, one line on the sensor. So both the line need to be aligned. If you don't align, it will not go only. It stuck here. You have to align, then only it goes inside. With the just press the applicator. The sensor get transferred from applicator, the sensor to applicator. So now with the help of this, so application side is usually back of your upper arm, either this one or this one, whichever is comfortable. You have to see this. There's no pain. It just you'll feel like a mosquito bite, that's it.
It should stay in body for 15 days.
And you can do bath, swimming also, till 30 meters it is available. Only caution you have to exercise is that you should not rub like this. Why? Because there is a filament which stays in your body in the interstitial fluid that continuously record your glucose every minute. So it will be costing around 5,200 is the MRP. For railways, it will be a discounted price. And there is a two ways to measure the glucose. One is the phone. So all the iPhones by default will have NFC, like near field communication, and other phones also you can check the compatibility. If there is NFC, it doesn't require any reader. Otherwise, we will be giving the reader also, like with every 4 sensors, we are giving one reader. With the help of that reader, you can take the glucose reading as many times as possible. There is no limit. So first 1 hour after application, it will not work. Why? Because it has to adjust to the body temperature. Pause that n number of times. Whenever you feel you want to check the glucose, just scan with the phone or either with the reader. You will get instantaneous glucose live recording. Sir? No, now it will not work, sir. It's a warm-up period. Warm-up period for 1 hour, sir. After 1 hour, why? Because sensor has to adjust to the body temperature, sir. 130. He is using, sir. No, mine is Libre 1. Libre 2 don't is scanning. It automatically streams here. When you open the app, it report appears. When you just see it. But only thing you have to keep the Bluetooth on.
Yes, sir.
Keep Bluetooth on, that's important. So all these benefits are there. You get more information by looking at ACP. So that there is some smart patient with the self-diet adjustment, they can postpone the diabetes itself. And there are many cases where they will be able to increase the insulin doses. Because patient engagement is very crucial. The moment they see the glucose level, the subsequent meal they will reduce the portion or they will take the necessary measures.
So one more thing, I want to introduce, I want many other physicians, I want to generate a Libre account for the physician here. So that he or she can see the patients sitting in the clinic. When sitting anywhere in the world, she can monitor the sugar level like CC camera. It is what is happening, entire thing you can see from the ear only. If any volunteer just want to, we can create one Libre, takes 5 minutes.
LibreView account, and you can add as many patients as possible, sir. If patient wants scan in Delhi also, you'll be getting the result. Even if patients sitting in US, you can see the reports from you sitting in here.
Yeah.
Up आ जाइए madam, let's do it.
Maybe we don't have
Ma'am,
much
we are
of
running
time.
It's 5 minutes, ma'am.
No, we are running short of time. Sorry. Please, we can have it later.
We can have it later, yeah? So we'll, thank you, Awad.
So, thank you very much for giving this opportunity to demonstrate. Thank you.
So I would call upon the last speaker of the day, Dr. Radha Mahita, physician, Central Hospital, Alaguda. She'll be talking on sepsis care.
Good evening, everyone. I know it's the last session. Everyone is tired. I'll try to be crisp and make it crisp and short. So as the topic says, it's sepsis guidelines. So these guidelines are given by the joint initiative of European Society of Intensive Care Medicine and Society of Critical Medicine. Based on many studies done in multi-care centers, they have released a set of guidelines. The last guidelines were in 2021. Now I just mainly focus on the updated guidelines which are released in 2026. So the guidelines mainly intend to support the clinicians caring for patients, management of pre-hospital, hospital and post-hospital settings, incorporate principles of antimicrobial stewardship and diagnostic strategies. So the new thing that has been introduced in this guidelines is that definition of sepsis. They mainly designed the guidelines based on these definition, which is definitive sepsis, where they have a definitive diagnosis based on clinical examination, and an alternative diagnosis is very unlikely. Probable is where you have a high suspicion of sepsis. Possible sepsis is where moderate sepsis, but an alternative diagnosis to be considered based on history clinical examination. Next is an unlikely sepsis, where there is low very clinical suspicion of sepsis, and an alternative diagnosis is more likely based on the clinical examination. So what's the first thing is screening and early management. Basically, it gives on quality improvement strategies. Quality improvement strategies basically a systematic and ongoing effort to improve evidence-based care processes, such as time of antibiotic administration and the display of diagnosis early warning system. Such as actually in the guidelines they have mentioned that there must be an electronic monitor where you enter the patient details and it gives an alarm based on the patient's details entered like SRIS criteria, and it gives a red flag saying that the patient is most likely to have a diagnosis of sepsis. Then according to the SOPs, again these are based on the hospital guidelines and it varies from hospital to hospital. Implementation of improvement strategies and new usage of standard sepsis screening tools. So the tools we know in News2, Muse and SIRS. But previously, as we know, we still use QSOFA. But the new guideline says that QSOFA to be considered in the last, and the other four are considered more superior when compared to the QSOFA scoring. So sepsis huddle, basically it's a code sepsis, where again mentioned it's a multidisciplinary team huddle. It says involves physicians, pharmacists, head of nursing at bedside to discuss and expedite sepsis diagnosis and treatment. Basically, it aims at achieve timely interventions, and it triggered to me the SIRS criteria with suspected infection source when you suspect your clinical suspicion is high. Evaluation, initial management. The important thing is it's a bedside tool, and it's a team effort on the bedside to decide on patient management. So regarding the blood cultures, we all know it should be considered as early as possible before the administration of antimicrobial therapy. But again, this should not be delayed before administering an antibiotic. We already know that sepsis bundle care says administer antibiotic within 1 hour. That doesn't mean you delay the administration because blood cultures are not available. It's again a clinical scenario. Repeat cultures are recommended to confirm clearance of bacteremia, especially in fungal treatment, fungal sepsis, and in organisms with Staphylococcus aureus, Staphylococcus libdinus, and Candida species. Repeat blood cultures are recommended to confirm clearance. Again, single versus multiple trials, trials have been done. Previously, it says that 2 peripheral blood cultures are important to diagnose the culture sepsis. But recent studies have shown that in single versus multiple size, there is no difference in the treatment or the outcomes. Again, blood lactate levels, that is also in sepsis bundle care. It says measurement of lactates is important even in the 1 hour and the 3 hour sepsis bundles. Fluid resuscitations, treatment and resuscitation should begin immediately. Patient in septic shock, give 30 ml of kg of IV crystalloid fluids in the first 3 hours. And then frequent ongoing assessment should be made on patients' improvement in monitor patients, and to avoid over treatment or over resuscitation is fluids. Basically in obese patients, when you are doing per kg calculation, take an ideal body weight, because again obesity you give according to their weight, then again they'll go into over-resuscitation. Crystalloids are the first line of choice. Albumin not to be considered unless and until you have already given large crystalloids and have cirrhosis. Supplemental albumin should be avoided, especially in traumatic brain injury patients. There is no definitive evidence of starches or gelatin. Point of care on ultrasound, non-invasive cardiac monitoring and invasive cardiac monitoring can be employed to measure the fluid administration and the response. There is no definitive evidence of cardiac output monitoring according to the new guidelines, like as pulmonary artery pressure, where you measure the cardiac output monitoring. And anyway, again, it's a patient individualized decision to decide the further resuscitation of fluids after the initial fluid bolus resuscitation. The main thing that has come in the new guidelines is after the acute resuscitation phase. Again, it highlights the word after. That means when the acute resuscitation phase is ongoing high dose of vasopressors and ongoing volume expansion, do not consider the option of fluid removal. Once you see that the patient is out of the resuscitation phase, then you consider fluid removal. This mainly highlights the importance of over-resuscitation in patients where they have an adverse outcomes. First, initially start on diuretics. If you feel that diuretics are not enough, then you can consider ultrafiltration or extracorporeal fluid removal. Again, it depends on individual factors like cardiorespiratory function, the renal function of the patient, the amount of vasopressor dose, and the clinical course of the patient. What are the vasopressors of choice? To maintain the MAP around 65 millimeters of mercury. In an older patient, maintain it a lower MAP over 60 to 65. Ideally admitted to ICU within 6 hours when patient is in sepsis. IV crystalloids are the fluid bolus resuscitation of choice, and if hypotension persists, do not delay in considering starting vasopressors. Inotropic support, norepinephrine is the first line agent, followed by vasopressin and epinephrine. Telepressin has no role in management of septic shock, and with associated cardiac dysfunction, again norepinephrine is the first line, but if an associated cardiac dysfunction is there, consider adding dobutamine as a second line in addition to the norepinephrine. But always, as we know, we have to be careful about the tachyarrhythmias. So again, that is patient invasive approach. Invasive blood pressure monitoring is advised in patients who require high dose vasopressors. So basically, this is an outline. First, monitoring fluids, vasoactive agents of continuous of hypotension. Again, this highlights the importance of measurement of blood lactate levels to further decide on fluid resuscitation and to assess the patient in septic shock. Next, sepsis of septic shock with multidrug resistant pathogens. This is a high-risk infection and low-risk infection. High-risk infection, consider MDR antimicrobial therapy even though your cultures are not available. Low risk of infection, do not start with MDR antimicrobial therapy. Risk factors for MDR therapy include intra-abdominal and deep-sided infections, necrotizing soft tissue infections, CNS sepsis or empyema. Consider the administration of anaerobic coverage even in the initial antibiotic protocols. MDR infection, again MDR pathogens. Basically, these are caused by Acetobacter baumannii, extended ASBL producing gram-negative, carbapenem resistant, MRSA and vancomycin resistant enterococcus. So, if the patient has a prior history of colonization with the MDR pathogen, prolonged use of antibiotics, and prolonged hospitalization in hospital where there is high prevalence of MDR pathogen, consider the starting of MDR pathogen antibiotic protocol even empirically. Timing, shock is present, sepsis is again, as per the definition, if it's a definitive sepsis, administered within 1 hour of recognition. So here we see that if the shock is present, even though your diagnosis is definitive or possible, give antimicrobial therapy immediately. If the shock is absent, then you may consider giving it within 1 hour, but again depends if you're able to get your diagnosis of sepsis within the prescribed time. And again, rapid assessment of infection versus non-infection should be considered if shock is absent. Antifungal therapy, there is no role of empirical antifungal therapy. Do not consider fungal biomarkers to guide, if the patient is already started on antifungal therapy, fungal biomarkers should not be considered to guide the discontinuation of empirical antifungal therapy. Antifungal therapy to be started empirically in high-risk patients such as on immunosuppressions, prolonged use of antibiotics, hospitalization, and intra-abdominal source of infection. Infection, again procalcitonin alone is not enough. It's again procalcitonin plus clinical evaluation which will guide your treatment. Early source control within 6 hours, like example, if you have any cellulitis, necrotizing fasciitis, this should be ideally treated within 6 hours of diagnosis to have a better outcomes in patients. And when you have an alternative diagnosis, please discontinue the antimicrobial therapy. and continue de-escalation of antimicrobial therapy early. This is again a new recommendation in 2026, and consider shorter duration of therapy. Administration, no fungal biomarkers as discussed. Empirical, again risk factors have been explained. Prolonged, and the new guideline which says is compared to bolus administrations, infusion of antibiotics maintains a minimal inhibitory concentration blood levels throughout the day. So if you're giving any beta-lactams or anything, consider giving it infusion over 3 to 4 hours rather than bolus administrations. And again, shorter duration of therapy. Do not extend therapy unless and until patient doesn't have any improvement. Selective decontamination of the gut. This is basically administration of non-absorbable antimicrobial agents to the oropharynx and upper GI tract. Treating aerobic gram-negative bacteria. It doesn't affect the anaerobic bacteria in the gut. So again, it has an two sides of thoughts. Again, it may create antimicrobial resistance. So it should have an individualized approach. IV corticosteroids. Again, it has side effects like hyperglycemia, hypernatremia, and uncertain effect on neuromuscular weakness. So multiple trials have been done. The timing of the antibiotic, tapering of corticosteroids. Many studies have shown that tapering is usually not required. The timing of doses, if you feel the vasopressor amount is increasing in patients, you can give steroids immediately. And the dose required is 200 mg of hydrocot or equivalent doses. Studies have been done in these considerations. Ventilation, consider pulse oximetry, O2 saturation, and this new recommendation is hypoxic respiratory failure. Consider HFNAC at an early phase. Trial of awake proning, duration and frequency again will depend on individualized patients. With ARDS, low tidal volume strategies, and without ARDS, tidal volume of 6 to 8 ml per kg per ideal body weight. Plateau pressure to be maintained at 30 centimeters of water. And if patient is not responding on mechanical ventilator, it is the veno-venous ECMO should be considered. So, where to start? Start 72 hours initiation of enteral nutrition. Initiate insulin therapy of glucose of more than 180 mg per dl. Venous thromboembolism prophylaxis to be started. Pharmacological, more beneficial rather than only mechanical prophylaxis. So it should be started in all patients unless and until contraindicated. Choice is LMWH. So Procal, it shouldn't guide your treatment, sir. It's only an additional biomarker. If clinically suspected, even with Procal you're suspecting sepsis, you can start treatment, sir. It is not an individualized approach for diagnosis and treatment of sepsis.
What is the mortality rate of sepsis?
So I think around 6.
What is the best available center?
So 38% as per what says the guidelines, sir. So that's why you should start treatment early. Sir, you're not audible, sir. Sir, but according to the new guidelines, they says no vitamin C at all, sir. Thank you.
So if there are no questions, we'll conclude the scientific session at this stage and we'll go ahead with the...
So we have the listation of the speakers. I request Dr. Ragamahita to stay back and Dr. Narayanasamy sir, please come out of the stage, sir. I request the chairpersons to please illustrate the speakers. Dr. Ragamahita.
I hope it was worth it. Now, time for validatory function. We will begin first by giving away prizes for the best poster and best paper presented. It was done today morning. We will be starting first with prizes for best poster presentation. The third prize goes to Dr. L. Satvika, DNB Medicine, CH Lalagud. Fast. Sir, forgot. I invite PCMD ma'am and Sai sir first to please come on the dais to felicitate the winners. And Sushma Mate madam, please. Dr. Satvika, may please come on the dais. Go.
Congratulations.
So she is our DNB student, second year. Second prize goes to Dr. Shravan, DNB Medicine, CS Lalagoda. Dr. Shravan is our DNB Medicine student, second year Lalagoda. And the first prize in poster presentation goes to Dr. P.S. Nazreen from Southern Railway. Dr. Nazreen is senior DMO from Trichy. Now coming to paper presentations, the second prize in paper presentation goes to Dr. L. Satvika, DNB Medicine, CS Lalagoda. And the first prize in papers, best paper, deservedly goes to Dr. Nazneen, senior DMO Trichy. Huge congratulations to all winners. So with that, we conclude the prize distribution for the posters and paper. As the session is coming to an end, we would like to facilitate some of our doctors who have worked tirelessly behind the scenes and helped us enable to conduct this function and make it a grand success. In no way, in any particular order, I would like to invite following doctors to kindly come on to our dais and receive token of appreciation from Dr. Sai sir and Nirmala ma'am. Dr. Haq sir. Dr. Haq sir has been the backbone of the accommodation and transport committee and much more than that. We are indebted to him for organizing this. He was taking care of the delegates behind the scenes. His work is not yet over. I think it will continue to be spill over till tomorrow, day after tomorrow morning also. Next is Dr. Suvan Jyoti ma'am. Ma'am has been working behind the scenes and making sure that all this prize ceremony, everything goes perfectly. She is managing all the micro aspects in detail. Then I would like to invite Dr. Shanmupriya madam. Ma'am has been busy anchoring and holding on the stage both morning, evening and again today.
Then Dr. Chetan Pandurang sir. He is the man who's been handling the entire IT system, the stage. He's the IT man of our zone. He's the one actually who was implementing the HMIS. Everybody knows his skills. And of course, he's a radiologist of repute. Then Dr. Vamsi Krishna. He's the one who has organized the TSMC registration for all of us. And thanks to him, everybody will be getting 4 credit hours from TSMC. Dr. Suji, she has been working, I think, from the beginning actually, coordinating with all the delegates. Her phone must be constantly buzzing with requests, messages. And finally, from our own Department of Medicine, Dr. Kavya. She has been working behind the stage and also looking after the hospital in these past 2 days while we were here.
Most important.
Yes. Padma? Padma Priya madam has left for residence, ma'am. She was in charge of all the food catering and hospitality and all. She was handling over. Will be. And Dr. Anil Kumar. I forgot, sorry. Ma'am, Dr. Anil has been working 24/7. He is a DNB surgery resident also and also a DMO with us. And he has been working and receiving all the delegates, making sure that everybody is comfortable in the state. Now, I would like to call upon Mrs. Shivakumari to receive token of appreciation. She's our ANO and she's been working behind the scenes to make this all happen. Yes. Moni sister. ANO. Mrs. Moni Thomas, our ANO. Mrs. Jyoti ANO. Mrs. Suguna, CNS and in charge of cath lab nursing. Mrs. Kavita, CNS and in charge of ICCU nursing. And last but not the least, a special thanks to Mr. Sharath and his team for organizing this entire event. With this, we conclude the validatory function. I call upon Dr. Jyotsna to give vote of thanks.
Respected dignitaries, faculty, guests, delegates, and ladies and gentlemen, a very good evening to all. As we come to the end of the APRCON 2026, it's my honor to propose the vote of thanks on behalf of organizing team. First, we thank our Honorable DGRHS for his constant support and encouragement. Sir, your blessings gave us strength to take every step forward. We deeply thank our PCMD Madam, MD Sir, Krishnaveni Madam for your vision, guidance and personal involvement at every stage made this conference possible. You have been guiding us light throughout. Our sincere thanks to our respected DG Irifam ma'am for kindly hosting this event at this beautiful venue. We also thank APRCON governing body for trusting us with the responsibility of organizing this conference. Your confidence in us has meant a great deal. A conference like this is a result of many hands working together. Let me thank each team with all my heart. To the organizing committee, thank you for taking care of every small detail with patience and dedication. A great event is always the work of team that share one goal. To the finance committee, thank you for handling everything carefully with full honesty. Your planning kept the confidence in a strong footing. To the transport committee, thank you for making sure every delegate travels safely and comfortably from our arrival to departure. To the reception committee, thank you for welcoming every guest with a warm smile. A kind welcome leaves a memory that lasts long after the event ends. To the cultural committee, thank you for bringing colors, music, joy to our gathering. You reminded us medicine and human heart goes hand in hand. To audiovisual committee, thank you for making every session run smoothly. The best technical work is the kind that no one notices, and you did that exactly. We sincerely thank our senior mentors and teachers whose advice and encouragement has shaped this conference and shaped each one of us as not only the doctors, but the best organizers. A very special word of thanks to our support staff, CHIs, ANOs, and Sharath and his dedicated team, the real unsung heroes of APRCON 2026. The long hours of quiet, careful work you put in behind the scenes made everything run smoothly. We always remember your effort with deep gratitude. To our speakers and chairpersons, thank you for sharing your knowledge so generously and for raising the standard of this conference. To our delegates, thank you for your active participation and your questions and your warm spirit. You are the reason of APRCON 2026 have been a success. We also thank our sponsors, trade partners for their valued support and our faculty, volunteers and our support staff, whose quiet work, hard work powered every session, every small meal and every moment. Finally, to each and every one of you present here today, thank you for your presence, your cooperation and your warmth. May this knowledge, friendship and memories from the APRCON 2026 stay with us for many more years to come. With this, I formally bring APRCON 2026 to a close. Thank you and Jai Hind.
Anyone wants to speak? Feedback form will be shared in the group. So kindly give your feedback, what you appreciated and what else we need to improve. Thank you.
We are birds with wings and no feathers, and a sad and hope. With all the memories and the small moments started appearing in the bird, each memory became a feather that gives strength to the bird. Every smile, every friendship shared learning, and finally wings became complete. The time the bird could fly, together memories became strength, strength became wings, and this is what 2026 APRCON 2026. Thank you.
Request everyone to please stay back. We'll just play a national anthem.
Jaya